nephrologists, nurses, trainees, we have dietitian coordinators, and some medical students as well. So I'd like to welcome you all and online participants as well. We will be live streaming this whole symposium, and we'll also be recording lectures which will be uploaded on our website 48 hours after the symposium closes. I'm delighted that after many years of planning, we have finally managed to get Professor Joseph Lim to come from Seattle to London to be a keynote speaker. Professor of Pediatrics at the University of Washington and Chief of Division of Nephrology at Seattle Children's Hospital. He also is Dr. Robert Hickman Endowed Chair in Pediatric Nephrology and past President of the American Society for Pediatric Nephrology. Probably the most well-known to all of you in the room as the editor-in-chief for pediatric nephrology. So maybe an excellent opportunity for networking. We are very grateful that you came all the way from Seattle to join us for these 2 days. The Young Transplant Professional Award was established this year. It's sponsored by educational grants from our sponsors. There were 3 this year. Dr. Ana Petrovic, who's a pediatric nephrology trainee from Serbia. Dr. Eftihia Todi, who's a just qualified pediatric nephrologist and started her work in Cyprus, and Dr. Panoraya Paraskeva, who's a transplant surgeon from Greece. Nico certainly would not allow me to give awards to all the nephrologists, so we are grateful that Dr. Paraskeva is here. We sponsored their accommodation and travel to this symposium, as well as 3 days observership at Great Ormond Street Hospital. So well done. The 3 of you who have won this award, you will get your certificate at the end of the conference by Nikos. This meeting would not be possible without the sponsors, and I would like to use this opportunity to thank Sandoz, who has been supporting this meeting since 2017, and also PharmaPal, who is our new sponsor and supporting us from this year. For those of you who have signed up for dinner, this will be at 6 o'clock this afternoon, about 5 minutes walk from here, and I'm sure that Dr. Papadakis will be helping us and guide us the way. The reason why I'm saying that is that there is a little bit more for some of us or some of you to this symposium than science. 4 years ago, Sanya, who is in the audience, and George met at this meeting, and I have asked George to escort the delegates and help them get to the restaurant. However, he was only interested in escorting one particular delegate and actually got cross to me. This is little Nikos, who has come along the way, and I've just learned over this weekend, and there's another boy on the way. So I hope that you will enjoy the conference, science, and whatever comes in between. And thank you all very much for registering. So we will start now with our first speaker. So I'm delighted to invite Maria Skanes, who is a dear colleague of mine. Maria is a senior renal nurse. She's a transplant coordinator at Great Ormond Street Hospital for Children, and pretty much all the work in transplantation that we do is fantastically coordinated, organized, and led by Jan and Maria. So Maria, thank you very much coming to talk about the transplant workup for children with infant onset end-stage kidney disease.
Good morning, everyone, and thank you, Yelena and Nikos, for asking me to speak this morning. So as Yelena introduced me, I'm Maria, and I work with my colleague Jenny Tanton at Great Ormond Street, and we're the transplant coordinators there. So as we all know, preemptive living donor renal transplantation improves the morbidity and mortality of children with end-stage kidney disease and is widely accepted as the gold standard for renal replacement therapy. So just to talk a little bit about the background at Great Ormond Street, we did our first living donor transplant in 1990, and we approximately transplant between 20 and 35 children per year. We have about 100 recipients on our books, so to speak, and about approximately 80 donors come forward to talk about or sort of think about donation. We look after children within the NHS, children from other centres with complex needs, children from Europe, and children from in our international private patient programme. Children should be approximately 10 kilograms for transplant, and about 15 months of age is the earliest that we can transplant at. Whoops, that's jumped, sorry. So just looking at our transplant numbers since 2009, as you can see, we predominantly do living donor transplants, and partly because we seem to be getting less offers on the deceased donor list, and also, whoops, that's jumping, because we very much promote living donation, as I'm sure everyone else does. You can see to 2020 to 2021 was our COVID year when we had to close our program for some time, and then 2021 to 2022 we worked very hard and caught up, which was quite a tough year. So just to look at the workup for the recipient. So of course you want to know their blood group, the HLA typing, which is done here at Guy's Hospital, and the HLA antibodies. For living donors, we'll do an initial cross-match with the donor if the recipient has HLA antibodies, has had a previous transplant, or if CTL here advise us to do so. And we'll do ABOI titers if we think we're going to have to do a blood group incompatible transplant. All children have to be fully vaccinated prior to transplantation, so not only their routine childhood vaccines, but we also ask for varicella if they're measles negative. We don't insist on COVID, but we do actively encourage it. And we don't ask for a BCG now. Some children have a BCG if they're born in an area where they need a BCG, but we don't ask for that. I'm not talking quickly enough for my slides, sorry. We check everyone's virology. If they're varicella or measles negative, we'll ask for a booster in those vaccines, and all children have to have Hep B vaccine. Handily, now with the new vaccine program, all children have Hep B with their routine baby vaccines, which helps us enormously. But we have to play catch up with the older children who haven't received those Hep Bs. We'll do all the children's coagulation, a basic screen initially. Then if there's a disordered result or there's a family history of bleeding or clotting disorders, we'll do a full thrombotic screen and ask for haematology's opinion if we need it to think about anticoagulation post-transplant. We'll look at the liver function and we'll do a fasting glucose or HbA1c if we deem them to be high risk. Looking at their imaging, they all have an abdominal vessel ultrasound to ensure patency of the vessels, and latterly we're now looking at the size of the vessels to make sure our surgical colleagues are happy. If the children are quite small, we used to say under 20 kilos, but we don't insist now. The children will have an MRV. If they've had previous femoral lines or if we see any occlusion in the ultrasound, then we'll proceed to an MRV as well. Sometimes we do a neck ultrasound if they've had lots of previous access. They all have an annual echo, and they all have a bladder ultrasound to ensure their bladder is safe and empties to completion. And will the bladder cope with the increased urine output post-transplant? And then just to think about, is the patient anephric or do they need nephrectomies prior to their transplant? So urology, I won't say too much because I'm sure Mr. Mushtaq can say far more than me. So we just want to know their bladders are safe for transplant. And a lot of our children come to us through urologies. They've already had urology referrals and urology plans. So they might have a bladder fill assessment or formal video urodynamics. We ask for our urologists to be very much involved in the MDM process. And we sign off with a urology plan for all our urology patients. We ask that all children are regularly checked by dentists, which is getting more difficult with the NHS dental provision in the UK at the moment. Some of them have an anaesthetic review, but they're all reviewed at our MDM anyway by the anaesthetist prior to transplant. Do other specialities need to be involved? For example, liver, cardiac, metabolic? If they do, we sign off that they're happy that we're proceeding to transplant. If it's a small child or a complex child, do they need a PICU or CICU bed? For living donation, this needs to be requested in advance. Some children need an extended and all-day theatre list, more the small children, the complex children. So we have to negotiate with our theatres as if we can have an extended list. All patients have to go through the MDM planning meeting, and everyone has to be signed off by the consultant. We also ask for help from our psychological colleagues. So they all have a psychosocial assessment, so all families pre-transplant should have this. And they look at the practical aspects. For example, if it's a living donor transplant, one parent will not be on site or around to look after siblings. And also thinking about parental responsibility. If you've got a parent who's donating and the other parent isn't the biological parent, do they have the right to consent? We think about care of siblings, loss of earnings, and the impact on the whole family that transplantation has. We discuss the follow-up, which is quite rigorous in the beginning, and are the family on board with this, and can they cope with this? And we also very much involve our play specialists with our preparation. So nearer to the time of transplant for the living donors, they'll meet with the consultant transplant nephrology clinic, which we have a monthly clinic there. And they also meet with the transplant surgeon. And more often than not, they'll meet with the transplant surgeon more than once. The nurse specialists, we do preparation discussions, quite rigorous and more than once, just to make sure the families understand the preparation involved with transplant, and what the post-up follow-up is and what we expect of them, what the meds are, the do's and don'ts post-transplant, and the plan for return to school, etc. And as I said, these discussions are very much ongoing. They're not a one-off conversation. Once we're happy to proceed to transplant and our colleagues at Guy's are happy, we'll confirm the date with the lead surgeon, with the ward and the family. We'll book PICU, send our email out to the whole team, book the hotel for the children post-transplant, and book the final flow cross match. And then we offer the families to visit the patient hotel, the ward, ITU, if they're not familiar with those areas. More often than not, with our preemptive transplants, many of the children haven't really been onto the ward before, so it's good for them to see that. For living donors, we see the children the week prior to transplant, where they meet the surgeon again and surgical consent is signed. We'll do a final flow cross match with the recipient and the donor, a baseline chest x-ray, and then we'll finalise the admission plans and any needs the family have. Consultant will sign off the protocol, and then everything goes up to the ward, and hopefully the patient is ready to go. With COVID, we now ask the families to shield for a week prior to transplant, just to reduce the risk of them catching any coughs, colds, flus, or COVID, etc. So we don't have to cancel the transplant. For children who are going to be activated on call, we'll send HLA antibodies, we ensure their protocol's up to date, signed off. We'll do on-call CNS talks, very similar to our living donor talks, and then we'll register the children with NHSBT. Once they're activated, we confirm this with the family, we confirm it with the ward team, and while they're on call, they have annual surgical reviews, annual echoes, and 3 monthly HLA antibodies sent, so that we've got up-to-date results on them. As I said, about 80 potential donors are presented to us throughout the year. So they normally meet myself or Jenny first, and we'll just discuss living donation with them, and just see, are they diabetic, are they hypertensive, what's their BMI. We'll give them a registration form. Once they've returned that and we've registered them, we'll do blood groups and HLA typing. Very particularly have to explain the HLA typing test, because we've been caught out over the years where dad isn't dad, and that's been quite a tricky situation. So we're actually in the process of developing a consent form with our trust solicitors before we take this test. We give them the information, transplant information they need, and once we get the results back, we refer them on to the lovely Anita at Guy's. We have lots of families asking about donors from overseas, so we'll see if we can get a blood group from them, see if we can get HLA typing. It can be very difficult to get HLA typing from certain countries, so sometimes they're posted over to us, they get lost in the post. It'd be quite a lengthy process. But if we get the results back and they're good, then again we'll refer them over to Anita, and they'll start their workup from overseas. So with the donors, once we refer them over to Guy's, they must make contact themselves with the Guy's team, and we very much explain that to them. And then from then on, all the donor workup is done at Guy's. So we just do the recipient workup, and the Guy's team do the donor workup with Anita. We work very closely with Anita. We hand over weekly to her and very much keep both teams updated with where we are with the recipients and the donors. The donors have a thorough medical and psychological assessment, starts with an initial discussion, medical tests, and then they may need to proceed to biopsy, cystoscopy, etc., which delays the workup for them. Once they're signed off at Guy's, they have a final independent assessment appointment, and where both donor and recipient and a representative of the recipient have to attend. More often than not, this is now done on Zoom as opposed to face-to-face. We also get quite a few complex out-of-centre overseas recipients, often referred to us from Scotland, Wales, Ireland, Europe, the Middle East. And some of these complexities include surgical challenges, comorbidities, complex urological challenges, and MMA. And in fact, Jelena has been very active in setting up an MMA collaborative network incorporating Great Ormond Street Kings, Guy's, and Evelina. And each case brings its own challenges, both surgically, medically, and I think more often than not geographically, because you've got another team involved and it's quite hard to get everything organised. So looking at the way forward and what can we do to expand living donation and obtain more living donors. So we nearly always have someone in the National Living Donor Kidney Sharing Scheme, and that's a quarterly national run managed by NHSPT, and it includes paired and pooled donation, and it's for recipient pairs who are HLA-I or ABO-I. So 2 pairs in the scheme is paired donation, more than 2 pairs is pooled donation, and it's all worked out on an algorithm so they can match and maximise the pairs. I do find that some families of donors are very reluctant to consider this. They're happy to give a kidney to their child, but the thought of giving a kidney to someone else, they're not so happy with, even though their recipient may receive a living donor kidney. But we refer them over to Anita, have a chat, talk about the scheme, and if they want to go forward, they can. So I think Jen and I have really been thinking about increasing education around this scheme because it is really fantastic. We put limits on our recipients, so age, mismatch, and this can all reduce the chances of the children being matched. But we have had quite a few successful matches in this scheme. We also have altruistic donors who come forward. So that's an anonymous, non-directed altruistic donor to a recipient on the waiting list. And they can be registered either into the National Living Donor Scheme to start an altruistic chain, or they can donate directly to somebody on the list. So sometimes we get phone calls from people saying, I want to give a kidney to someone. So we'll either direct them to the NHSPT website with a really good section there on how to register, or we'll speak to our lovely colleague at Guy's. We can also do blood group incompatible transplant, where we transplant across the blood group barrier. We don't initially start with this. We'll always advise 3 runs in the sharing scheme first to see if we can get a compatible donor. And we'll consider an ABO-I transplant if their titers are low enough. If they are, then we need to plan an individualised plan regarding immunosuppression and either plasma exchange, DFPP or IA, depending on their titers. We can also consider HLA-I transplant. So transplantation when recipient antibodies are present against donor HLA. So again, we'll take advice, particularly from our clinical scientists at the lab at Guy's, nephrologists and our adult colleagues regarding a tailor-made immunosuppression protocol, and very much discuss with the families, with this and with ABO-I, risk versus benefit and the risk of increased immunosuppression with these transplants. So historically, we always accept a 111 mismatch for living donor, and initially a 110 for someone who's placed on the list for deceased donation. And then once a child had been on call for a year, we reduce their criteria to a star 1 equals 3. So this means we'll accept a 1 or 2 antigen mismatch on the A or the B, but only 1 mismatch on the DR. Will still equate to a 3 antigen match. However, we have changed our practice, and I believe Evelina have as well, in that if a child has match points of 5 or over, we will now list them initially for a star 1 equals 3. The waiting list now seems to be about an average of 2 years. The children are waiting a very long time, ending up on dialysis. Sometimes with living donation, we'll accept a 2 antigen match from a very fit, healthy donor after much discussion with the team and with the family. Social media campaigns are becoming increasingly more popular, and the HTA have said it is not illegal to advertise for an organ as long as there is no offer of a reward, payment, or material advantage. And this can incorporate directed altruistic donation. And a framework is being looked at nationally, because I think everyone approaches it slightly differently, and we have asked for a national framework for guidance. And it very much requires collaborative work with your donor and recipient team, because you can have numerous people phoning up, and it can be a lot of work. So just to say, we've started doing a theatre open day, which we try to run 2 or 3 times a year, where we invite the children to theatres on a Saturday morning. The theatres are opened up. We do it in with the cardiac team, and this is a really good day. They can dress up, they can scrub, they can pretend to suture. We have the mannequins where they can intubate, ultrasound, etc. And they find this a really, really worthwhile day. So improvements, we're always trying to improve what we do, make it better. So we continuously audit our practice. Any child who dies, who has an unexpected outcome, will have an M&M. We constantly look at our preemptive rates. Can we improve them? Were there any patients on dialysis who could have received a preemptive transplant? If so, why didn't they? Are there any delays or barriers to listing a child on call? And as I said, we're drawing up a consent for HLA typing. And just lastly, I was quite excited by this. There's a JCVI, the Joint Committee on Vaccination Immunisation, are recommending a universal varicella vaccination programme to be introduced as part of the routine childhood schedule. And it should be a 2-dose programme offering vaccinations at 12 and 18 months using the combined MMR, so it would be the MMRV. And I know Kate and myself would be delighted if this happens, because we have to do a lot of work with catch-up with vaccinations and trying to persuade GPs that this is their job, not ours. So that's a bit of a whistle-stop tour to preparing a child for transplant. Hope I haven't spoken too quickly. Thank you.
Thank you, Maria, for a fantastic.
Something.
Any questions?
Do we have any questions?
For Maria from the audience?
Anybody? It won't bite, this microphone.
That would be nice.
So, well done to start with. I suspect that the people who call you and say, I want to donate a kidney, most of the time they say, I would like to donate a kidney to a child. Is that something that can be directed to an HSBT, or it just goes in the general pool?
You can't altruistically donate to a pool. So you can either altruistic donate to an individual, so someone you see on a Facebook campaign, on the news, etc., or you have to altruistically donate to anyone, because therefore someone could phone up and say, I want to donate to a child, I want to donate to a female under 16. So that's right, isn't it, Anita? Yeah. So it's either an individual or anyone.
Thank you. Anyone else? No? Okay, thank you very much, Maria. It was an excellent talk. I'm delighted to introduce a colleague, Professor Imran Mushtaq, who is a pediatric urologist at Great Ormond Street Hospital and has experience and expertise treating children with hostile bladders. Today, he will be giving a lecture on how to manage transplantation in a child with hostile bladder. So Imran, thank you very much for joining us. I am cautious that you have theaters running.
So, so thanks, Yelena. Thanks, Nikos. And thanks, Muttley, for all the organisation. And thank you for getting me to come back here. You'll see that my title is slightly different to what's on your programme, because actually what I'm talking about is how to manage the hostile bladder in transplantation rather than how to do transplantation in hostile bladder. So it's sort of slightly a different emphasis. It's a bit of an interactive talk. Okay, so I'm expecting a bit of audience participation. And I'm not really an intellectual type of person because as a surgeon, I'm very sort of practical. So I see problems and I see how to fix the problems. And I'm quite good at doing that, but I'm not very good at giving factual, intellectual sort of talk. So hopefully you'll enjoy it and you'll actually probably learn more than from one of Steve's talks. So I guess the first thing is what do you guys understand to be a hostile bladder? I'm sure you've all heard the term hostile bladder. Well, actually, what does a hostile bladder mean to you? I know what it means to me. Anyone want to make a suggestion? What do they understand as, because I think most of you are nephrologists, so you will have heard what hostile bladder is. What is a hostile bladder? Okay, I'll start pointing at people soon. Yes, what do you think? What's your... Exactly, yeah, that's right. Yeah.
Or it's too small, it doesn't hold what it's supposed to hold.
Yeah, I mean that could be one definition. You know, I guess the thing about hostile bladders is that there will be in the textbooks and in all these sort of urological associations, there will be definitions of what is a hostile bladder. But actually, in the context of a child who's getting a transplant, it essentially to me means a bladder which potentially could damage the new receiving kidney. That's to me what a hostile bladder means. And a hostile bladder can be due to many different things. Now, this is just a picture of what most of us would understand to be a hostile bladder. And you can see on the one side, it's sort of a normal bladder. On the other side, on the right side, it's sort of thick-walled, it's inflamed, it's just not healthy. So most of us would understand a hostile bladder to be small in capacity, thick-walled, maybe trabeculated or irregular, and probably what we would know is called about high pressure, because that's what really I think can damage a recipient kidney, is if the bladder is storing urine under very, very high pressures. And again, people talk about certain numbers like 40 centimeters of water, and anything above 40 centimeters of water can then cause high pressure damage to a transplanted kidney. But you mentioned about infections, and infections is another thing. So you may have not a thick-walled, small capacity bladder. You may have a very, very large bladder which doesn't actually empty properly. Therefore, the child gets infections. And as soon as you transplant that patient, the risk of infection goes up because they get immunosuppressed. So that is also a hostile bladder. So I think in the context of what we all do together in terms of transplantation, hostility of the bladder can mean other things simply than high pressure, low capacity, etc. It can mean other things, as you say. So it's just important to understand, you know, the context of what we're talking about. Now, what I'm going to do is I'm going to present you a couple of cases, and these are real cases, just to really see if you had your coffee this morning and see really, you know, what would you do here? Okay, so this is a 9-year-old girl, recurrent urinary infections, bilateral reflux, and bilaterally scarred kidneys. She's already on CIC, which is not uncommon in children with reflux. They often have bladders that don't empty properly. She's got a good urine output, but she's still getting recurrent infections. And every time she gets an infection, her creatinine shoots up and then takes a couple of weeks and comes down again. She's got a significantly impaired GFR and hypertension. So this is not an uncommon scenario, which I think you'll all have recognized. She's had a urodynamic study done, which shows she's got a trabeculated, thick-walled, high-pressure bladder, right? So she is now nearing transplant, okay? So she needs some sort of evaluation to see what we're going to do. Are we going to put her new kidney into this bladder, into this system? No. And we're not going to, because she's still getting urinary infections. Once she's transplanted, the infection rate will go up with immunosuppression. She's got a very poorly compliant, thick-walled, bad bladder. Okay, so what are we going to do for this patient in order for her to have a safe system to receive the transplant? She's already on CIC. Huh? Augment her. Yeah, I think she does need an augment. Definitely needs an augmentation. But when? Before transplant. Yeah. So this girl is very straightforward. Okay, we'll start off with the easy ones. Straightforward. She's got an abnormal bladder. She's on CIC. She needs her bladder to be made safe. The only way to make it safe is to augment her. She's 9 years old. She could probably learn to do urethral CIC, or she could have a mitrophanol, and she can catheterize from above if she doesn't want to catheterize from below. But she's already on CIC, so she may continue to do CIC from below. But she needs a planned augmentation. But the key thing here, which I've outlined, is that she might need hemo backup, because we know that children who've got really severely deranged, she's not quite at she's not needing PD, but the burden of the operation, which is a very significant burden to the native kidneys, can push her into end stage, and she might need hemo backup. So she's the sort of person that we would plan very carefully. We wouldn't just, as urologists, put her on a list, do her transplant, and see what happens. We would discuss her case with our transplant colleagues, with our nephrology colleagues, and arrange a certain time when we know that there will be the facility to give her hemo if we need to, because hemo slots are not always available. So it'd be a very carefully planned augmentation with the option to go to hemo should she tip over into end stage. So she's very straightforward, but you can see the complexities of her. So here's another one. This is a 10-year-old boy who's got valves. Again, one of the commonest reasons for transplantation. He's got end stage and he's on PD. So he's been on PD for 4 years, this boy. He's polyuric, which again, we know commonly boys with valves are polyuric. Even if they're being dialyzed with PD or even with hemo, they still remain polyuric. He's got a good capacity bladder, but his compliance isn't good. So the capacity is good, but it's storing urine under high pressures. And he's also ready for transplantation. So what sort, because we discuss these cases in our MDM, and sometimes it's obvious what to do, and sometimes it's actually not that obvious, because when you do something, it can have consequences. So what's the plan for this boy? Anybody? What? Start catheterizing per urethra. You could do. 10-year-old boys don't like to catheterize. Okay, so you could start catheterizing. It's a good point. Okay, he's got a good capacity bladder, but he's got poor compliance. So even if he's emptying regularly with catheterizing, he's still got a hostile bladder in terms of compliance. So I'm not sure you would put his new kidney into this bladder because of the poor compliance. He's sort of similar to the previous girl, so he probably needs augmentation. Yeah. So I think augmentation. But what's the twist here? He's on PD. Oh, Maria, you know everything. So he's on PD. So how can you do a major laparotomy and a bladder augmentation on a patient who's on PD? You can't, because you can't PD them straight afterwards. So correct. So he needs to switch to hemodialysis first, because once you do your laparotomy, you do your bladder augment, you can't PD him. So he needs to first of all get established on hemodialysis. Then he needs to have his bladder augmentation, and then 3 to 6 months after his augmentation, he receives his transplant. So you can see it's slightly complicated. And again, if as urologists we just transplant this boy, augment this boy, it just doesn't work out. So the key thing again is making a very detailed plan with all the team about what to do at what stage. And the good thing here is he's already polyuric, and even if you switch him to hemo, I still think he'll still have a good urine output. But why is that relevant? Why is it important to have a good urine output if you're doing a bladder augmentation? Cycling the bladder, yeah. So when you do a bladder augmentation, you create a new bladder, but it's not doesn't instantly go from like 100 mils to 400 mils. You have to have urine flow through that bladder. You need to have filling and emptying cycles. So the newly made bladder will only have a capacity of 100, maybe 150. You need to have a good urine flow in order that bladder to stretch up and reach its capacity, which it will do after about a month or so. So urine flow is imperative for the success of bladder augmentation. If you've got an anuric patient or you've got an oliguric patient, it will not work. Your augmentation may be successful, but your newly made bladder will not reach the capacities that it needs to reach of 300-400 mils. Okay, so you really have to be careful about urine output. Another one. This is a 6-year-old prune belly, rare condition, but we see them. But as we know, a lot of them can have severe end-stage renal disease, like this patient does. He's got severe bilateral reflux. You can see his cystogram. He's got massive reflux into both systems, and he's getting recurrent infections. He's got a poor GFR, and his urodynamics show a large capacity, poorly contractile bladder with big residuals. So, slightly different, but again, he needs a plan to be made whether this bladder is safe or this system is safe or not safe. Okay, so he's slightly different. So what could you do for this boy? He's got recurrent infections, he's got high-grade reflux, he's overall got a large capacity, and he's 6, so he needs transplanting soon, but because he's got recurrent infections, his system isn't safe, and he also doesn't empty fully, and that's probably why he gets recurrent infections. So what can we do for this boy to make that him safe to receive a transplant? So the main problem he's got is he's not emptying his bladder effectively. So you could do CIC, yeah? You can do CIC, he's got a urethra. The problem with prune bellies is they often have areas of atresia or hypoplasia in the urethra. So while we think it would be simple to do CIC in this boy, actually practically in the prune bellies, it's not so easy because, as I say, they often have abnormalities or areas of narrowing in the urethra. So it's not so simple for him. So probably the best thing for him is a Mitrofanov. And he's 6, so doing urethral CIC may be technically difficult. It may be psychologically difficult for him. And remember that these patients have a very lax abdominal wall. And what we often do is we do a plication. So we tighten the abdominal wall. It's called an Ehrlich's. You tighten the abdominal wall, and at the same time, you make a Mitrofanov as well. So you do one operation, you do the plication, you do the Mitrofanov. So then that way, they've got a tighter abdominal wall. It helps with their respiratory function, and then you've got a system to intermittently empty him. So he's relatively straightforward, and he should be fine. He's got poor renal function, hopefully enough that just doing because doing just a Mitrofanov is not as big an insult to the body as doing an augmentation. So hopefully his renal reserve will be adequate. He won't go into end stage and stuff, so he should be fine. So this is just a list of things that one has to think about when you are thinking about making a system safe for the patient to get his transplant. You've got to think about the patient age, and what you might be able to do in a 10-year-old may not be so easy to do in a 6-month-old or a 1-year-old or a 2-year-old. So age is so important. Their underlying urological, nephrological condition, how bad is their renal dysfunction? Are they got good renal reserve still and they'll handle a big bladder augmentation, or actually have they got really minimum reserve and you're worried that the kidneys won't actually handle the surgery, that they may need hemodialysis post surgery? Urine output, I've already said that's like a big thing. You've got to have good urine output if you're going to do an augmentation. If you don't have good urine output, you're stuck. And and I know, you probably work in different centers, and people talk about when you've got an oliguric or an anuric patient, why not cycle the bladder? So people talk about putting a catheter in, filling the bladder artificially several times a day. It's complete rubbish. It doesn't work. I've never seen it work, but I know people talk about cycling of a bladder, but I don't think that really can work effectively. So if you do an augmentation, you do it, and then for weeks afterwards, you artificially fill the bladder to get it to stretch. I don't buy that. You've got to have good urine output. If they've got a history of UTIs, what is their reflux status? Are they already on PD? Are they already on hemodialysis? And again, I think family and social issues are very important. And I'll show you some cases where I think that is particularly relevant. So this is just a list of things that one has to consider when you're thinking about what to do about the bladder and the urinary tract. So it's quite a long list. There's a lot of things to think about there. So I've put the list in the corner just as a reminder so you can think about these things. This is another patient, 11-year-old, Vactel syndrome, so he's got multiple congenital anomalies. He's got a solitary left kidney that's severely hydronephrotic. So it's a real patient. This is a real patient who came from the Royal London to us. So he's got Vactel, he's 11, he's got severe left hydro, he's always had severe left hydroureteronephrosis. He's got a small capacity, poorly compliant bladder. He does not have reflux. There's the trick question. Doesn't have reflux. And he's got quite advanced renal dysfunction. He's fecally incontinent, poorly compliant, lots and lots of social issues. So, 11-year-old boy, bad hydroureteronephrosis, bad kidney disease, incontinent. So what would we do for this boy? See, it's complicated, isn't it? Everyone's like baffled. What the hell to do? So age, if you look at the list, age, he's 11, so he's old enough to do most things. He's got a severely dilated left kidney, solitary kidney. It's severely dilated, there's no reflux. So why is it severely dilated? Because it's probably obstructed, and the local team have never actually thought that this child could have a VUJ obstruction in that solitary kidney, because there's no reflux. There's no doubt he's got a shitty bladder. The bladder's no good, but maybe he's got an obstructive component, which may be reversible if you get rid of the obstruction, right? So for this boy, this is what we did. We actually brought out that left ureter as an endometriostomy. You can't reimplant it because you're just reimplanting it into an abnormal system. His social issues and his other issues, fecal incontinence, etc., he's not really ready as a patient, as a family, to have a bladder augmentation. They're not ready for it. So the priority here is to see what can we do to improve his renal function. And if you bring out an endometriostomy, you get complete drainage of that solitary kidney, and you may see some improvement in his renal dysfunction. So this is what we did for him, because he's not ready, the family's not ready for any kind of bladder augmentation type surgery, because that will require them then to be doing intermittent catheterization of the bladder every sort of 3 to 4 hours. There's already lots of social issues, there are already compliance issues. So you do not do major bladder reconstruction surgery in a non-compliant patient. You don't do it. And you might say, well, why are you making him even more incontinent? Well, he's already incontinent in the feces, he's already in nappies. So when you create him a ureterostomy, that urine will just flow into the nappy. So you're not making him any worse, but you might make his renal function better. Okay. So the devil's always in the detail, and this is a real patient that came to us, and this is actually what we did. And the local team had completely not thought about this as an option. Hopefully nobody's here from Royal London, otherwise I'm really in trouble. That's a good point. You could have done a nephrostomy first, but then okay, that's a good point. Let's say you did a nephrostomy and your renal function improved, then you'd say, good, let's do an endometriostomy. If you did a nephrostomy and your renal function didn't improve, then your next step would be do nothing. You could have done nothing. But then the problem then is that at that particular time point, your renal function didn't improve. But if you create an endometriostomy, because we're not going to be doing any augmentation surgery for probably many years on this boy, because he's not ready, family's not ready. If you create a ureterostomy, you might slow down the decline. So you may not see an improvement, but you'll know more about this than me. But by creating an endometriostomy, getting free drainage, maybe the decline in renal dysfunction may slow down. Maybe it'll take him 4 years to get to end stage rather than 1 year or 2 years. I don't know. I mean, you're more experts on that. What do you think, Elena? I don't know. Nikos? It's a really good point, because you could have done a nephrostomy and tested to see if drainage helps or not. It's a good point. But obviously we did what we think was beneficial to him, and he's now several years down the line. He's still got his endometriostomy and he's fine, and he's definitely not had transplant. I think it did.
I guess the thing is, it's not an acute issue, is it? That's the reason why, as you said, it's more about what's going to happen in a year or so. So that's normally why we're going to do it.
Yeah, because we were thinking about something that he would keep for many years. And your point's good. Even if renal function didn't improve, it may have stabilized it and prevented it going off more rapidly. Because with an obstructed system, he still is at risk of getting infections, and a bad infection could, as you probably know, knock off what nephrons he's got. So it's complicated, but what we did was not something you'd obviously think about doing. So here's another one. How much time have I got? 10 minutes? Only a few more cases. So 15-month-old valve patient. So he's much younger, 15 months old. He's got high-grade reflux on his right kidney, as they commonly do, and we know that they do in valves. He's got end stage and he's on PD. So he's got a good capacity, stable, compliant bladder. So he's got a good capacity bladder, but he is getting recurrent infections, and the family were doing CIC, but then got into a bit of trouble with a false passage and then can no longer do CIC. So he had a good capacity, stable, compliant system. So his bladder's good. He's got high-grade reflux, and he's at end stage. He's on PD, so he needs transplanting. This boy needs transplanting, okay? But due to to do double voiding, because a 15-month-old, you can't get them to do double voiding, but when he's a bit older, maybe you can teach him double voiding. So the focus here was to create a system to receive the transplant, and ideally for the transplant kidney to be joined to the native bladder.
Hey man, what about if you've done all your usual preventative measures? What about right nephrectomy?
You could do, but sometimes the kidneys have got reasonable function.
He's on PD.
He's on PD. That's right. If you do so if you do a right nephrectomy, then you've still got the aspect of recurrent infections.
Or maybe not.
Or maybe not. Yeah, you could have got rid of the whole right system as an alternative on hope that if you got rid of that system, maybe he'll effectively then empty his bladder because he's not refluxing. That's another option to consider. And he'll probably he may or may not get that at some point. But I guess you don't know how much urine's coming from there. I know it's not good quality urine, but you don't know how much urine's coming from that. And it could be that that kidney's producing a lot of urine flow. I don't know. It is an option, but I think we generally don't do that, do we? If you have an alternative like this, it's simpler, because this is simpler, I think, for him. So and if this hadn't worked, let's say we did the refluxing system and it didn't work, then you may have to consider that as a second option, isn't it? 10-year-old female, bilateral renal dysplasia, early onset anuric. So, severe early onset dysplasia and almost anuric from birth. Started PD very early on, and then she progressed to having a renal transplant into the native bladder, because we assessed the bladder at the time of transplant and it was reasonably good. So we thought we'd give it a chance. So she transplanted into her native bladder at 2 years of age and then did well, did very, very well. She was incontinent, and that's the key thing. Although she was transplanted into her native bladder, she was incontinent. So the urine was going into the bladder, but just coming out again. So there wasn't any sort of high pressure problems to the transplant kidney. But then at about 8 years post-transplant, she started to get problems with the creatinine going up and the transplant kidney developing some hydronephrosis. So she initially fine. And I suspect probably what happened was she started to become more and more continent and then started to, get higher pressures in her bladder. And then that's why she started to get hydronephrosis and her creatinine went up. Whilst when she was young, she was just incontinent, but then her continence improved with age. So she's 10. Her transplant's already working fine, apart from the occasional rise due to the hydro. So what do we do here? Yes. So you can do a bladder augmentation here. So this is simple. You just augment the bladder and you'll be fine. And then she can either do catheterization from below, because remember, once you've done a bladder augmentation, you must catheterize. The only exception is boys with valves. A small cohort of boys with valves who you augment may still be able to void naturally per urethra, but they still have a mitrophanol. So this girl will need to catheterize. So she's not catheterizing now, but post-augmentation, she'll need to catheterize. So you need to discuss whether she'll want the mitrophanol or she'll catheterize from below. So she's absolutely ready for an augment. 18-month-old, bilateral renal dysplasia, bilateral ectopic ureters, end-stage renal disease. So this patient is already on PD. It's got minimal urine output and it's got a tiny bladder. Okay, so this is a younger child, end-stage, on PD, and no minimal urine output. So she needs transplanting. She's very young. So what are we going to do when we do her transplant? How are we going to create a safe system? You can't. That's the point. You can't. So this is one of those rare exceptions where you do an endourethrostomy from your transplant kidney. Okay, this is one of those rare cases where we have to do it. She's too young. You can't do an augmentation on an 18-month-old. Okay, her bladder is tiny, so actually you can't even augment that bladder. It's so small. Okay, and she's on PD, so you just don't want to mess with her peritoneal cavity. You just do her transplant. You create an endourethrostomy, and then much later on, when she's older and she's ready and the family's ready, you make a new bladder. It's not an augmentation, it's a neobladder. So you take a piece of colon, take a piece of ileum, you create a new bladder, and you put it down in the pelvis, and you connect. So you disconnect her, take down her urethrostomy, connect it to the new bladder, because you need urine flow. You need urine flow for that new bladder to work. Okay, so this is a slightly different approach where we have to do an endourethrostomy first. For those of you who have not seen what an augmentation or a mitrophanol looks like, or an appendix, so this is just some pictures. So You can see the appendix top right, and this is the appendix plumbed into the back of the bladder, and that's how you create your mitrophanol channel. So you join one end of the appendix. So the bladder has been split open like a clam. We call it a clam. So you split the bladder, you open it up like a clam, and then in this picture here, that's the back plate of the bladder, that's the front plate, and that's the bladder neck down there. So the bladder's been opened up, and then you re-implant it. So you don't just join the ureter, you actually do make a tunnel, so like it's an anti-reflux. So you don't want urine coming back up the mitrophanol, so you re-implant it like you re-implant a ureter. And then, so that's how you do your mitrophanol. If you want to then augment the bladder, then you take like about a 40 centimeter segment of ileum, you open it up, and then you join it, and you can see that's what it looks like there. So that's the bladder, and then you've got like a dome of ileum joined, and then the mitrophanol on the right. So that's how we do an augmentation. And you know, it's bigger, but it takes time for it to get up to the 300-400 ml capacity. This is a nice paper which we wrote recently in Paediatric Transplantation, written by me and my friend Kiarish, who's a pediatrologist in Melbourne. And we've written a lot of papers together. And this is a nice paper to read. I've given a copy to Muttley on PDF, and Muttley will email it all to you if you haven't read it. It's just a really nice paper. It's quite complicated, but it tells you, you know, what sort of things to think about urologically in patients who are getting transplantation. And I'm really proud of this. This is in the paper. It's a bit complicated, and I thought about this, and I don't normally think about complicated things, but I think it's a really nice thing, and it's called a Venn diagram as well. I didn't know that. But it just gives you, it's a nice thing, and it tells you when you've got patients who are getting to transplantation, the three things you have to think about in your mind and how those things overlap. And you can, you know, these patients can have abnormal kidneys, they can have abnormal bladder function, and they can have abnormal fluid balance. And what we've put in there, we've put the different diseases in there. So if you take nephrotic syndrome, NS, nephrotic syndrome patients typically do not have an abnormal bladder, but they have abnormal fluid balance and they have abnormal kidneys. If you take, for instance, patients with post-urethral valves, they almost always have abnormal bladders, they have abnormal kidneys, they can have abnormal fluid balance as well. So we've tried to sort of put patients with different diseases into different areas. So it just makes you think that when you have one of those patients, it's a reminder thing for you to think that if I've got a PUV patient, I mustn't just focus on the renal function, I must think about the fluid balance, in, out, etc., etc. So this is in that paper, which you might find helpful and useful. So last slide. So remember, the important thing is to get an augmentation surgery, they must have good urine output, they must be of an appropriate age to do the catheterization, and they must have adequate renal reserve to tolerate the operation, which is a big operation. Thank you. I like that. I thought that was good.
Great. We'll see what the feedback says.
Exactly.
Thank you very much. You were an absolutely fantastic talk. Thank you very much. And I'm personally delighted that you've gone into the medical side of the nephrology and transplantation with nephrotic syndrome. So well done for that, and well done for our team for actually getting a surgeon to think about the medical side. Any questions from the audience? Any still?
I'm Stu, one of the transplant surgeons from Leeds. You do a lot of ureterostomies, or it seems like you do. How they receive them from radiologists in Leeds, they do maybe more often than a conduit. Is that something that you try and avoid, or?
Yeah. So.
Is it last because they want the microbladder?
Yeah, so the advantage of the ileal, yeah, exactly. So the advantage of an ileal conduit is that the patient would have a bag, so you'd be continent with an ileal conduit. So you'll have an ileal conduit, you have a urostomy bag, which means that they don't have to wear nappies. I guess it depends on the age of the patient. Now, this patient was quite young, so she was in nappies already. The problem with ileal conduits is they are notorious. Who's that famous artist who's got one? I've forgotten her name. She's a really famous artist who's recently had a cystectomy done. Tracy Emin. So she's recently had a cystectomy, and she's got a urostomy bags now temporarily, and she tells you they're notorious for leaking and falling off. So if you've got a young child of 4 or 5 with a bag playing in the playground. I think accidents happen much more commonly with them, whereas a nappy system is low maintenance. All you got to do is change the nappy. It's very rarely that you get significant leakage accidents and stuff. So I think we do tend to do more ureterostomies. I cannot think the last time we did an ileal conduit. So I think it's just an institutional difference. And then because also for an ileal conduit, you've got to take a piece of intestine, you've got to create a stoma, etc., etc. So it's a much bigger operation. I just worry about the continent side and accidents and urostomy bags coming off because they're not great.
Thank you.
Steve?
Steve, a quick question because we need to
Just
move
very
on. Yeah.
quickly, that was excellent, Imran. Just going to ask, because obviously you've heard the waiting list is going on, but we try and do living donor transplants where it's all possible. You said 6 months wait between an augmentation and
Yeah,
a transplant?
that's right. I think you can do it in 3 months, and we've discussed that before. About some patients that we wanted to do it much earlier. 6 months is ideal. 3 months is completely acceptable, but I think less than 3 months is a bit tricky in terms of getting that good capacity and getting the compliance low of the reconstructed bladder. So 3 to 6 months, yeah.
Thank you very
Okay,
much.
I better go.
We'll invite you again. Thank you. So the next speaker is actually a course director of this symposium, Mr. Nikos Kesaris, who's an adult and pediatric transplant, renal and pancreas transplant surgeon, and also works and supports and leads on the combined liver and kidney transplantation for children with MMA conditions. Nikos was past lead for the pediatric surgical transplantation at Evelina and Great Ormond Street Hospital. His focus now is within the European Society of Organ Transplantation and is heavily involved in setting up the pediatric kidney transplant programs around the globe, should I say. His first talk, one of the 3 that he will give at this conference, is on surgical preparation for kidney transplantation. So, Nikos, thank you for your help and support in organizing this, and I look forward to your talk.
Thank you very much, Helena, and it's great to see you all here. Thank you for joining us today. This talk is going to feed into my next talk later on today about complex pediatric transplantation, as there's some overlap, obviously. So we've heard a bit about preparation for transplantation from the medical side. I'm going to concentrate mostly on the surgical side, even though we heard a lot already on the urology side. I'll speak a bit about that, as well as other surgical aspects, vascular considerations, coagulation, as well as what we do when the child is very small in comparison to the kidney he or she is receiving. I'm glad this paper was not shown before, but essentially we had previously, a few years ago now, reviewed the different procedures and interventions we've done in urology in patients with lower urinary tract dysfunction, and whether we've done that before or after transplantation. So we had, in the period of 8 years, 288 transplants, and 77 of these were in 75 children with lower urinary tract dysfunction. The majority of those, as you can see here, were from children with posterior urethral valves, and 46 received an intervention, and we've heard a lot about interventions in the previous talk. So the majority seem to be bladder augmentations with Mitrofanov in some 37% of the cases. And as you heard, it does depend a lot on if the patient is able to produce urine and keep essentially self-cycling the bladder. Now, the majority of these were pre-transplantation. Obviously, these kids were passing a lot of urine. And the outcomes of these, whether they had the intervention before or after transplantation, were similar with respect to graft survival, as you can see here, 95, 100% respectively. And you've already seen much better pictures than this. This is creating the new bladder using dilated ureters. And this picture shows using small bowel in this particular case to create the augment. This is a picture of a Mitrofanov, and also looking at it from the surgical and the transplant side, seems to be in the place where you want to put your transplant, isn't it? Most of the time, you can actually create your incision just below that and push everything upwards extraperitoneally. But that's how it looks. And the majority are on the right side because most kids will be right-handed, and that's why it's there. Sometimes you use the left side. And it depends also from which hospital you work at, and maybe through the umbilicus as well. And when you run out of options pre-transplantation, as Imran showed before, you can do a cutaneous uterostomy, and that's how it looks. But many of those do end up stenosing, so they're not without their own complications, let's say. So we always involve the urology team pre-transplantation. We can also discuss potential sites for the Mitrofanov as well, as I mentioned before, right side or umbilicus, for example. And we've heard a lot about making the bladder safe, and we want a low pressure, compliant, sterile, and a decent reservoir before transplanting, and also continence. Actually, Imran is always very helpful. He says, if you need to move the Mitrofanov during your transplant, let me know and I'll move it for you. We've never had to do that, but it's always good to have some support if you need to. We tend to do a midline incision for the smaller kids, and I'll talk more about small kids later on. And you can use a midline approach to create the to do your transplant and bladder anastomosis in the cases of Mitrofanov or augmented bladder, or you can use the retroperitoneal approach. And of course, retroperitoneally, you can avoid adhesions as well. Occasionally, we need to remove one of the native kidneys, or even more rarely, both. We are guided by the urology team, nephrology team, as well as the patient choice sometimes with respect to that. It's about 1 in 800 where you get 2 ureters, where you might need to reconstruct them, join them together. We tend to put them separately. You could also use the native ureter. I'll talk a bit about unblocks later on. We use the Leach-Gregoire technique, and we'll always use a stent that stays in place for about 4 to 6 weeks. Previous surgery is important, as there might be adhesions, and it might take a lot longer to do the surgery. Depending on the situation, consider starting the recipient first to make sure it's feasible before a living donor nephrectomy. If they've had previous transplants, like a liver transplant, you can always either do a retroperitoneal approach, or if you could do a midline, just inform the liver team in case you need some help with the mobilization of the liver to achieve enough space for transplantation. Also, for the smaller ones, we do have a second colic at hand for extra help. This day and age, kids come in all different sizes. It's not just adults. And of course, if a child is obese, it takes longer to do the procedure. The risks are high with respect to wound problems. Also, there's a bit more risk of delayed graft function, especially if it's in deceased donation. Vascular considerations, we may have multiple arteries, and we'll hear more about that later on. But essentially, we try to utilize all the arteries that we have. We may need to do some reconstruction with well-known strategies, as shown here. And small veins we can divide, and I anastomosis equal veins myself. And we start with an ultrasound to assess the vascular anatomy, the alex as well as the aorta. And depending on the size of the child and how easy it is to do an ultrasound, we may do an MRI for the younger ones. If there are known vascular abnormalities, like no IVC and so on and so forth, we may do a CT venogram or a standard venogram, but we do less standard venograms these days. I'll show you a case of a 14-year-old. This was an Evelina patient where we had the child on the deceased donor list for a second kidney transplant after losing the first one from rejection. and she was on hemodialysis prior to that. And you can see your heart sinks when you try to find a vessel to your anastomosis, and there's none really, or very little. So you need to look a bit more carefully. So this child had a left external iliac vein, which I happily utilized at the time of the deceased donor transplant, with some heparinization at the time, with an excellent outcome. As we know, the smaller the child, the smaller the aorta as well, and I don't know, you ask any surgeon when the good blood pressure at the time of surgery, we'll hear more about that from our eminent anesthetic team. And yeah, so that's an issue that we do encounter very often, especially in the small children, and of course, occasionally we get caught out because the recipient, the donor kidney comes with a history of hypertension, sometimes multiple antihypertensives, and we don't see the effects until we transplant the child. And I remember one particular case, small recipient, GOS this time, we took a time zero biopsy after it took a bit of time to become pink, and all the arteries were sort of obliterated really from the hypertensive disease. So I wasn't sure how I was getting its blood supply, but anyway, it did last for about a year, that particular kidney, or a bit more. Now, we don't routinely screen from thrombophilia ourselves, but in this European Society for Pediatric Nephrology survey, some 94% of transplant centers do screen for that. And this table gives the percentage of the units who actually give heparin. For example, those previous thromboembolic events, 87%, positive thrombophilia screen, 87%, small donor graft to a small recipient, 55%, and other venous or arterial abnormalities, 55%. We routinely give low-dose aspirin in our cohorts, both at the Velina and Great Ormond Street, based on this data where there's less graft thrombosis. Now, what about when there's a discrepancy between the donor and the recipient? Well, what is a small or a young child? We define, or this particular paper defines a small child, one that's less than 20 kilograms, this one less than 15 kilograms, this one less than 11 kilograms. So there's no precise definition. We tend to call a small child one that's less than 20 kilograms in our hospitals. And the main reason for that is because we do an intra-abdominal transplant if it's less than 20, as opposed to extraperitoneal, even though that definition has become more blurred recently as we do more extraperitoneal transplants in the ones sailing that are between 15 and 20. Anyway, we reviewed our data, less than 20 and more than 20 kilograms, to see if there's any changes in graft survival. And you can see 123 in the less than 20 and 330 in the more than 20. And there was no significant difference between these two groups of patients. So we talked a bit about investigations, specialist reviews before they come to see us in clinic. And then sometimes they go back for further investigations and so on, and come back to us again in clinic. I think it's always good to see them often to make sure you also obtain a good consent as well. And eventually they'll pass through our MDM before we formally consent them and do their transplant surgery. Thank you very much. Take take the opportunity of some fluid management. Yes, thank you. Albumin.
Prepare them, especially if somebody's got nephrotic syndrome and high
Yeah.
chance of recurrence.
Well, obviously we prefer it to be, I guess, in the 30s, but I rely a lot on my nephrology colleagues. And I guess also from from the thromboprophylaxis point of view, also that's a risk. I guess we don't worry so much about the albumin because most of the time it's fine. We occasionally worry about ureas, and that's would have been a much bigger discussion. Yes, thank you.
I was just going to add that we normally, like Nico said, don't really look at the albumins anymore, but we do try and get them in the 30s. The fact that their urine output is reducing is indicative by the fact that their albumin starts to rise. So you can see that. And for the nephrotic children, for the genetic positive ones, we don't really do the nephrectomies anymore. And for the patients who don't have a genetic variant, we tend to nephrectomize only if their coagulation is abnormal or they have a really good urine output, or albumin is usually not an indicator. I can remember one in the high 20s that we've recently done and has been fine. So we just look at the overall picture and try and do that.
Yes, thank you, Zainab. Yeah, thanks. Good question.
Any more questions? Steve?
I just wanted to touch on, you talked about the size of the patient being weighed, but surely the important thing is the length of the child because you're wanting to know about the vessels. So is there a way that we should be thinking about the vessel? Maybe tell the audience what your minimum vessel size is. How many millimeters on ultrasound or MR?
Yeah, we prefer the aorta to be more than 4 millimeters, I would say, ideally 5. I guess, yeah, we need to tailor to the patient to take the whole picture into consideration. Of course, you can always do and transplant on a younger child if you have a smaller kidney. And indeed, if you look at the literature has been coming from China the last 5-10 years, they do a lot of that. So they actually send all the young, small donors, let's say, into the pediatric recipient, and even under 1 year of age. And occasionally we see, for example, Walter, who's going to join us tomorrow. Unfortunately, couldn't make it in person, but he transplanted a small kidney into a 5-kilogram recipient when he was in Stanford. So it is possible. It's just we don't have many of those kidneys, unfortunately. Yeah.
Okay, thank you very much. In the interest of time, we'll move on, but I'm sure
Thank you
there'll
very
be
much.
discussions during the coffee break. Thank you, Nikos. The next.
You seem to have a
They should be talking about the intraoperative development of all those children that Maria Nicholson is not even talking about. I think thank you very much. Hello everyone, my name is Nadine. Thanks for inviting me back. So we'll spend the next 20 minutes looking at some of the anaesthetic challenges and how this feeds into the surgical and nephrology opinions. For most of the talk, I'm focusing on the smaller children and the large midline laparotomy, where the transplant's being, the kidney's being transplanted onto the larger vessels. So from the anaesthetic point of view, although I'm a paediatric anaesthetist, I very much see that I have two patients when I'm thinking about transplanting a child, because my duty of care is obviously to the recipient, but also I do focus, especially for the live-related transplant, areas that we have a donor, and although I don't meet them, I want to make sure that the process is as smooth as possible so that we give the best care opportunity to both the donor and the recipient. So we try to do this through a thorough workup for theatre, as we've spoken about earlier with Maria. We have a very formalised MDT process. We try to be very clear, open and honest with our discussion, both with the child and with the family. And one of the most important things, I think, is having a high level of communication within the specialist team. So that is within, between the surgeons, the nephrologists and the anaesthetists. And hopefully if we get those three things right, we've got the child ready for transplant on the day, and we can proceed to hopefully a safe surgical environment, with the hope that that leads to a quick recovery, getting the child and the family out of hospital, because we know that that's best, and get them home as soon as possible. So there are three things that I focus on. So preparation, both in terms of a long workup, which may take months, and then thinking about the preparation the 24 hours beforehand. Thinking about how I'm going to manipulate the physiology so that a large kidney can be transplanted into that small recipient. And I think anyone who goes into this would be naive to not undertake some sort of thought process around the psychology for the child and the family. So we've got a brilliant MDT process. As we said, it occurs monthly. One of the anaesthetists will attend. But actually that MDT relies on the larger surgical specialties, the nephrologists, surgeons, anaesthetists, but also we can't do it without the CNSs, we can't do it without the ward nurses, the play specialists, and we have a very brilliant resource by which we can get cardiologists, respiratory, to look at those patients early on and follow them through that process. Our transplant patients are recurring visitors for surgery and anaesthesia, and that's why it's important to also remember the psychology. So some of these children will need to come for scans or lines before we even get to the main transplant day, and then post-operatively they're going to need their stent removed. They might need further transplants in the future. They may need fistulas or more lines. So it's really important to think about how you're going to manage the family and you're going to manage the patient. Because if you get that wrong first time, that is a very long process whereby that just culminates in chaos. As Maria mentioned earlier, on the actual day of the transplant, it's important to be aware that perhaps the most supportive family member may not be present for that day because they may be the donor. So why is it anaesthetically so complex? So I've picked out three cases that sort of sprung to mind. I've been involved with all three of these. So they're real patients. The first one is an 8-kilo patient. I think he was about 3 years old, who's coming for a preemptive transplant. I think it's a different patient to Imran's, but also had prune belly syndrome and developed regular ERTs. And of course, came from another country, arrived in the country, came to Gosh, and then 24, 48 hours beforehand, he's got an ERT. So everyone's looking to me, what are you going to do? So great, I've got a patient with prune belly who's got respiratory symptoms, who's having a massive midline laparotomy, who's a very small patient, and who's come from abroad. So everybody wants you to carry on. I did postpone it that day because I think the combination of those factors, once you've got immunosuppression on board, things weren't going to be smooth. And actually we did go reschedule, and it was very successful. The second patient is 16-year-old, 52 kilos, so basically an adult patient who presented to us in acute renal and cardiac failure, required ITU admission, and came to theatre initially for a PD catheter. And I took over from the anaesthetist that started this case, and very shortly after I took over, he arrested on the table. We got him back, went back to ITU, did an echo. It did show some impaired LV function, but definitely not, I would say, in context with the clinical situation, which is obviously a common problem with echo. He had some PD for a while. He went home, stabilised, and then came back to us for renal transplant, and that all went smoothly. The third patient is someone who we're working up for transplant currently, 17-year-old who's only 14 kilos, who's got dysplastic kidneys, is already on PD, and has a background of primordial dwarfism, trisomy 15, hypertension. She doesn't really walk. She's got intellectual disability, and and usually she's also a grade 4 airway. So she's already come for anaesthesia, for scans, and to get her PD catheter inserted. But you can see from here the age range, the size range, the comorbidities are vast. So we've got respiratory, we've got cardiac, and we've got some unusual syndromes which make the complexities really very big. So our smaller children, as Nicholas said, normally 8 to 20 kilos, will have those large laparotomies. They've got these renal patients, whoever they are, their growth is very much lower than their peer group, and their weight is very small. So when you come to do a transplant in these children, you're trying to manipulate their physiology in order to get that kidney perfused. So if you've got a fit and well dad who's 80 kilos and you want to put that kidney into a 10 kilo child, we're looking at what blood pressure would be optimal. Obviously, everybody wants you to hit the donor blood pressure. If they're fit and well, that might be possible. If they've got hypertensive disease, it might be very difficult. In a child who's only 10 kilos under a general anaesthetic, this is going to possibly be difficult. So you have to have some strategy of how you're going to achieve this, or formulate some negotiation with the surgeons. So renal perfusion, just to go back to basics, in an adult, 20% of your cardiac output is expected to be delivered to the kidneys. So they are expecting 600 mils per minute per kidney. And if you think about a 10 kilo child, their circulating volume is only 750 mils. So when you go to reperfusion, if you've not got your strategy in place, you've not got your volemic status sorted, you either neither going to reperfuse the kidney well, or you're going to have massive cardiovascular collapse on the table. As I've said, our children are regular attenders, so they'll pretty much tell you what they want. We try to be flexible and adaptable. So gas or intravenous induction, but really I want to know what is their preoperative hydration status. It's no longer necessary to starve children or adults for prolonged periods. They can drink up to an hour before surgery. So in terms of starvation, that shouldn't be a problem. But I do want to know what's their dialysis situation, when did they last have it, what's their normal fluid restriction. We're not keen on dialysis on the morning of surgery. Occasionally it is required, but it is unusual, and it will be seen on induction with profound hypotension. You're going to need invasive lines. So as we talked about earlier, we tend to scan the neck if they've had a lot of lines before, so we can assess where it's best to insert those lines, and you're going to definitely need some kind of invasive monitoring. In terms of intraoperative management, so you need very good IV access. This isn't always easy in these children because volume replacement is quite massive. And I would expect in these smaller children to be giving in a range of 150 to 250 mils per kilo of fluid. So when you first start doing these transplants, it seems like an insane amount of fluid to give a child. But that is generally what is required for these smaller recipients. I will definitely need some form of central venous line for being able to give inotropes. If they've got a permacath or a vascath already in situ, then I may choose to use that rather than inserting another venous line. Monitoring, we do central venous pressure monitors. This is not looking at a number, but just at the trends that develop. And in terms of arterial line, definitely for the small children, this is massive surgery onto the major vessels, so I need an arterial line. In the larger children, I probably tend to avoid inserting unnecessary lines, especially thinking towards the future, if that child may come back for further transplants or need a fistula inserting. Probably an arterial line isn't necessary in those larger recipients. It's a large amount of fluid that you're going to give, so be sure to warm, be sure to monitor temperature, and then you can think about whether it's possible to do more formalised cardiac output monitoring. In terms of fluids, this is ongoing debate, which I'm not sure will ever be sort of sorted out, but paediatric fluid management is sort of based on the 1950s, and it's still managed around that. We haven't moved massively on. So that's from studies by Holiday and Cigar, and that's really where that 4-2-1 rule for maintenance fluids came from. And much of paediatric fluid management is based on that, looking at using, 0.45% saline with some sort of dextrose. This isn't what we're aiming to use in the surgical population, and it's not appropriate. It can lead to so I've written hypo, but hyperglycemia and hyponatremia in a post-operative surgical patient, and it's absolutely not useful for large fluid shifts. So when I assess the child, I look at their baseline fluid requirements and their electrolyte balance. I will look for a period of months over their blood results, particularly looking at how they handle potassium and whether that's been a problem. As I said, I want to know when the last dialysis was, what their fluid restriction generally is, and I'll do an early blood gas intraoperatively to try and get a feel for the child in terms of how dehydrated they are or what their electrolyte disturbance might be. So you want to note your starting potassium and you want to note your starting hemoglobin. Again, because of a really thorough and prolonged workup, our children's gases are normally excellent and hemoglobin is optimal. Sometimes with a deceased donor, it might be slightly different. But with large amounts of fluid that you're going to give intraoperatively, the hemoglobin is probably going to drop a bit. So you need to have some sort of strategy about what's the lowest hemoglobin you're going to be comfortable with, because these are the children that we don't want really at all to give any blood transfusion to. So targets here might be quite different to other surgical populations. In terms of dextrose, it is very unusual to require dextrose, and we would completely avoid it unless there is a specific metabolic or endocrine reason whereby we'll run a small maintenance dextrose infusion, but that won't be separate to our fluids used for improving volemic status. We're going to monitor it as we do hourly blood glucose and gases. Patients obviously have a stress response to surgery where you'll see a raise in glucose anyway, despite dextrose. And the thing with dextrose is it will also cause a hyperglycemic osmotic diuresis. It will just cause you to give more fluid, so you're sort of chasing your tail. Third space losses. So the reason why often we don't need to give a blood transfusion is due to third space losses, although apparently this is a controversial topic. So there are studies suggesting it's non-existent. Other studies saying that the losses can be quite huge, up to 15 mils per kilo per hour. Over the past decade, there's been a sort of roller coaster in change, particularly in adults, where they're trying to formalise cardiac output monitoring, particularly in renal transplant, looking at using cardiac output monitors for goal-directed fluid therapy. So they're using these monitors to optimise the hemodynamic variables and then adjust the fluids according to that. So we have both of these at Great Ormond Street, the esophageal Doppler, which is the bigger one on the bottom. That works by looking at flow of blood through the aorta. So obviously in these small recipients where you're clamping the aorta, that's not good. You're going to have a period of time when that's not going to be that useful. We have Lidco, which we have used for a couple of years. We used it for about 18 months in the renal transplants to see if it would change our fluid challenges, but it actually found it just correlated with what we were already doing. These cardiac output monitors are not validated in children, but they may be useful, and particularly in the older adult-sized patients. If you have them, they're a good addition to the other clinical variables that you might be looking at. In terms of what fluids you're going to give, obviously we've got colloids and crystalloids. So there are natural colloids, blood, which, as I've said, we always have 4 units on standby should we have a sort of catastrophe, but it's something that we really want to avoid. And you will see the next day, once the patient hopefully has started passing urine, that huge amount of fluid that we've given intra-op has already either been passed out or has been lost through to third spacing. So where the hemoglobin may have dropped, by the next morning on the ward round, it's elevated back to normal. So if you've given a blood transfusion, you're going to see a very high hemoglobin. Albumin is, I think, still popular in paediatric medicine, it's never really been something that we do in anaesthesia. The adult papers have shown in a variety of contexts of surgical populations and medical situations, albumin has poor outcomes. So it's not something that I would naturally want to use. In terms of synthetic colloids, starches and the dextrans have completely gone out of favour, and we don't have them in Great Ormond Street anymore. They're known to cause bleeding. They can cause, some of the larger molecular dextrans can cause renal failure in themselves. We still have some of the gelatins lying around, and depending on the situation, they can be useful as they stay in the intravascular compartment longer. So if you have a very, very prolonged surgery and you're struggling to maintain volemic status, they can be useful. But really, the studies show there's not a huge difference between colloids and crystalloids, so we veer to crystalloids. So we've got 0.9% saline. Again, in paediatrics, this is something you would normally use as your fluid bolus in a sick child. And it is good. It doesn't contain any potassium, so that may be useful if you're struggling with a potassium load. But it does cause a hyperchloremic acidosis. So it's not something I would use in vast quantities. So we're looking now towards Hartmann's and Plasmolite, both of which have got osmolalities similar to plasma and an electrolyte component similar to plasma. So they're naturally what we've used for decades in anaesthesia, and it's definitely become more popular. One of the nephrologists has recently done a study looking at the use of Plasmolite in renal transplants. So then we move to the what can be an intense moment, reperfusion. So as an anaesthetist, it's one of the surgeries I really monitor the stages of what's happening up until that point, and I try really hard to have the patient completely ready for reperfusion. I would hope the surgeons give me some kind of warning, and they do normally, that they're going to release the clamps and they're going to do it in a timely, controlled manner, and we're going to talk about what's happening. And for the most part, that's fine. And if the kidney turns pink quickly, there's a sigh of relief and everybody's very happy with themselves. But if that doesn't happen, there's a lot of looking at my monitor. What's my blood pressure? How much fluid have you given? Do you need to give some more fluid? So I've been doing this for about 10 years, so I expect these questions every week. So it's my duty to know how dry that patient was at the start, and it's my duty to make sure that they're at the right volemic status at the point of reperfusion. So I can be quite confident using those monitoring values that I've spoken about and knowing what's normal for a renal transplant, where I am in that phase. I've also got my drugs ready, so I've normally got a phenylephrine boluses, which sometimes keep the surgeons happy because I can give them some false numbers. I've got some inotropes on the end of the line ready to go. And then we sort of battle it out. And if I'm absolutely confident that I've done my bit, then normally we now have a very good relationship where I can say, I think I'm okay with my side. Do you want to have a look at the kidney? Because there are other reasons, apart from fluids and blood pressure, why that kidney's not reperfusing. So the position of the kidney, is there any thrombosis? Have you just been jabbing at it for a little bit too long? Can you give it a break for 5 minutes? In terms of inotropes, every institution is different. I would say we veer more to using dopamine. That's not due to renal protection, but I think surgeons are a little bit more comfortable with dopamine, and we think that it maybe causes a little bit less vasoconstriction and therefore perhaps has a lower risk of thrombosis. In truth, I'm not sure that there's any sort of realistic truth to that. There's not a right inotrope or a wrong one. In some patients, particularly the cardiac patients where we don't want a raging tachycardia, then I'm going to probably veer to noradrenaline. But these are normally required. It would be normal to have those on at reperfusion, and maybe in the smaller children that's going to continue into the ICU. In the patients that we can wake up a little bit sooner, we can normally have the inotropes off by the time they get up to the ward. This is a brilliant surgery for me because I can see the physiological changes in front of my eyes. You can see the kidney picking up. You can get a feel for how well you've done your job by the stability of the patient at reperfusion. For our larger patients who are going to go to the ward later, we would do transversus abdominis plain block at the beginning of surgery, and the surgeons kindly will insert a catheter under direct vision at the end of surgery, and will start a local anaesthetic infusion. And this has been really quite great for the patients that are waking up straight away and going to the ward. They still have a morphine nurse-controlled pump or patient-controlled pump, but the amount of opiate that's required has dropped dramatically, which means they're more alert, they've got less nausea and vomiting. In terms of the smaller patients, obviously they're going to remain sedated and go to ITU. So thinking about post-operative care, we want to continue all that work that we've been doing intraoperatively into the post-operative period. So sometimes once the kidneys reperfused, everything's looking good, the patient's diuresing, actually you've still got to maintain your bulimic status, avoid hypotension, and do all those good things for quite a few hours after before you actually get them up to the unit. So you can, if you're not careful, get behind again on fluids. So you need to keep monitoring everything. So we want to close the abdomen without impinging on our ventilation. We're going to remain fully sedated, probably for 12 to 24 hours. We want to ensure we've got good analgesia. We want to avoid hypovolemia, hypotension. Again, where possible, avoid transfusion. You might want to let that hemoglobin drop to more around the 5-6 mark. Keep your maintenance of monitoring, and there's another team that's getting involved here, and that's ITU, who also have a different outlook on things sometimes. So that's why it's really important to maintain that high level of communication. And at that point, we do a very thorough handover between nephrology, surgeons, anaesthetists, and ITU to ensure that all these things we've been aiming for to get that kidney working continues until that patient's awake. And that's all.
Okay, thank you very much, Nadine. Any questions for Nadine? Question.
So you didn't tell us what blood pressure you consider minimum.
Well, I've got different views. So the reality is, if you put somebody who's fitting well under a GA, you know, their blood pressure drops dramatically, they will still pass urine. If they're on an ITU and they're sedated, even an 80-year-old man will pass urine at a much lower than I think in general the medical population will accept. For the surgeons, I think I would say 100 is a popular number. Ideally, if I can get the blood pressure to a similar level of the donor, which I think if it's a fit and healthy adult, I think 100 to 120 systolic is very reasonable. That's achievable. But in an 8-kilo child under anaesthesia, we're talking about using a lot of inotropes. And then you're into the risk versus benefit. Just be squeezing everything up, is that going to actually cause problems for the kidney? So I think it's just communicating, but aiming for a realistic number above 100, I think is fair.
Anish?
Thank you. So we tend to sort of sometimes ask the surgeons what was the perfusion sort of pressure, and sort of look at it. Thankfully, when they wake up, they've got a higher pressure just because of the pain.
Yeah.
The question I had was, is there a weight which you think pediatrics should reconsider? Because we are quite used to, I'm thinking of the big patients, we've got patients now sort of above 100 kilos, and we are sometimes at risk of giving, not thinking about it as adults because they're just not used to our expertises with young children, as you said. Is there something along those lines that you think we should reconsider and just...
In terms of blood pressure?
In terms of just how we think about our transplant patients, when we are taking them for transplant, then they're a very big way.
I think that's when cardiac output monitoring is genuinely useful, because they will need much less fluid. So I think if you can use a LIDCO or some of these cardiac output monitors, which is what they're doing in adults for renal anyway, I think you'd be able to guide your fluids much better, not sort of overload just for the sake of giving fluids. I think that would be useful.
More questions? No, Nadine, thank you. We've overrun a little bit, but it was an interesting discussion. So it's a coffee break now. Should we say about 10 minutes and then back for the...
I think we know that she's been
Well, we arrived this morning in this room with like 100 degrees, and now it's like Congratulations. Well done, well deserved.
Yes, thank you very much. That was very socks in the house.
I just went to my brother-in-law's who were looking and they're all growing up, and I said, "Your two focus on hungry," because I was one of the two boys.
Okay.
Oh, my mom was just to say,
Perspective.
well, they always just to say, the boys are all, hanging up with them and stuff.
Well, we're secrets here.
So now you take your kid?
Yeah. I mean, they're tired.
Yeah, it's a good.
With a small bed in the house.
I was on call last week. I had to look through it. It looks very good. I got a reading of it, so I'm going to
I was wondering if my emails were coming through.
No.
I was not.
Yeah, no,
I didn't want to bother.
no, we've got a really strong firewall at the moment. For some reason, even when you, basically, the way that it works is you get a list of emails, some of them you don't. But for some accounts, it's really, so like, when someone has international organizations email us, like ESP, some of us get emails and some of us don't. And we've spoken to ICT, they're not quite sure why. So if you don't, then message me or tell me.
I told you, like, Dr. Mars is always so,
But last week I was on call and I literally had a manic, but
I don't want to bother.
I've printed off things, so I will.
Thank you so much for your time.
Were you well otherwise?
Yeah. Thank you for such a nice. It's only really don't really have a service, so I appreciate it's always amazing. Very eager to start, professionally, but these things are important.
And the curriculum was probably.
I saw that. Oh, yes. I can try and do my best to some things are natural. One way or another,
So you'll decide to behave yourself now. Now it doesn't matter.
So one of my friends is a pediatrician, the kids are all grown up.
Okay.
So she's doing it.
She was doing it.
Hey, okay. So so we were. I thought someone here. So much. They were just jet lag. Once you over that, which is like.
I know.
There's always something huge. There's always something. This isn't. And you know, you just like to say, well, you She's still moving along. I was trying to get to 6 months. There was a year. And I started back at work. Yeah, she's still not that conversation. I feel like that, yeah, I feel like I'm such a picky mum, barely keeping it together. But so if you could just that's the plan.
Exactly. So make sure.
I'm thinking soon.
Well done. Sounds very good. That's very fun. Just think about I'm an occupational right? For example, I'm supposed to get with the person who's I've spoken to. She's older than she is. So he's cool. Dad. Provide for the Told you twice. It's your job. Yeah, there's no way to culture, but
I asked the fella to switch it down before because it was dead off.
Yeah. Hold the microphone.
Well, I've just got rid of a load of stuff. So that works and that works at the moment. And fingers crossed we won't get any of that, whatever that is.
Yes, okay.
So we can switch this on. So it's that little red button there.
Okay.
You hold that down until the light comes on. And then it shouldn't make any noise whatsoever. But it'll only do it while we're live, won't it? It won't do it when it doesn't matter.
Yeah, this is the same order. I'm just thinking, so that's George for the back, obviously. But I'm just thinking, so you can't plan it then. It's probably 1 to 1:15. And then lunch is half an hour, so we probably start at 2 o'clock. Which is fine because we can finish just after 5.
No. So we've got George, you, and yeah. You change it. Not change around the first section, is it?
So you can book your flight ahead?
And then we went.
George, yeah. Elena, Flynn. ready to rock. I can use this. Yep. You switch there's a little red button. You hold the red button down at the very bottom. Yeah, hold that down and it comes on. Yeah, when the light comes on, let go, and then we're ready.
Hi, everyone. Could I ask you to come back and sit down with your drinks, and we'll start the next session. Sorry, running out of time. Yeah, I'm
Just a little before we reach. You need to stand there so that they can see you coming. You need to stand next to them.
Can you see me? Can you see me now?
No, it's the cameraman. You seriously, I don't play this.
So we're going to start the second session. Just want to say thank you to the delegates who are joining us online, apart from all around the world. That's amazing. We also have the Twitter account. We want to ask some questions at Transplant for Kids. Thank you very much. So, without any further delays, I'll ask George Papadakis, who is one of our consultant transplant surgeons here at Guy's, Evelina, and Great Ormond Street, to come to the podium and give us his talk on choosing the right living donor. Thank you, George.
So hello, and thank you for the invite, Yelena and Nikos. It's a bit awkward to give this talk, especially with some specific people in this room. And yes, I'm talking for Maria, Kate, Anita, Christy, the real heroes behind this huge effort to end up with the right living donor. I don't think it's going to. Good. So, why living donor transplantation? As we all know, is a treatment of choice for most patients with end-stage renal failure. It provides the optimum outcome in terms of graft and patient survival. Did I do that? Sorry.
If you just touch it somewhere else, it should go away.
Can I go back?
Yes, go back. Oh dear.
Provides the optimum outcome in terms of graft and patient survival, and very important for the pediatric people, it gives a better chance for a preemptive transplantation as opposed to the waiting time in the deceased donor transplant list, which is around 2 years, as we heard earlier. Through the shared scheme, it gives the option and the opportunity to some people to get a better quality or a better matched organ, and something that we're going to discuss in a bit. And for a small proportion of complex recipients, it actually offers the opportunity to be benefited from a better organ that they would probably never be offered something similar in the deceased donor waiting list. So, and having all this in mind, obviously we promote and we try to always prefer the living donor option. And these are the numbers of our transplants for the last 2 years. And you know, the combined program served by Guys, which involves Great Ormond Street patients and the patients at Evelina, is considered, I believe, the biggest pediatric program in the world. And as you can see, these are the numbers of the deceased donor transplants, which is actually also less than 1/3 of all the transplants, whereas 2/3 or so comes from a living donors. There are different types of living donor transplantation, of living donation. So one is what we call the directed donation. That's the very common scenario, especially in the pediatric world, that one of the parents donates to their child, or in general, it can be emotionally related donation, which mostly in the adult context is like when husband and wife donate to each other. If we don't have a compatible donor, or if there is any other reason that we will discuss in a bit, then we enter the pair donor recipient pair in our national. I'm definitely doing something wrong here.
I think you're touching this.
You don't want me to touch it? Okay.
I think you're touching the keypad thing.
I won't touch anything, I promise.
Okay, right. Okay.
So the pair would enter our national sharing kidney sharing scheme. And as Maria mentioned earlier, if it is two pairs, it's called a pair donation. If it is more than two pairs, it's called pool donation. And something that is going up and up the last few years is what it is the non-directed altruistic donation. A number of people, which I believe is more than 110 now in the UK, they have donated their kidney altruistically, either as a direct donation to a patient, or most often, and that's something really interesting, and maybe we can discuss it another time, how a non-altruistic donor triggers the chain donation, which is something that can end up in benefited much more people than one-to-one. There is also the directed altruistic donation, and this is, again, I will have a lot of referrals to Maria's talk because there were some overlapping. So, first of all, there is a genetic relationship and no established emotional relationship. This is, for example, a cousin that you've never met, and suddenly they hear that you have a kidney problem and they come forward to donate to you. Okay, and the other one is what Maria mentioned with a lot of social media campaigns lately, is donors that they have no relationship, but they never knew the recipient before it was found out about the renal failure of the recipient. I'll be very careful now. Sir? Great. So, how we find the optimal donor for our child? Well, this is a big process, and it's not a linear process. It's a very dynamic process that can go back and forth. Okay, and as I said, the real heroes behind this, especially this initial part of the process, is our living donor coordinators, Maria, Jenny, in the Great Ormond Street side, Kate for Evelina, and you're too many guys. Anita and Christy are here. So, as soon as we know that the child heads towards the need of a kidney transplant, an initial discussion starts with the family. And this discussion is not only obviously in one meeting, but it happens again and again. And that leads to, especially the transplant coordinators in the pediatric side, to form like a very strong bond and know very well the families and the different dynamics within the family. And that helps hugely when the adult donor side team at GUYS gets involved. They have a huge feedback and very useful feedback from the pediatric team to say that, you know what, this is happening, this is not happening, this could work, this will not work. Okay? And this is part of the initial assessment. And once we identify a potential donor, and as it was mentioned earlier, the donor, they need to come forward. Okay, so we cannot say, oh, my cousin wants to donate to my child. The donor needs to come forward. Then we have set up this 18-week process that we're hoping to have done the transplantation by that time. In the first 2 weeks, they are, in a way, again, part of kind of the preliminary process in order to, when the coordinators facilitate the initial discussions with all the potential donors, because as I said, it may not be one. And especially when it's not one, then we need to find the most appropriate one. And the most appropriate one is not necessarily the parent with the best match. It's not necessarily um, the, the grandmother who he really wants to donate the kidney. Okay, so we need to look in a more holistic approach, the whole picture, Because to give you an example, yeah, most of the mothers want to donate to their children, right? But most of the mothers are much, much better to you know, calm their children or make the child feel secure after the transplant. Therefore, you don't want the mother to be stuck in another hospital having had an operation and not have, you know, like the most appropriate support for the child afterwards. We say that we look in social, psychological, and medical risk factors. We will discuss about the medical factors. Regarding the social and psychological, other things that we look into is who brings more of the income in the house? Is it sustainable to have the transplant? Are there other siblings? And you know, since if especially if one of the parents is in another hospital having had a major operation, are there enough people to look for the rest of the children? Or who is going to be in the hospital? So there are lots of factors that we put in the equation before we end up choosing the right living donor. But once this is done and we have found the one, there is again the initial medical and psychological and logistical process, which again is run by the main living donor coordinator. And as part of this process, we will perform the, uh, we will check on the blood group compatibility, we will check on the HLA typing, mainly for the children who have had reasons to be sensitized in the past. We need to make sure that the donor understands the process that they're getting into. Obviously, we need to take a very detailed medical, social, family history and check on a number of factors, including the BMI, um, the past medical history, the past surgical history. But what is the main focus of this initial collection of information is to make sure that there is not any hard stop that will tell us that this donor cannot proceed. And these hard stops, which actually are the contraindications for living donors, include when their kidney function is less agents. And obviously, if the potential donor is found out that he has one kidney, probably we won't take it out. Although there are mothers that they ask both of their kidneys to be taken out when they are in this very unfortunate family that they have two children with renal failure. And then any psychiatric disorders, which obviously will be, if identified or if suspected, they will be referred further to a specialist to assess. Oops. So regarding the renal function, the initial assessment is based on a measurement of the serum creatinine, based on which we estimate the eGFR. People who are of Afro-Caribbean or African family origin, we need to adjust the eGFR, and the most accurate measurement is using the EDTA eGFR. And you see that table that I was mentioning before, that what is the threshold of EGFR according to age that we are allowed to start discussing about donation or not. Obviously, as the age progresses, renal function is one thing. There are more and more factors that we need to think of, including, is that really the kidney that we want to give to the child? But we have other solutions for that we're going to discuss further down. As part of our preliminary investigations, we need some kind of imaging of the kidneys. It can be ultrasound, can be an MRI. Most often it's a CT imaging. And if in that imaging it is found out that there is a discrepancy more than 10% in the size of the both kidneys, then we're obliged to do a function test, a split function, to see, using a DMSA, to see which kidney, if the kidneys are within they're like balance their function. And if it is so, we always go for the kidney with the less function. Yeah. So we leave the better kidney to the donor. So, very common question is a history of malignancy in the donor side an absolute contraindication? And the answer is no. There are specific types of cancer that, yes, they are probably a hard stop, like a melanoma, a renal cell carcinoma more than 3 centimeters, lung cancer, breast cancer, sarcoma, and the ones you can see on the list on the right. But there are types of cancer that did not exclude you as a donor. For example, if you had a colon cancer, Dukes A, and that was more than 5 years ago, and you're considered treated, you are probably can be considered as a donor. And equally, I mean, I'm not gonna, but you're going down the list, but like renal cell carcinoma less than 3 centimeters, something that we do use in the deceased donor transplantation as well, by just excising it, or a history of stage 1 breast cancer. Anyway, what I want just to take home as a message is that a history of malignancy does not automatically make you not a potential donor. Obesity. So, big discussion. So, for anyone who is still considered overweight, BMI of 25 to 30, they can safely go ahead and donate. Okay, so the discussion is what we're doing above 30. And until recently, I think BMI of 30 was like a hard limit. Lately, we start to jingle a little bit. So let's say 30 to 35, we kind of discuss it. Of course, that includes to make clear to the potential donor that going through the operation with a higher BMI means definitely higher risk of wound-related complications, wound infection. It makes the operation harder, which means less ideal, and we know that it will not. We know that most of the people with BMI, especially above 35, which we wouldn't do it at the moment, to be honest, they would have a prolonged hospital stay as a result of the operation. And that my last point here, although this is known for a number of obesity-related reasons, is that obesity increases morbidity, but does not increases mortality. So, but that's still a reason not to do it, according to me. Now, I don't know, we are about to pretty much establish in the next few years the use of the robot to doing the donor nephrectomy. I don't know if the introduction of the robot in a regular basis changes these dynamics, and maybe it makes it safer and with better results to do the donor nephrectomy in obese patients. Obviously, this is a purely technical and surgical way of seeing it, because having an operation to take a kidney out on an obese patient, obviously you need to think of the increased risk of developing diabetes and all the other potential renal failure issues. Age-wise, so currently we do not consider donors less than 18. The Human Tissue Act does not allow it for England. It does allow it for Scotland. It's above 16, but we wouldn't do it. And that's one side of the spectrum, the young donor. And if it was to be done, because in theory, someone who can consent above 16, legally speaking, could consent to donate the kidney. But at the moment, if it was to do something like that, as a bare minimum of the good clinical practice, we would definitely require the co-signature of the parents as well. The main issue with a very young donor is that there may be renal-related conditions that they have not been diagnosed yet, and they will be in the next few years. On the other side of the spectrum, the old donor is not an absolute contraindication again. Obviously, you need to make it safe, and you need to make sure that from a cardiopulmonary perspective, you're not about to harm a patient. As we all know, living donor transplantation goes against one of the basic principles, as stated in the Hippocrates Oath, that first do not harm. So we do harm to start with by doing a major operation to any donor. Let's not do it worse, something like that. So, but as I said previously, grandparent want to donate to the child. Now the sharing scheme allows us to enter pairs based on the age difference, and in that way the child would get like a younger kidney, and the kidney from the grandparent would be directed to someone else. Virology wise, as I said, the hard stop is only the HIV and HDLV. I find it very hard to imagine us choosing a donor with the history of hepatitis C or B, probably. I don't know if we get to that point. I have not been involved in such discussion. Maybe we can help with that. I mean, if it is deceased donor waiting list or a Hep C, a living donor, but I'm sure that would be very complicated discussions. We may have it in the future. If the potential donor is CMV positive and the child is CMV negative, obviously we need to counsel on, on the prophylaxis that we need to have and the extra risks that the child have. And I have an exclamation mark on EBV, and that's because EBV virus, first of all, most of the children are EBV negative, whereas most of the adults are EBV positive. And EBV has a very strong correlation with the development of PTLD, the post-transplant lymphoma, and that's is something that should have like an important kind of part in the equation of choosing a donor. But let's say that we went through this initial part and we don't have a hard stop, and now we are moving forward down our protocol. And in a way, at that point, there are two types of donors. There are the straightforward donors that they're good to go ahead, and there are the more complicated ones. The more complicated ones most likely will need further intervention. They may need a further even procedure in terms of, like a cystoscopy, like a flexible cystoscopy, investigating any microscopic hematuria or so. The straightforward one, they would go down the line, they would have their imaging reviewed in our MDM, and hopefully they will get en route to get a date, provided that the potential recipient is ready and have their operation. Now, as I said, as part of this final collection of our data, we have a CT angiogram with abdominal KUB for all our donors, and that's something that we discuss in our weekly MDM, where we have radiologists, the coordinators are there, transplant surgeons, and occasionally nephrologists. I just put some random pictures from these meetings just to show that what we can find, we will definitely comment on the number of arteries of each kidney. Okay, I mean, I have one with 3 arteries here. Okay, again, depends. Obviously, our hope and what we would love to have is single artery and single vein in both kidneys. And if that's the scenario, we would go for the left side. And the reason for that is that the left renal vein, having to go over the aorta all the way to the cava, is much longer, which make it much easier the implanting surgery. So if we have the option of a left kidney with single artery and single veins, that's out of the discussion. Unfortunately, that's not always the case. Regarding the venous, multiple venous branches, as Nico said, it's very rarely an issue, if ever, to be honest, because you can easily ligate any extra veins and use the one remaining. A common finding, and that's in the picture in the lower right side, is that you can find you see that the cava, it's kind of pressed by the aorta. It's what is called like the retro aortic cava, where the arrow is. Other things we comment on is if we have a single or a duplicated ureter. You can see in the picture in the upper right part, on the left kidney, there are two ureters going down, and that's something that we would like probably to avoid. And different cysts or other anomalies that can include like PUJ obstruction. You can find stones, and the stones is another discussion. If there are small stones, first of all, you need to run a metabolic investigation to the donor to make sure that there's not any background of creating more stones in the future. If it is a single small stone, we would take the kidney with the stone. We would leave the stone-free kidney to the donor, and quite often we perform a back table ureteroscopy trying to remove the stone before we implant the kidney to the child. Okay. So size, Nikos mentioned it roughly. Should size be part of the equation? I mean, if it's like a huge dad and we have a tiny child, should that exclude the dad from being the donor? Our answer is usually that size is not the problem. If it is, our solution would be to, and meaning that you can always implant it. The problem is how to close the abdomen in a safe way and without putting any extra pressure to the lungs, and then Nadine will start saying, the things that she doesn't like. So solution to that is obviously to use an biological mesh. We use biological mesh because this is not, promoting infection as any other of artificial material. And actually that's two pieces of mesh closing the abdomen. The reason we have the hands here, and I notice that Nikos actually probably I stole the picture from him, is that we say that the kidney is roughly the size of our fist. Okay, so that's how roughly you can estimate the size of the parent kidney, and you can compare it with the child abdomen. Now, what we have done in the past, although I don't think we have done it for some time now, but anyways, another solution we have when there are concerns regarding that if the kidney will fit, what's the ideal positioning, etc. What we've done, Nikos has done this, is to 3D print the abdomen of the child, and that's what you can see here, and 3D print, based on a CT scan, the kidney of the potential donor, and that allows us to play in a way, or try, or try to position the kidney in the abdomen and make it possible to imagine how you need to do it and if it is feasible. Now, some special issues in pediatric transplantation, and which also should be part of our equation, is the HLA mismatching. Why HLA is mismatching? Because the children will most likely need a second transplant down the line in their life. Even, we say that our expectations from a living donor kidney is around 25 years or so, hopefully a bit more, but nevertheless, it's very likely that the child will need a second kidney, and that's why we need the ideal HLA mismatch in order not to sensitize the child, which will make it harder further down the line. ABO incompatible transplantation, Maria mentioned it as well, is probably less trickier in children because they have lower tethers. Nevertheless, there is very clear instructions that incompatible transplantation, ABO or HLA, even more, needs to happen in centers that they do have an experience in doing that and they keep up their skill set. Very important, as we said, that the children need to be, so we need a good viral script of the adult, the potential donor, because we need to have the children vaccinated, and the crucial role of the EBV potential transmission to the child. Social aspect, I will go back to I'll just duplicate what I said 3 minutes ago. We need to put in the equation stuff like the relationship of the child with the parents. Can the child afford the specific parent to be away for the first post-op period? Can the family afford financially or so the whole story? Or what would be the ideal setup to make this already painful process as much as comfortable? Once we've done all that and we have our donor, and I will just leave you with that, that's where we show up suddenly, apart from the X-ray meeting, and we assess the donor, obviously to discuss the operation, discuss the risks, discuss anything that may have been missed in the previous process, which very rarely has. And that's the time that we have the independent assessment from the HTA, make sure that there's no money involved, make sure that there's not any blackmailing involved, and that may happen even within families. If the plan is to include the pair in the national sharing scheme, that's the time to register them, and the final cross match about a week before we finally get the date and the pair is admitted to the hospital and have the operation. And I think that's all from me at the moment. Thank you.
Thank you very much, George. You've covered everything very well. Thank you. Can I ask everybody who may have a question or a comment if you do things differently in your unit? Oh, thank you.
That was a really good talk. How often do you really think there's a big issue with the size mismatch between a small child and an adult? And I suppose my point is that in Leeds we've, can't think of any occasion where we've had to use mesh or anything like that. Now we don't do laparotomies; we do them all extraperitoneal, and we tuck them up right under the liver. And it looks weird at the end because you've got essentially a wound with nothing in it other than a ureter coming down. But if you plumb the kidney onto the cava and the common, which is what we tend to use, you can get to the aorta if you want to, and you create a pocket which is naturally there. And the kids, their tissues are so untouched by anything else, disease, anything. They're really delicate. It just creates this beautiful plane. You stick the kidney up under there. There's no bulge. There's no pressure on the abdominal wall. You can close it with no problem at all. And we do that routinely. There was one time we had this massive farmer, humongous. And he came in to see me in the clinic, and I was like, "There's no way we're getting your kidney into your child." He had a huge cyst on it as well, and we couldn't get it in until we popped the cyst and plicated it. But then it went in fine. So even some really big male father donors can go into these. It was his daughter, very small, she's only 3 or 4. Have you tried sort of putting it anywhere else or doing a different sort of surgical approach rather than just having to put mesh on?
You mean as opposed to put it intra-abdominally?
Yeah, if you just
so if you want my personal opinion, I think Nikos agrees, or maybe not, but I know that a number of my colleagues is that I think the kidney is placed much better if you put it in an extraperitoneal approach, in that pocket you describe, and that's what we've been doing. And that limit of 20 kilograms, we actually, at the moment, is definitely about 15, but from 10 to 15 depends of who is the implanting surgeon. There's a good possibility that it will go for an extraperitoneal approach, and I 100% agree with you that it positions the kidney better, and I'm so much fan of this technique that that's how I do the adult side as well, because I always was thinking, why we struggle to position in an adult and not the child? So you just go further up. I don't know, Nikos, do you have a comment?
Yeah, very good point. Even though there's a paper from Niaz Ahmed some years back where he used mesh. But anyway, I've only intentionally put in once the mesh in advance before closing in a dwarf case. So normally you don't need to, but we were caught out once or twice where we closed, we did the and it was compressed, so we had to open and put in, or a day or two later where there was high intra-abdominal pressure, reduced urine output, but it's very uncommon. Thank you. For the benefit of time, we'll move on as well. And it's a pleasure to ask Yelena to come up and give her talk on liver or kidney transplantation in children with metabolic conditions. Thank you, Yelena. And thank you, George.
Thanks, Nikos, for the introduction. So in the next 20 or so minutes, I'll try and be slick to to allow for Professor Flint's time. We'll talk about the indications for liver and kidney transplantation in children, particularly focus on combined liver and kidney transplantation in patients who have metabolic conditions. I'll present one of the patients from the medical side, and I'll leave all the interesting surgical bits for the complex surgical session later this afternoon. But the main aim of this talk is really to show how can we play and win as a team, because we do not want to find ourselves in a situation when we have a lot of experts in the field and wonder how do we play and maybe win as a team. We want to be more be like an orchestra where we can think the same, breathe, and feel as one to deliver these complex transplants. So most of us in this room, and I know delegates online, can find ourselves with generation we belong here, but our patients are those ones coming from Generation Z, and now even more Generation Alpha. And these are some of the characteristics of our patients, so I think some of us need to catch up with them sooner rather than later. So in pediatric renal transplantation, the major advance 20, 30 years ago was that lung hypoplasia is not a problem anymore. In the past, children with congenital anomalies of kidneys and urinary tracts due to the pulmonary hypoplasia, secondary to oligohydramnios or anhydramnios, did not survive outside the neonatal period. But now it is not uncommon that a couple of months later after they birth, we get a phone call from the neonatologist and saying, well, they're off the ventilator, their lungs are actually fine, but the creatinine is 300. So Malcolm Coulthard, who's a consultant pediatric nephrologist from Newcastle, has actually warned us about this in his paper from 21 years ago now, when he was saying that the children who reach end-stage kidney disease in the first 2 years of life actually do not have that bad outcome, and they do survive. We made advances in infant dialysis. We can sort out the lack of the vascular access. That's one of Nikos's future talks. We talked a little bit about the previous symposium about the sensitization, but most importantly, there are new indications for kidney transplantation. Those are the children who have end-stage kidney disease since infancy, who might need multiple kidney transplants or multi-solid organ transplants. And all of that, we as a team have to deliver in the crucial time of their lives, in the childhood, because that is the time when we all grow, when we get educated, and when we actually form our social context. So quite an important period in our lives. This is a very old and very boring graph of the causes for the end-stage kidney disease. Of course, 40 to 50% will go into the congenital anomalies, but we are now starting to depict who are these others. And that includes some metabolic patients with methylmalonic acidemia or primary hyperoxaluria type 1, some of the complex ones, for example, children with Schimke's immunoosseous dysplasia. We've recently done one at Great Ormond Street Hospital, and colleagues at Stanford as well and Pittsburgh have done a couple of those as well. It is not uncommon that there are children who need multiple solid organ transplants and not only liver and kidney. So what would be the indications for liver and kidney transplant? Roughly speaking, they can be grouped into 3 groups. The first one are those children who have end-stage liver failure and then concomitant renal involvement, any conditions which lead to that. The second one, which I will focus on, is the isolated functional liver defect in systemic diseases. And the third and rarest one would be the secondary renal failure after the liver transplant. We might not see that now, but now when the liver surgeons are doing liver transplantation in much smaller children, it might be that even in the childhood, we will be seeing the children with chronic kidney disease secondary to CNI toxicity. This is a list of some of the conditions who would be part of the first group, some ciliopathies, recessive type of polycystic kidney disease, particularly the phenotypically aggressive one. This is the perinatal and neonatal onset, glomerulosclerosis, which gets associated with type 1A glycogen storage disorder, on MPGN, which we have seen with alpha-1 antitrypsin deficiency, children with Alagille syndrome, biliary atresia. Those children who have the metabolic condition, we often talk about primary hyperoxaluria type 1. And the usual, up until recently, recommendation was that the liver transplant should happen when the child is not below the CKD stage 3B in order to avoid the systemic oxalosis. The recommendations for pre and post-transplant continuous venous hemofiltration until we get below the saturation level of oxalate, which is less than 30 micromoles per liter. However, in some countries, since 2020, lumasiran has now been licensed as a drug, which reduces the oxalate production. We need to be aware that this drug is not available or licensed to be used in many other countries. The second one is the methylmalonic aciduria. Children with MMA have improved overall survival, so they are now coming as transplant candidates. Transplantation for these children is not curative, it's therapeutic. And there is still debate and uncertainty whether combined liver and kidney transplantation is favorable than sequential liver and kidney transplants. Those children who have GFR less than 50 at the time when they are assessed for any transplant are considered to be candidates for combined liver and kidney transplants. And this is the protocol from the Stanford, who has done the highest number of these patients. In the past, complement hemolytic uretic syndrome or atypical HS used to be an indication, but now with eculizumab is not. And as I said, in the third group, it's either hepatorenal syndrome or CNI nephrotoxicity. So what are the outcomes of liver and kidney transplantation in children? There are numerous reports in the last 10 years reporting on excellent patient survival and excellent liver and kidney allograft survival. And what all of these papers have commented on, and conclusion which we can draw, is that there is an immunological advantage of doing combined liver and kidney transplant or getting both organs from the same donor. Long-term survival of children who have combined solid organ transplants is similar to the isolated liver or kidney transplant as reported in the literature. No doubt, they come with surgical complexity, and with careful selection of patients, excellent outcomes can be achieved. These surgeries are rare. Worldwide, there's anywhere between 10 to 30 combined liver and kidney transplants in children. And more recently, we are starting to learn about the long-term renal outcome in the patients with MMA, which is now being reported in adolescents in the adults. So we expect in the next 1 or 2 decades to get a lot more information on these children. This graph is a paper from 10 years ago. The patient survival over 10 years, you can see the top line, which is the blue one, combined liver and kidney transplant, has an excellent patient survival, better than the liver or the transplant, isolated liver or kidney transplants. And the graph on the right shows the graft survival split for isolated liver and kidney, and also in those who had combined liver and kidney, and looking into the liver graft survival and kidney. So overall, looking very good. Now, the inborn errors of metabolism, or metabolic conditions as we call them, are rare. They are genetic conditions, and it is only that the increased awareness of the presentation of these conditions and improved diagnostics which have actually increased the incidence of these patients. They are the patients who have fragile health at all times. They can have rapid metabolic deterioration with any minor illness or any intervention, and that includes any surgery. Now think about the combined liver and kidney transplantation, complexity of that, and then add on top of that metabolic frailty. The decompensation can affect the liver, pancreas, and heart, and you can just imagine decompensation of these organs. Any one of them can lead to death. These children often have developmental delays and faltering growth. So for primary hyperoxaluria type 1, the enzyme deficiency is secondary to the genetic variant in the AGXT gene. That mutation leads to systemic oxalosis, which is basically a deposition of calcium oxalate crystals in organs and in tissues. Mainly affects the kidneys. And it's said that in the infant onset of this condition, 50% of children at the age of 15 will have end-stage kidney disease. Some of the phenotypes are successfully treated with pyridoxine replacement or an early liver transplantation. As I mentioned, lumasiran has been approved 3 years ago. However, in a lot of countries, it is not available. And therefore, if the patient has end-stage kidney disease, liver should be transplanted first and then a kidney, ideally after the 6 months. When I ask colleagues in France who have a huge experience in transplanting this patient, why 6 months? because we would anticipate that the child would be on dialysis between the liver transplant and the kidney transplant. It was anticipated that that would be the period which would allow sufficient oxalate excretion or removal through the hemodialysis when we have stopped actually the hyperproduction of the oxalate because we have given the healthy liver. If you are opting for the simultaneous liver and kidney transplant in these patients, which is organs coming from deceased donors, we do need to consider CVVH intraoperatively. In our center, in our experience, surgeries are done at King's, and we advise CVVH for 48 hours at least. Some centers continue CVVH for 1 week, such as colleagues in France. No doubt, all of these patients need personalized protocols, depending on the time that they've needed on dialysis and so on. So the outcome of the liver-only transplantation in inborn errors of metabolism is actually not that bad. This is in pediatric population, where we have a good patient survival at 10 years of 80% and allograft survival of 67%. And 20 years later, survival of the liver 70% is considered as an excellent outcome. The patients with MMA are slightly different. So this is a rare autosomal recessive disorder. And we must remember that liver is not the only one that makes the enzyme. About 18% of the MMA activity comes from the kidney. They present in infancy with metabolic acidosis, developmental delay, and failure to thrive. They are known to have renal diseases and also neurological complications, for example, the basal ganglia strokes. Prevalence of end-stage kidney disease can vary between 20 to 60% because it's a rare condition reported just coming through. So in the next decade or so, we'll probably learn more. Preemptive liver transplantation is the gold standard for these patients because it might prevent them from needing the kidney transplant later on. It does lead to 95% reduction in methylmalonic acid levels. An early combined liver and kidney transplantation is indicated in the presence of chronic kidney disease. We must remember that this is not a cure and it's only therapeutic treatment. So how do we choose whether a child with MMA will need a kidney or a liver or combined one? There are various transplantation options, and this needs to be patient-tailored and needs to fit in within the personalized medicine. So we are moving away from the isolated kidney transplantation for these children and would only consider these as patients who have limited life expectancy or limited quality of life. And we can debate for a long time what does the limited quality of life mean. Because remember, it's only 18% of the MMA that is made in the kidney. We still have the liver that makes majority of the enzyme. Isolated liver transplantation would be great for children who either present with progressive developmental delay, neurological deterioration, but have preserved kidney function because that might prevent them needing a kidney transplant in the future. Or combined liver and kidney transplantation if they present with a GFR which is less than 50. Now, what's really interesting is putting these children on a waiting list is very challenging, and as us and colleagues from Evelina know, the waiting times are long because they are not a priority. They have normal appearance of the liver and normal liver function tests. There's no portal hypertension, and therefore they are not priority when the organs are being allocated for the very good reasons. It's a complex management of the systemic disease. How can we protocolize this? And each child is with different ages, have different genotypes or phenotypes associated. So it's an individualized and personalized medicine that works for them. They have excellent outcomes. This was an old paper from 8 years ago, and the mean follow-up at that time was 3.5 years with an excellent patient survival and only one liver allograft lost due to the common or well-associated risk. We move on to the immunosuppression. How do we immunosuppress these children? It really is center-dependent. There is no consensus, and any one of these options can be recommended. We use basiliximab at induction, and then CNIs, tacrolimus, and MMF and prednisolone. In Germany and in France, for example, they use cyclosporin instead of the tacrolimus, MMF, and prednisolone. There was a trial which looked into the use of everolimus and low dose of CNI. The study was discontinued because of the high risk of PTLD and infections. This was probably the landmark paper which was published by the colleagues from the Stanford on the first 14 patients who have either had a liver or a liver kidney transplant. Out of the 14 children with MMA, they have had 8 children who had combined liver and kidney transplant. And if you only look into the age group, you will see that the children who had a liver transplant only were less than 2 years of age. Only one child was 3 years of age. And everybody else who had combined liver and kidney needed both organs. They measured the serum MMA levels 1 and 4 months post-transplant, and you can see significantly reduced and decreased in the levels in the children who had combined liver and kidney transplant. Looking into the neurological outcomes, those who had a liver transplant, 3 out of 5 gained some motor skills, and there were no neurological deteriorations, which was quite successful. And those who had a liver and kidney, so longer surgeries, longer general anesthetic, more complexities, they have maintained at least their previous level with no further neurological deterioration. And this is just a little bit in more detail, showing that there is a significant number of patients who have increased and gained their fine and gross motor skills after the transplant. So there is an overall patient benefit with decreased frequency of hospitalization, liberalization of diets, and weight gain. But what about improved quality of life? So this is the only one patient that I will present. Medical side of it, because it will be presented in more detail later on in a complex surgical session. This was a 4-year-old boy who was referred to us with genetically confirmed methylmalonic aciduria and Williams syndrome, and also had a single renal dysplasia, single kidney, which was dysplastic. He was referred to our London MMA transplant working group, and this really felt like trying to get the English football team to learn how to play as a team and win the World Cup. So we had all the experts that we could from about 4 hospitals. We had metabolic experts, endocrine experts, there was renal experts, renal transplant and hepatobiliary surgeons, 2 sets of anesthetists, cardiologists, radiologists, intensivists, clinical nurse specialists. We had 2 sets of coordinators, once for the liver transplantation, once for the kidney transplantation, 2 sets of dietitians to manage the renal end-stage disease and the metabolic ones, pharmacists, and of course, place specialists, social workers, and psychologists. We must never forget them because the support that these families need is humongous. There were 3 hospitals in London and 1 which was local. So in April 2021, this child had a combined liver and kidney transplant, deceased donor organs. His weight was 12.5 kilograms, and I believe today it remains the smallest child when it comes to the weight. I'll try to remember the height, Steve, of this child. But liver was implanted first, kidney followed. It was a 10-hour-long surgery. And remember, this is the patient with MMA. Any minor illness or any minor disturbance can actually make them crash. The way how we facilitated this 10-hour-long surgery is that the hepatobiliary anesthetist was on an open line with the metabolic team, and this was metabolic consultant. But we've done all of this, and then they couldn't close the abdomen. So you'll hear about that. So this is how the patient looked when it came to the PICU. This was a courtesy by the Nikos, I think. With all this surgery, the surgeons have managed to preserve the gastrostomy that the patient had. For me, this was unbelievable. He came to the ITU, he was intubated, ventilated. We did manage to achieve metabolic stability, but this child still remains at risk of basal ganglia stroke, even post-operatively. The immunosuppression, we debated, less for isolated liver, but then kidneys need more, and we managed to find some common ground. He had basiliximab, which was given after the liver was implanted, then steroids, MMF, and TAC. Fluid requirements, Nadine talked about how difficult it can be. We had here metabolic requirement, renal requirement, liver, and the endocrine, which inotrope to use. I left it all to the anesthetist. The liver team loves adrenaline. The renal transplant team hates adrenaline. So we've kind of went with hepatobiliary surgeons, and I won't talk more about that and use a bit of adrenaline. But when all these people gather, and everybody will come, because this doesn't happen every day, who leads the team? Because you can imagine the human factors, if we incorporate human factors here a little bit, this is a very stressful situation for every single health professional who was involved, every nurse, every coordinator, every consultant. And leading the team needs to be the intensivist because he needs to orchestrate nicely, all of us. I will not spend a lot of time on this. I've just put something on place which is widely accepted as a perioperative management for the isolated renal transplant and the one for the liver transplant. There are some similarities, but there are also big differences what they use. So we had to kind of join that together and come up with something which would keep the patient metabolically stable. So this is how the abdomen looked when Nikos finished implanting. You can see the healthy liver, which is on the in the right upper quadrant. There's some bowels in and omentum, and somewhere there, Nikos has managed to implant the kidney. This patient underwent 7 weeks later rectal muscle fascia implantation, and this is what his abdomen looked a couple of months after that with preserved gastrostomy. George has mentioned a little bit of the 3D printing. We use it now for the renovascular patients. So this is one of our renovascular patients. We have used it in the past, or led by the Guy's team, the 3D printing. But it doesn't work for deceased donor organs. When you're doing combined liver and kidney, you can prep the abdomen, but you don't know what is the size of the organs that you will get. And although I believe we agree that we will ask for the left lateral segment of the liver, hepatobiliary surgeon decided that the liver was very good. Let's just implant the left lateral segment. So the first 6 months, he was inpatient for 2 months and had 2 organs and 1 tissue transplanted. A lot more surgical details will follow. Good function of both allografts. He was maintained on tacrolimus and MMF. And 6 months after the transplant, when he was at home, he had some earache. So he was given amoxicillin. He then developed vomiting and diarrhea. So just remember, he's got a metabolic condition for about 3 days, and the emergency feeds that these patients usually get put on did not lead to any improvement. So he went to his local hospital with a creatinine of 310, previously based on about 60 to 70, and grossly elevated liver function test. So if you are a doctor seeing this patient in your A&E and you get these results, which team would you call first? Will you call the renal transplant team or the liver transplant team? Who would call liver people first? I'll call liver, right? Yeah. Whoever you call, if you have good communication between the teams, and planning of these transplants pre, intra, and post-operative takes a lot of months. So what you're dealing with is the sick metabolic patients with 2 transplanted organs, endocrine and metabolic conditions who's immunosuppressed. But the management for this patient is really the same. Is the airway, is the breathing and circulation, and D, don't ever forget the glucose. The IV fluids that you want to use for maintenance will require metabolic input. He was inpatient only for 1 week in his local hospital. And for the purposes of this talk, I calculated there were 28 healthcare professionals who were involved at any point during that week from 9 specialties in 4 hospitals between England and Wales. But he was made better because everybody worked as a team. So back in 2018, we contacted Stanford when we were discussing setting up a working group and actually giving these children an option to be assessed as transplant candidates. The reason why we asked the Stanford colleagues to come and talk to us about their experience is that we did not want to trip over the same rock because we knew that this will be a difficult road to go. We had many experts, so we were really lucky, but we had to build a team. We never ever doubted that we will have challenges, but it's very rewarding to see your patients getting better. There are still some things that we are asking ourselves. One is, how do we maintain the skills in managing complex patients with rare conditions? Should we actually do this for such small number of patients? But if they are surviving their initial conditions, why not? So in the last couple of minutes of this talk, some learning and recommendations, and this was recently published in Paediatric Nephrology, so I now formally and publicly thank Professor Joseph Flynn. We have published the protocol that we use for this patient, and it is based on the same principle. We hope that it can be applied to any other patients because it is very detailed in the preoperative, perioperative, and postoperative management. Very detailed planning is really important because if we don't do that, we will fail to plan. The metabolic stability before you go into the surgery and anesthetize patient is really, really important. Therefore, the involvement of the multidisciplinary team from the time of the transplant assessment onwards is really necessary. If the patient have metabolic instability, it should not undergo a surgery. You must not proceed with that. If there is a metabolic stability and we are waiting for the organs to come maybe from a distant part of the country, we agree that a 4-hourly blood gas check to ensure that that metabolic stability persists is really important. Availability of the senior metabolic, renal, and liver anesthetic teams is necessary for these patients, and obviously holistic approach for managing them. You won't be able to do this in a center which has experience in the MMA, because apart from maybe a couple of centers which have had some experience, there aren't centers. But if your surgeon, anesthetist, nephrologist, hepatologist are experienced in doing high complex cases, this might be a program. This might be a program that you might want to consider. There's nothing on the quality of life, these children. And if you look for the kidney only, quality of life in kidney-only transplant recipients, out of 366 studies, only 8 looked into the quality of life. So we have just completed 3 weeks ago in the UK a national study which was running over the past 2 years. It included 92 patients who had a multi-solid organ transplant during a 20-year period. And you can see vast majority are those who had liver and kidney, but good number of patients who had a heart and kidney transplant. And what we've added on is the quality of life in these patients. And to our knowledge, this will be the first published study which correlates the clinical outcomes with the quality of life in children who undergo this type of surgery. So to summarize, there is a change in indications for combined liver and kidney transplants in the childhood. Good clinical outcomes which are comparable to children with isolated liver or kidney transplant. It does take a village to raise a child, and it does take a multidisciplinary team to facilitate this transplantation. It remains a high-risk surgery for patients with inborn errors of metabolism, but it can be successfully achievable, and if done in the center's experience in doing complex surgeries. And it's personalized protocols that work the best for these patients. Thank you.
Very much, Jelena. Great talk and a lot of great work as well. Questions from the audience? Yes, thank you.
Hi, Ellen. Can I just ask, do you have any experience yet of working patients up who are on lumasiran for transplant? Because we have a patient in Glasgow who parents have essentially, a PH1 patient, sorry, who parents have kind of declined liver and they want to just continue with lumasiran, which makes me a little bit twitchy.
With the,
Sorry?
to continue with, sorry, I couldn't hear.
Lumasiran, sorry, for PH1. Have you, in Gosh or anyone else in the room, I guess, has anyone else?
Yeah.
I know there's been there's a French case series that was published of some patients that have.
Yes, we do have. We actually have a family who has 2 children, and the daughter, who is probably now about 13, had for PH1 had a liver transplant first, then the kidney, and now needed to have a second liver transplant. At the time when she was having her second liver transplant, her mother gave birth to a second child who had a PH1, and I believe it was the first neonate that William Van Hoff facilitated treatment with lumasiran. He must be now probably 4 years of age and is not coming up for transplant assessment. So that is the only one case that I can remember, but maybe Zainab and Steve can comment more if they have any more patients. But yeah, we have actually a family with 2 children who underwent different pathways.
Thank you. Thank you very much, Jelena. Oh, one more question, sorry.
Just in terms of workup for in terms of workup for a child with MMA, which GFR would you take? Because these children are really malnourished. So would you always do a formal EDTA GFR?
Yes, we do. And metabolic team, actually, they're part of their monitoring, at least at GOS, and I know at Evelina as well with Roshi there. They do annual GFRs, formal GFRs, and that's what we monitor for them. So never estimated. You're absolutely right.
Thank you. So it's a pleasure to ask Professor Joseph Flynn to come to the podium. Professor Flynn, he's a pediatric nephrologist, and he's a professor at the University of Washington School of Medicine, and he's a Division of Nephrology Chief at the Seattle Children's Hospital. He's also the Chief Editor of Pediatric Nephrology, past president of the American Pediatric Nephrology. I could go on forever,
No,
but
stop.
I will stop. And the first presentation of Professor Flynn is the role of ambulatory blood pressure monitoring in pediatric kidney transplantation. Thank you very much, Joseph.
Well, thank you for inviting me to be here. It's great to be here to see friends and meet new people and talk about a couple of my favorite things, blood pressure and ambulatory blood pressure monitoring, which, you know, there's going to be a little bit of overlap between my two talks, but I tried to make them different. So this talk will just focus on when do we use ambulatory blood pressure monitoring in pediatric kidney transplantation and how does it help us? And I guess before I start, how many of you are routinely doing ambulatory blood pressure monitoring following kidney transplant? So a minority of people. Okay, great. Well, hopefully I will convince you all to start doing it when you're at the end of the talk. So I'm going to talk a little bit about ABPM. I'm going to go through that very quickly because I assume most people know about it. Then how it's used to detect hypertension after transplant, the correlation between what we see in ambulatory monitoring and intermediate outcomes, and then how you can use it to manage patients. So start with a description of a patient. This is a 6-year-old boy who had gotten a living-related kidney transplant. He had ANCA-associated vasculitis for his cause of end-stage kidney disease. He came in for a routine checkup about 6 months after transplant. He had normal kidney function, which you can see there. He had been on some amlodipine already. And at the clinic visit, he had one blood pressure reading at the 95th percentile for his age. All of his other readings have been normal. So we did his ambulatory blood pressure study, and this is his study, which I know it's too small for you to see. So what it showed was, this is, remember, a 6-year-old boy. His mean awake blood pressure was 122/88, mean sleep blood pressure 112/74. His blood pressure loads were between 50 and 100%. He had blunted systolic blood pressure dipping. So how does that relate to, taking blood pressure? So we know that there are a lot of problems with taking office blood pressures, body position, activity level, room temperature. I think all of our blood pressures are probably 5 points lower right now because the room is so warm. Cuff size, what device, the oscillometric versus auscultatory. If you're listening to the blood pressure, do you have observer bias? I want the patient's blood pressure to be lower, or terminal digit preference. So we know that office blood pressure measurements have some inherent problems. Ambulatory blood pressure monitoring is a procedure in which the patient wears a device, takes the blood pressure at a regular interval over 24 hours, allows us to look at the patient's blood pressure outside the office during their usual activities. I had a patient the other day who said, I'm going to do some weightlifting today while I'm wearing your ABPM. Is that okay? I'm like, yes, as long as you put the monitor underneath you so the weights don't hit the monitor. It allows us to identify specific blood pressure phenotypes, which we'll talk about. We use it to confirm the diagnosis of hypertension. And we know that ambulatory monitoring results correlate with target organ effects of hypertension in both adults and in children. These are just some different devices that are out there on the market. They're small, they're relatively quiet. They take many measurements over 24 hours. Usually for us, if the patient is really good, we'll get 60 or more readings in 24 hours. And there's lots of different devices out there. The real benefits are that it overcomes the problems that I talked about with office blood pressure measurement. It's a machine. There's no terminal digit preference. There's no observer bias. It allows you to look at the patient's blood pressure pattern, identifying patterns like white coat hypertension, masked hypertension, and nocturnal hypertension. It gives us clues into detecting secondary causes of hypertension. And although we won't talk about it today, it allows us to evaluate the patient in a more cost-effective manner. So we talk about blood pressure phenotypes. I use that phrase frequently, and the phenotype is combining the office and the ambulatory blood pressure. And so you can see in the grid there that depending upon whether the office or ambulatory blood pressure is normal or elevated, you have 4 different phenotypes ranging from normotensive to ambulatory or sustained hypertensive, white coat hypertensive, or masked hypertensive. Okay, now, when is it endorsed? So in the American Academy of Pediatrics guideline, we endorse using ambulatory monitoring in a variety of circumstances, including confirming the diagnosis of office hypertension and ruling out white coat hypertension, to evaluate blood pressure patterns in patients who have high-risk conditions, and all solid organ transplant patients fall into that category of being candidates for ABPM. And then to assess how well the patient is treated. And this is particularly important in kidney transplant patients after they've been diagnosed with hypertension and started on therapy. Now, people have looked at ambulatory monitoring in transplant for many years. This is an old study by my friend John Soroff, but it's very illustrative of what you see. So they looked at 42 children at where he was at that point in Texas, and they showed that the blood pressure loads were high for both systolic and diastolic blood pressure, that they were much higher compared to control subjects, and that many of these patients had non-dipping. Dipping is how far the blood pressure drops during sleep, should be at least 10%, but they found that 80% did not have nocturnal dipping for systolic blood pressure and half for diastolic blood pressure, and they actually saw reversed dipping in several patients where the sleep blood pressure was higher than the wake blood pressure. And so then when you look at many studies have been done since then, you come up with a table like this that I published in an editorial a few years ago, which goes over multiple studies that have been done up to that point. It's a little old now. I have to update it. But just to show you a few points on this table, that if you look at the percentage of patients who were hypertensive by ambulatory monitoring, it ranges from about 25% to almost 90%. So that ambulatory monitoring is picking up a large number of patients with hypertension. And then when you look at how many of those actually had masked hypertension, okay, where the office blood pressure is normal, but when you look at the 24-hour study, that's abnormal. The studies that reported it reported that between 20 and 70% of their patients who were hypertensive by ABPM, it was masked hypertension. So you would not pick up the hypertension in those patients without doing ambulatory blood pressure monitoring. And then this is a more recent paper, which was a study from the Pediatric Nephrology Research Consortium in the US, 6 centers combined, where they looked at how these patients were classified by ambulatory monitoring. And basically you can see that almost none of them, I guess I don't really have a pointer. Oh, I do. Almost none of them had white coat hypertension, 1%. 25% of them had mast hypertension. And then many of them had ambulatory hypertension, and all of these unclassified patients, which was because of the prior AHA classification, which was a mess, which we have fixed. And then many of them here, if you look at their blood pressure load, half were normal, but again, a huge percentage had mast hypertension. Now, it's done in adults as well. And this was a very interesting study done in New Zealand, where they said, well, let's look at ambulatory monitoring in our transplant patients and see what it tells us. And they actually found that patients whose blood pressures were, whose office blood pressure, this is not without blood pressure, but with office blood pressure at target, 75% of them had abnormal ambulatory blood pressure monitoring, and that 1/3 of them had mast hypertension. That of these with mast hypertension, this 58%, 1/3 of those had isolated nocturnal hypertension, which again is something we see very commonly on ambulatory monitoring. And when they looked at ABPM and used the results to manage the patients, 40% of their patients had a change in management based on the ambulatory blood pressure study result. And we see that in children as well. Now, here is again some data from the group. I think this is the same. No, this is from this is a single center study, I think, from Cincinnati, where they looked at blood pressure status in their transplant patients and looked at ABPM blood pressure phenotype and then kidney function. And what they saw was that, just looking at the bottom here, is that this group in the center who have mast hypertension had lower GFR no matter what equation you wanted to use to estimate their GFR. They went through like 5 different equations, but all of them were lower in the mast hypertensive group than in the normal blood pressure group. And in the sustained hypertension group, was even lower, which they didn't do any statistics because they had such a small number of patients with ambulatory hypertension. So showing that in patients who have mast hypertension on ABPM, they actually have impaired kidney function compared to patients whose blood pressure is normal on ABPM. And so then what can you do and how can you use it? How does it help you? So this is a study that was done in the Czech Republic, where they looked at how they were able to, what was the change in the patient's blood pressure over time using sequential ABPM and then adjusting therapy based on the results of the ambulatory blood pressure study. And what they showed was that they actually didn't see much of a change in their daytime blood pressure here on the left-hand set of bars. And then, but they did see some decrease in the daytime diastolic blood pressure over time. But most importantly, they saw improvement in the nighttime blood pressure over time. And what that then enables you to do, because many of these patients actually have masked hypertension on the basis of their sleep blood pressure, is that fewer of them have hypertension over time if you're then using the ambulatory blood pressure study to modify their therapy. And they showed that as you looked at their blood pressure over time and you looked at their kidney function, those who had, those whose blood pressure remained normotensive over time had better kidney function than those whose blood pressures were hypertensive over time. So again, showing that effect of hypertension by ABPM on kidney function in kidney transplant patients. Now, there are other studies that have looked at other ways in which you can use ambulatory blood pressure monitoring to manage patients and improve outcomes. This is actually the study for which I wrote the editorial where I made that table, where this was a study done, I think, in Italy, where they looked at just a small number of kidney transplant patients who had very careful assessment for intermediate markers of cardiovascular disease. So they had ambulatory blood pressure monitoring done. They had carotid ultrasound done to look at the carotid intermedial thickness, and they had echocardiograms done to look at LV mass. They had a control group who just had carotid ultrasounds done. So they did ABPM annually, and every year they would look at the ABPM results and they would adjust the treatment based on the ambulatory blood pressure monitoring results. And these were initially young patients, but they then got to be quite older, so some of them had to be switched to adult criteria because they actually then studied them 9 years later after doing this for 9 years. And they looked at their blood pressure status, their carotid intermediate thickness, and then their LV mass 9 years after using this ABPM guided therapy. And what they showed, which I know it's too small to tell on this, but they actually showed that the CIMT was higher than the control group at baseline, so here, but on follow-up after using ABPM guided management, they actually had a decrease in the carotid intermediate thickness, which was statistically significant and then equal to those patients, the younger patients' baseline carotid intermediate thickness. And they also showed that they had a decrease in their LV mass index at the last ultrasound, and the number with LV hypertrophy had decreased from 6 out of 22 to 1 out of 22. So they had a decrease in the prevalence of LVH. And the same thing was seen recently in a study from the 4C group, where they looked at kidney transplant patients in the 4C study, and they looked at just about 3 years of follow-up, and they did something really interesting. They looked at blood pressure under the curve, and they used and they calculated that for systolic and diastolic blood pressure, and they also have been doing ABPM guided management of their patients. And what they showed was that blood pressure that was continuously below the 60th percentile was associated with a decrease in LV mass index and a reduced proportion with left ventricular hypertrophy, very similar to the Italian study from 10 years ago. And this is where they showed that the blood pressure percentile had those who had LVH, more of them had blood pressure in the 90th percentile in the red compared to those without LVH over time, where it was 43% versus 15%, and then 21% versus 2% for diastolic blood pressure. Now, there is one study done in the Czech Republic where they looked at sort of mimicking ESCAPE for transplant patients, where they looked at standard control of blood pressure versus intensified control of blood pressure. And they actually saw not much of a difference between those two groups. I'm going to actually talk more about this study in the next talk. And then the other thing that's interesting to think about is, should we use chronotherapy? These patients have nocturnal hypertension. So the question then becomes, should we be dosing their antihypertensive medications at nighttime? Or should we be giving them an extra dose of something at night? And what's really interesting about this is, I'm going to talk about the one pediatric study that is published, which I was a reviewer for and wrote an editorial about. Because what was very interesting is that this has never been done in the adult transplant literature. Okay, this was never done. But there was a small pediatric study, and I'm just going to summarize this slide by saying it didn't help. They converted patients from non-dipping to dipping, but had no effect on the outcomes they looked at. And I'm going to show you a little bit more detail in the other talk. So, sort of putting this together, we know that post-transplant hypertension is common. We know that it's very frequently detectable by ambulatory blood pressure monitoring, that the value of ABPM is that it detects these circadian blood pressure abnormalities like blunted and reverse dipping, isolated nocturnal hypertension. We know that the target organ effects of hypertension correlate with ABPM findings, and these things include reduced kidney function and left ventricular hypertrophy, and that ABPM-guided treatment can improve some of these intermediate markers of cardiovascular risk. Now, here's my patient. I actually got to see him again 11 years later. He still has his mother's kidney, or his aunt's, I think it's his aunt's kidney. Yeah, his mother is a nephrologist. His mother's a nephrologist. This was a very stressful transplant. So they showed up at my clinic 11 years later, because he'd been bouncing around for other people. Still has a decent level of kidney function. Home blood pressure is good. And now this is his ambulatory blood pressure. I swear this is the same patient. I am not making this up. So 11 years later, he was switched to candesartan. And I'm going to talk about that in the next talk. And he has great ambulatory blood pressure and office blood pressure and stable kidney function. And so he's a success story. Oh, I just made it a little bit bigger there, but you can see a nice ABPM, and you can see we changed software programs. And thank you for your attention.
Thank you very much. That was an excellent talk. Any questions? I'm sure there would be a few.
There you go, Manish.
So, Joseph, thank you for a very nice talk. So, I'm sure you get asked this all the time. So, what should be our target for the blood pressure for these patients? Should we go by?
I'm going to talk about that in the next talk.
Okay.
So I'll ask you two very quick questions. One,
I know it's a little hard. I mean, I offered 2 talks, but they're so intertwined. It could have been one 90-minute talk, but that would have been way too much to ask you to sit through. Yeah, Steve.
I was going to ask you 2 very quick questions.
Yeah.
One, do you remove those episodes when patients are doing exercise or do you include them in your overall data? Do you want to answer that?
Yeah,
first?
well, it's a good question because the reason to do ABPM is to capture their blood pressure on a usual day, right? So if that kid who I saw on the other day, on Thursday, is weightlifting, every day, then we should know what that does to his blood pressure.
And then my second one is, should we stop measuring blood pressure in hospital? Should we not just use home blood pressure and ambulatory blood pressure monitoring?
If you're asking me whether blood pressures obtained in the inpatient setting are useful, I will tell you they are not. And that oftentimes in the clinic, they're not useful either. Except probably in Manisha's hypertension clinic and our hypertension clinic, where we actually are paying attention to it. Yeah.
Thank you. Excellent.
Thank you. So we'll move on to the next talk, which is actually the plenary lecture. And that's titled Epidemiology, Pathophysiology, and Treatment of Post-Transplant Hypertension. Looking forward to that. Thank you.
Okay. Great. All right. Oh, this one I did the whole fancy thing, no disclosures. But I will be discussing off-label use of blood pressure medicines. Okay, so for this talk, we're going to try to hit actually 4 areas, not just the 3 that are in the advertised title, because I can't not talk about the impact of post-transplant hypertension on the allograft, and then pathophysiology, and then treatment. So prevalence, how frequent is it? Well, I'm actually going to start with a slide about adults, because I think it's useful sometimes to think about that, and we take care of a lot of, well, maybe you all don't. You transition your patients at what, 16, 17? Yeah, we keep our patients until 21 at a minimum. But anyway, we see a lot of young adults, but sometimes it's good to know what our patients sort of look like when they get older, and what our patients look like when they get older, or what adult transplant patients look like, is that they're all hypertensive. All of them, basically. So I highlighted here the different studies. The ones where the prevalence is lower were old, and the more recent ones where the prevalence is 60 to 90% are current. And so it's sort of bleak. Well, in children, it's not much different. And I don't need to tell this audience how frequent it is. So we're going to start with just the overall kidney replacement therapy population. Because I really like this study where they looked at children in Europe who were getting hemodialysis, peritoneal dialysis, and who had received a kidney transplant. Because remember, those are the 3 possible therapies for kidney failure. And when they looked at just what the blood pressure distribution is, okay? So these graphs show the blood pressure distribution. I'll make this a little bit bigger for you to see. And just talking about the transplant patients, so about 30% of transplant patients overall had blood pressures, these are measured blood pressures that are 90th percentile or higher. And then when you look at in the middle group of bars, those who are on blood pressure medicines, it's about 40% of transplant patients on blood pressure medicines have measured blood pressure above the 90th percentile. And then when you look at those not on blood pressure medicines, about 15% of them, 15 to 20% of them have blood pressures above the 90th percentile. So just like in every other stage of chronic kidney disease, post-transplant patients frequently have high blood pressure, and frequently it's not detected, and frequently it's still high even when it's being treated. And I'm going to then talk about Dr. Sinha's study, because he's sitting right in front of me, that looked at the United Kingdom experience. And so this was a really neat paper to read. I wonder how many miles you put on your Mini Cooper, because they went actually to visit all the centers. Probably all of you had Manish or his team visit you. This is great, I thought. And a great way to make sure you're getting complete data, no doubt. So they looked at the blood pressures retrospectively 6 months, 1 year, and 5 years after kidney transplant. And on average, about 27% were hypertensive at each time point. And it really wasn't any different between 6 months and 5 years. Maybe slightly different, but it was really about the same. And if you then, and those were, I think, the measured blood pressure, right? And so then when you added in those who are being treated for hypertension, it was close to 50 to 60% were actually could be diagnosed as hypertensive. The antihypertensive medication use actually decreased over time, which I thought was odd, because a third of those on medication were still hypertensive. And then there was a big center effect, which basically for those young people in the audience, it means that there was a lot of variability between centers, which actually impacted their statistical results and had to be accounted for using some fancy funnel plot things, which I don't really understand very well. But when you're doing a multi-center study and there's a lot of variability between centers, that can actually have an effect on your results. Okay, back to the present. And so here's some data from their paper, and just to show you a couple things where what were the factors that they found that were associated with hypertension. So short height, which I imagine is because the high blood pressures weren't being recognized in the shorter children, something which we've just published out of the CKID cohort, actually. And then donor source, where deceased donor patients were more likely to have hypertension compared to living donor patients. Most likely, I would assume, as we'll talk about in a little bit, this is related to different immunosuppression, probably higher doses of calcineurin inhibitors and corticosteroids. And then this is a graph where they looked at blood pressure z-scores at the 4 different time points after transplant, with the black part of each bar being those not receiving blood pressure medications, and the gray bars, no, black on medicine, gray off medicine. And just showing that there is this pesky group whose blood pressure is above the 95th percentile at every time point. And actually, I would say you have two pesky groups, because those above the 90th percentile is probably not good for them either. So that you actually have, a big number of patients at every time point who have abnormal blood pressure. Okay. What about other places? So this is a more recent paper from the CERTAIN registry, which is a registry study in Europe. I don't know a lot about it, but this is a really nice, they published recently a paper about their experience, and they looked at blood pressures after transplant. And again, just to show you that even at 3 years after transplant, they had only Actually, I should have just circled the bottom part, because the bottom part, the bottom 23% not in the circle are the ones with normal blood pressure. And so what they're showing you is that 70% of their patients in their registry have hypertension at 3 years after transplant. And then if you look at some American data, this is from the North American Pediatric Renal Trials and Collaborative Studies Registry from 10 years ago now, because I haven't published anything recently, even though I keep asking them to. And this is just different medication use after transplant, which is interesting to look at. So antihypertensives in deceased donor transplants is the highest, right? The most frequent. And then right underneath that are antihypertensive medications in living donor recipients. You can see 60% in the living donor recipient group, even out to 5 years after transplant, and about 70% in the deceased donor group, even 5 years after transplant. These are unpublished data. Don't tweet this slide, from our Improving Renal Outcomes collaborative registry, where we looked at blood pressure control status after transplant. And you can see it's divided up into those with normal measured blood pressure, those with abnormal measured blood pressure, those on medications, and those off medications. And what we've outlined in the yellow are all of those you would say have hypertension. It's about 56% are on blood pressure meds or have uncontrolled blood pressure in the IROC registry. And then one interesting thing to think about are the normative data you're using to classify patients as hypertensive. So again, this is an analysis, unpublished analysis from the IROC registry, where we compared using the prior normative data from the fourth report that are being carried forward in the ESH guideline for some unfathomable reason, versus the updated normative data in the 2017 AAP guideline. And you can see that actually fewer patients are classified as normotensive and more patients are classified as hypertensive. And this is because of the lower normative blood pressures in the 2017 AAP guideline compared to the old guideline. All right, and then so that all of those data are really based on office blood pressure measurements. So and then I've already showed you this, slide from the prior talk about it being even more frequent based on ambulatory blood pressure, and many of them have masked hypertension based on abnormal nocturnal blood pressure. Fine, so this is a common problem no matter how you measure the blood pressure. What is it doing to the kidney transplant itself? Well, it's doing a lot of bad things. So here is, again, that study I showed you earlier, where we looked at blood pressure phenotype and kidney function, and we showed you that those who have masked or sustained hypertension have reduced GFR compared to those with normal blood pressure on ambulatory blood pressure monitoring. So kidney function is worse. And then again, from the Czech Republic, showing you that those who have hypertension over time have worse kidney function compared to those with normal blood pressure. And then what about other aspects of things we look at after kidney transplant? We look at kidney function, of course. We look at graft survival, which I'll get to. But how about some other markers of cardiovascular risk? Because it's more, we have to think about these things as well. Because we know that the number one cause of death in our patients is going to be heart attacks and strokes. They don't die from their kidney failure. They die from cardiovascular disease. So it's very important to think about these intermediate markers of cardiovascular risk. So this was a old study, but very important, I think, because it looked at LVH post-transplant and how it changes over time. And so this was a retrospective single-center study, again from Cincinnati, where they looked at echocardiograms about 1 year, 3 years, and 4 years after transplant. And what they found is that many of these patients had LVH initially. It actually tended to persist, but it got less severe. And they showed that systolic blood pressure was an independent predictor of LV mass. And just looking at their echo data, so here they're showing that LV mass did decrease over time. That's in here, but the percent with LVH stayed the same. And remember, this is from almost 20 years ago now. So these would have been patients, and these were patients with up over 5 years of follow-up. So these would have been patients transplanted in the around 2000 or earlier, before there was widespread use of ABPM. And then this is their LV mass index over time, showing you that it did tend to decrease over time, probably with treatment of hypertension. But they didn't really talk about that in that paper. Here's a more recent paper where they did look at that. So this, again, is the 6-center study from the Pediatric Nephrology Research Consortium in the US, where they looked at LV hypertrophy and kidney function according to blood pressure treatment. And what they showed for both blood pressure, LV mass, and GFR was that those who had hypertension off medication, that there was worse LVH based upon if they had higher blood pressure, whether they were on or off blood pressure medications, and that kidney function was worse in those who had higher blood pressure, masked or sustained hypertension, compared to those with normal blood pressure. And this was a very recent study, recent paper we published in the journal that I thought was really interesting because they looked at vascular stiffness. Now, vascular stiffness is a very interesting problem because I think that it's one of the initiating factors in target organ damage. And we've shown some work in non-transplant patients from our Schipholhoit cohort that patients with increased vascular stiffness tend to have more target organ damage like LV hypertrophy and even changes in cognition, although that's not published yet. Anyway, this is, again, a European study where they looked at vascular stiffness and blood pressure evolution and what happened over time. And what they showed was that if the blood pressure goes up over time, the vessels get much stiffer over time, which is likely one of the things that then leads to LV hypertrophy, which leads to graft damage. And so it's very interesting, and I think requires a lot more study. Okay, how about allograft survival? Well, again, I'll start with an old paper, which I think is a very important paper because it actually sort of predicts what is to come. And so this was a retrospective study from Cincinnati of patients, a 20-year cohort of kidney transplant patients where they looked at those who had hypertension and those who did not. And they showed that hypertensive recipients had much worse long-term graft survival compared to normotensive recipients, that they had, those who had systolic hypertension had more graft failure regardless of any other problem. It was an independent predictor of graft loss. And that, right, independently predicted graft loss. And then if you look at what they did in these two graphs was divide the patients into those with and without hypertension, and they looked at graft survival over time. And the dashes don't show very well, but the bottom lines on each graph are those whose blood pressure is above the 95th percentile, and you can see how much more graft loss there was compared to those whose blood pressures were below the 95th percentile. And then this is a fast forward to only 10 years ago. This is a study from Minnesota, where they, University of Minnesota, where they did sort of the same thing. They looked at, well, actually, what they looked at was antihypertensive medication treatment. But so those who are hypertensive, which are in the dashed lines, and these lines you can see better, also had poorer graft survival over time, up to 20-year follow-up, compared to those who were not on blood pressure medication. And this was true for their overall cohort, for their living donor cohort. Not as great an effect for the deceased donor patients. So it's not good for your allograft. Now, why do we have this problem? Here we go. For the rest of the talk, I could again keep you here for the rest of the day, but I promise not to. But I like this cartoon because it really sort of puts things into context and categorizes them. And we know that there are multiple factors that can lead to hypertension in these patients. So things like how well the kidney is working, the immunosuppression, and so all of these things on this side are the immunologic factors, but there's lots of non-immunologic factors. Things like what happened with the surgery? Did they get 20 liters of fluid, which is always obviously going to affect their blood pressure in the immediate post-transplant period? Did the surgeon do a good job in anastomosing the kidney artery, or is there transplant renal artery stenosis? And then things like the donor, did dad who donated the kidney to his daughter actually have masked hypertension, and that now his daughter has the same problem that she inherited from her dad's kidney? And then did the recipient have hypertension or other problems that lead to hypertension? So a lot of different factors can actually sort of come together to lead to hypertension in the recipient. Now, this table sort of divides things up in a little bit different way, from recipient factors, donor factors, to transplant specific factors. And I'm going to focus for a minute on the medicines, because I think it's important to understand the effect of the medications on blood pressure in our patients. So starting with corticosteroids, are you all using steroid free, or does your protocol include steroids? Free. Every patient, even high risk? Okay. Interesting. Okay. So we know that glucocorticoids are associated with post-transplant hypertension. There are many different mechanisms, all obviously the same mechanisms that make any patient treated with corticosteroids have hypertension: activation of the mineralocorticoid receptor, activation of glucocorticoid receptors on smooth muscle cells, and I think activation of the renin-angiotensin-aldosterone system. We know that it's dose dependent, because in adults, less than 10 milligrams a day of prednisone doesn't cause hypertension. And we know that patients on alternate day prednisone have less problems with hypertension than patients on daily prednisone. This was a study where they looked at steroid avoidance and incidence of hypertension, and they showed that those who were steroid-free had much less hypertension at different time points compared to those who had steroid-based regimens. This is their preliminary paper. They actually ended up, I think, publishing this paper and then abandoning steroid-free immunosuppression because of risks of rejection. Although we still do steroid-free immunosuppression in Seattle for our low-risk recipients. Our high-risk recipients get steroids. Now here's another study from the Pediatric Nephrology Research Consortium where they looked at cardiovascular risk factors in patients, and they compared those transplanted under steroid avoidance protocols compared to steroid-based protocols. And what they showed was that both systolic and diastolic blood pressure were lower in the steroid-avoiding group, and that the number of antihypertensive medications were lower in the steroid-avoiding group. And here is just showing you the blood pressures, so that even out to 3 years post-transplant, the steroid-avoiding group had lower systolic blood pressure and lower diastolic blood pressure compared to those who were transplanted under steroid-based regimens. Now, how about calcineurin inhibitors? Well, first, I want to shatter a myth. The myth that tacrolimus doesn't cause hypertension is not true, okay? If anybody walked into this room thinking that, don't you dare walk out thinking that, okay? Because it has the same. This is a study done in I think a study in children looking at, could be adults, I forget, I apologize. Looking at rates of hypertension based on whether or not they were on tacro or cyclosporin. And cyclosporin's a little bit higher in the green for both diagnosis of hypertension or on more than 2 antihypertensive medications, but it's not very much different, okay? And then I was really happy to see this paper come out last year, which is a meta-analysis of calcineurin inhibitors and multiple complications after transplant, and just focusing on post-transplant hypertension. All of these bars are crossing the center line in the meta-analysis, and there was basically no difference in rates of hypertension in those receiving tacrolimus compared to those receiving cyclosporin. So does anybody now believe that there's a difference? Okay, good. Now, why does this happen? And why is it the same between the two? And the reason why it's the same between the two drugs is because of all of the things that calcineurin inhibitors are doing that are non-immunosuppressive, okay? So we know that they cause, vasoconstriction, they lead to sodium retention, they activate intrarenal renin expression, they increase the expression of endothelin, which is the most potent vasoconstrictor our body makes. They also interfere with production of nitric oxide, which is an important vasodilator. They lead to decreased synthesis of prostacyclin and increased production of thromboxane B, which is, and you can see there, vasodilator versus vasoconstriction. They increase sympathetic nerve activity, and when you're on them for a long time, they cause graft fibrosis. And I should have put chronic CNI because tacrolimus causes the same interstitial fibrosis and vascular lesions as cyclosporin. So this is from 2001, but you know what? It is exactly what happens. And we've known this for a long time. And so this is a nice cartoon, actually from a paper about heart transplants. But this was a really nice description of how actually calcineurin inhibitors impact multiple pathways, including renin-angiotensin system, sympathetic nervous system, endothelin, nitric oxide, causing vasoconstriction, affecting tubular function, infecting all these different, transporters in the distal tubule, leading to retention of sodium and hypertension. So multiple mechanisms by which these drugs cause hypertension. Now, other things just to mention that are also relate to causes of hypertension, we have to talk about allograft things like obstruction of the ureter, rejection, ischemia, reperfusion injury, transplant kidney artery stenosis, and the long term things like chronic allograft nephropathy, recurrent disease, de novo glomerulonephritis, donor vascular disease, and then, I guess, transplant renal artery stenosis. So we know it's common. We know what it does to the allograft. We know why it happens. How do we treat this thing? There's just like a hydra, right? It has so many different things to go after. So first of all, we can look at how to modify some of the things going on in the kidney. And so starting with calcium channel blockade. So calcium channel blockade, we know that systemically they lead to relaxation of vascular smooth muscle cells. Well, in the kidney, they actually help modify that calcineurin inhibitor glomerular, afferent glomerular arteriolar vasoconstriction. And when you look at the effects of calcium channel blockers in adults, because we don't have data in children, treating patients with these drugs reduces graft loss, improves GFR, and reverses LVH. And for that reason, we've, for many, in many regimens, they're felt to be first-line agents. We know there are problems with lower extremity edema if you put them at 10 milligrams of that amlodipine. And we know that if you give them with cyclosporin, it'll make their gums look bad. But otherwise, they have very many good effects. One thing just to remember, I'm sure you all know this from working with your intensivists, is that nicardipine will muck up your tacrolimus levels. And our kidney transplant patients are the one patient group we don't use nicardipine in after transplant because we start our tacro on day one. I don't know what you do. And then long term, you have to worry about diltiazem and verapamil if you're using them. But most of the other calcium channel blockers don't affect your levels. Again, it should be CNI levels. Why? I look at these slides 10 times and I didn't fix them. I apologize. What about RAS blockers? What might make us think about using them in a kidney transplant patient? So we know that in general, they lower proteinuria. They do that because they reduce the interglomerular capillary pressure. We know that they lower hematocrit, which can be good in these patients. We know they're cardioprotective. They have somewhat of a potassium problem in some patients. They can increase the creatinine. They can lower the hematocrit. And then we know that ACE inhibitors can lead to cough and angioedema. So we know those things about these drugs. But what about in transplant patients? What happens if you treat transplant patients with these drugs? So it helps. And so I'm going to couple adult studies that looked at use of ARBs specifically. So this was ARBs and ACEs in the next one. So this was a retrospective analysis of use of losartan in about 300 transplant patients when patients were on losartan, they had lower blood pressure, and the decrease in GFR over time, which is naturally seen following transplant in adults, was slowed. And they did that by plotting 1 over serum creatinine, which many of us used to do in the old days before we could actually estimate GFR. They had reduced proteinuria, and they didn't really see any bad effects. They didn't really see problems with potassium or uric acid or hematocrit. Now, this study is comes from the Wisconsin Allograft Recipient Database, so it's really big. 2,700 adult transplant patients, and they were able to pull out 400 of them who were on RAS blockade compared to about 2,300 who had not. And they showed a reduced hazard ratio for graft loss of 0.6, 0.7 for death. Okay? Death was less common in patients treated with RAS blockade for both total graft loss and death-censored graft failure. That's huge, right? And of course, it was better in those with proteinuria, more benefit in those with proteinuria. They did see some hyperkalemia. Now, and then what about kids? So this is Blanche Shaver's paper from Minnesota that I showed you earlier. And so they showed that patients who were on treatment for hypertension had worse outcomes. But then they looked at the class of antihypertensives they were getting. And guess what this dotted line is? ACEs and ARBs. ACE or ARBs had better graft outcome compared to not being on an ACE or ARB. So you can almost say that all of their graft loss in their patients with hypertension was in patients not treated with an ACE or an ARB. So think about that for a minute. Not only should these things be in the water, they should be there should be a poly pill for transplant patients with these drugs. Okay, and why is this so beneficial? This is sort of putting this together a little bit, but as I was talking about earlier, which a lot of it is related to intraglomerular hemodynamics and how the effects of calcium channel blockade and ACE inhibitors counteract the effects of calcineurin inhibitors. Okay, now you want to know about blood pressure. Oh, and then, of course, a lot of patients do need combination drugs because it can be, these patients can have quite severe hypertension because, you know, they come to transplant already having been hypertensive or already having been on dialysis. They don't have normal blood vessels. So it's hard to actually effectively treat their blood pressure. So just like treating any other patient with complicated hypertension, you may need to use combination therapy. All right, what about treatment goal? I was asked about this by my friend there. So I went to look at guidelines for treatment goals. And so KDIGO in its transplant guideline actually had a goal, which I was really surprised. And they had a goal for children. They said less than 90th percentile if less than 18, which is based on office blood pressure measurement. And then they say for use any class of drug, but if there's proteinuria, can use an ACE or an ARB. So that's 10 years ago or 14 years ago now, but they haven't updated it. It's the only transplant guideline KDIGO has done. How about the European Society of Hypertension? What do they say? So this is a pediatric guideline. So they recommend calcium channel blockers as the initial drug, but they have no other specific treatment recommendation in terms of a goal. So you would assume that the CKD goal would apply, because by definition, all of these patients in our transplant clinics have CKD. So that's what you would assume. About my guideline. Well, guess what? We didn't really talk about transplant patients either. But so therefore, our general goal of less than 90th percentile would apply. But then, we looked at the ESCAPE data and we endorsed the ESCAPE goal for transplant for CKD patients in the AAP guideline. But when we were talking about this in IROC and trying the Improving Renal Outcomes Collaborative and trying to decide what goal we were going to use for controlled hypertension based on ABPM, there was a lot of unhappiness with 50th percentile of MAP because people are concerned about hypotension, particularly overnight in these patients. So our consensus was 75th percentile on 24-hour MAP. So I don't know if that answers your question, but that was, and I think that's still reasonable. But we need a study, basically. And then this is the study I talked about, well, if we did an ESCAPE trial-like study in transplant patients, would that help? So in this study, they randomized a small number, and this is probably one of the problems with this study, is it's way too small, of transplant patients to strict blood pressure control versus usual control, so less than 50th percentile or less than 90th percentile on ABPM. They had ABPM every 6 months. These kids must be angels. None of my patients will do it every 6 months. They were all on ramipril, and then they added amlodipine if they had proteinuria, and then amlodipine, then ramipril if there was no proteinuria. They only got to their target in about two-thirds of the intensified control group. But there was no effect on primary outcomes, no difference in proteinuria, no difference in rate of eGFR decline, and one might almost say that it was detrimental to the allograft, because look at how quickly the GFR dropped in that first year in the intensified blood pressure control group. So it makes you wonder whether that is actually a good thing to do or not. Okay, let's talk about chronotherapy again. So this is, as we've talked about, nocturnal hypertension is frequent, blunted dipping, they all have it. And in the general population, this is not good for you. In adults, we know that non-dipping and nocturnal hypertension is associated with increased rates of stroke and death and bad things like that. And in the general hypertension literature, this is very controversial as to whether to use chronotherapy. There's one group from Spain that says it helps. Everybody else thinks that that group is crazy or falsified their data. Okay, this is serious. And so it's very controversial. And if you look at adult kidney transplant patients, it has never been studied. There was one pediatric study, so pediatricians leading the way, although I'm not quite sure to where. This was a small study at 2 centers where they screened all of their patients for non-dipping, and so 60% of them had non-dipping, no surprise. And so they randomized them to an extra blood pressure medicine at bedtime, in addition to whatever else they were taking. And I think they used short-acting medications like enalapril and isradipine. I'm pretty sure it was enalapril and isradipine. So they gave them an extra dose. And what happened? Well, yeah, they got them to dip, but there was no effect on their outcomes of interest. And so this I pulled out of their table because their table is just unmanageable. and they didn't have any nice figures in the paper. But so here is the data. So in these columns are where the patients were at baseline. And then here is their data follow-up at 6 months. And so you can see in the intervention group, they went from all non-dipping to only 47% non-dipping. So they got a lot of them to dip. But they still had a lot with nocturnal hypertension, and maybe this was the problem. Their LV mass didn't really change, 49 to 45. The percentage with LVH didn't really change, 35 to 33. And then their pulse wave velocity, because they looked at that as well, didn't change. And so although they got the patients to drop their blood pressure, they didn't see any benefit. And I had real ethical problems when I reviewed this manuscript, because I don't think giving an Alpro at bedtime is healthy for a kidney transplant patient, because they don't drink always overnight, and you're potentially really dropping their blood pressure quite low. And so I personally don't think this should be done. What I really think we need to do is use the ambulatory blood pressure study and modify their overall antihypertensive therapy. So if they're hypertensive overnight, then they need a higher dose of their angiotensin receptor blocker, or they need a second blood pressure medicine added. They don't for the day. They need a second once daily blood pressure medicine added. Now, some of my patients actually who are on two medicines, some of them split it up with something at nighttime and something in the morning, and it's fine. I tell them I'm not particularly interested. I'm going to prescribe for you medications that, at least in theory, are once a day medications. So all I really care about is that you take them. And whether you take them in the morning or at night is less important than whether you're taking them at all. And I'm sure that we would probably say that about any medication that is only dosed once a day. All right, I'm almost done. So let's talk about putting it all together and managing these patients. I didn't talk about post-op blood pressure management because we all know it's because the surgical team gives too much fluid. So you have to dry them out and make sure that the surgeon did a good job in hooking the renal artery back up. And so after that, if you talk about in the first 6 months post-transplant, you're going to screen them with office blood pressure, ABPM. All of our patients get ABPM 6 months after transplant at Seattle Children's. Calcium channel blockers are our first line drug, and often those are what's added in the early days based on office blood pressure. And then if we need to, we may add a diuretic, or we may add a beta adrenergic blocker because of the activation of the sympathetic nervous system. And then after 6 months, that's when we'll either add or switch to an ACE or an ARB. Like the little 9-year-old boy I saw last week, still hypertensive, still has some LVH now at about 14 months after transplant. It got better on amlodipine, but I switched him from amlodipine to olmesartan because he has a little touch of proteinuria too. You could continue their calcium channel blockers, and then you should be doing ABPM, I think, to guide your therapy. We do ambulatory monitoring every year in patients on therapy and every 2 years in those who are not on therapy at Seattle Children's. So all of our transplant patients know that ABPM is part of their follow-up because we feel it's that important. So hypertension's frequent. We know it has significant detrimental effects on allograft survival and other things. Treatment should probably be aimed at normalizing the blood pressure, just like in patients with, lesser stages of CKD. calcium channel blockers, ACE inhibitors, and ARBs. We've talked about that. We often need to use multi-drug regimens. And then the things I think that are unclear are what should the goal be and whether or not we should use chronotherapy. I think that small pilot study was too small and not conducted in a way I would have preferred to really be able to answer the question. And I thank you for your attention, and I think we should all have lunch.
Thank you very much. That was a beautiful talk. Any quick questions before lunch? Okay.
Did I answer your question?
Yes. Oh, the other way around. Was that a joke or a?
Yeah. No, it was because he had asked a question about goal. I mean, office blood pressure is going to be important as well, and I think we've shown, at least and you've shown even in your work, that lower office blood pressure is helpful in slowing CKD progression. And like I said, all these patients have CKD, so lower is going to be better. And so if you get them to a normal office blood pressure, that's the first step.
So just related to that, do you think if there is a study to be done, do we have to chase a kidney function target, or do we have to chase a hypertension blood pressure target? Because when you talk to the transplant doctors, they are more concerned about kidney function, like you showed. What would be better?
Well, clearly you're going to be studying both, and I think the only way you could do that study is really to have the blood pressure target be the basis for the intervention, but have kidney function be one of the outcome variables. And then, but also, obviously in these days, you're going to look at vascular stiffness, you're going to look at LV mass, and look at cardiac function and some of the advanced measures of cardiac function using tissue Doppler, and then probably vascular stiffness and even atherosclerosis. I mean, it really needs to be done in a comprehensive way. Big undertaking. And it can't just be a natural history study. There's lots of value in studies like CKID and 4C, but you can't, in those, although they're large cohorts, they're actually too small to be able to sort of model a clinical trial. You need big data to be able to model. In a retrospective sort of or a natural history study, you actually need very large numbers to be able to model a clinical trial. So you actually then need to do a prospective study to get the data that you need. Yeah.
Thank you very much, Joseph. That was superb. So lunch is ready now, and we'll have 20 minutes only, unfortunately. But feel free to bring your food here so we can carry on. Thank you very much.
Well done. Very good. Thanks. Very good. Yes. The best lunches in the world.
Yeah, okay. Z. Where have we got to? Yep. Can you hear me? Good. We're on a different computer now, so hopefully it'll work. We're just about to start running the PowerPoint, which is all right.
Hi, hello. Hi, I'm George from Sergius here. I'm gonna start the session, introduce you, put your video, and then maybe have one question at the end, if that's okay with you? All right, thank you. Okay. Um, so going forward after our lunch, which I hope you enjoyed, great. We're going to the afternoon session, and we're gonna skip the first lecture, which may or may not happen a bit later in order to catch up with time. So instead of Mr. Kesaris, let me introduce Dr. Amy Gallo, who is an associate professor in Stanford on liver and kidney adult and pediatric transplantation. She has recorded her lecture, but she is online. So after watching her video, we will have the chance to ask her any questions. Okay? So if we can start the video, please.
Thank you so much for the opportunity to speak today at the 8th Pediatric Kidney Transplant Symposium on surgical complexities in liver transplantation. I am so sorry that I'm unable to join in person, and thanks again for the special arrangements that still allow me to participate. I have no relevant disclosures or conflicts of interest. I love this idea of being asked to discuss surgical complications of liver transplant in 15 minutes. It definitely makes the job seem less daunting. As I think back through my own training, I remember how the complexities have evolved. As a fellow in training, many can probably relate. The complexity was trying to maintain complete focus to line up cases, operating on the donor, and then participating in the implant, at the same time caring for all the patients. It was probably most complex trying to figure out how to eat and sleep. But if you really think about the care for these patients, the complexity can be seen in every aspect of the patient's journey. And I do think this is part of the surgical job. From patient selection as a candidate, to the timing, to allocation parameters, to donor selection, what type of donor to use, the size criteria, all the intraoperative management, including blood loss, pressor use, bypass, dialysis, surgical techniques, the postoperative care, the anticoagulation, blood pressure, CVP, and immunosuppression use. There's also long-term complications, and really trying to keep the vascular anastomosis intact. That being said, I have learned things from the job over time that allow liver transplant surgical complexities to evolve, and I would love to share these ideas which could be extended to other medical fields and might help to simplify the complexities. For example, pediatric transplant is a very small field. We need to stay involved. We need to be present, be willing to learn, listen, grow, travel. This is essential for being a skilled caretaker. We always have to remember this is about the child. Each kid has his or her own story. We are just trying to make their lives as good as possible, given their health impediments and their goals. Timing of repair is, however, very crucial. If the liver disease has progressed, the cardiac surgery may not be successful because of liver failure complications. But if the cardiac surgery is not performed, the liver transplant likely won't be successful, or the child may never be a transplant candidate. When we were able to recognize the need for a tight interdisciplinary approach to this complex problem, we were able to establish a Alagille syndrome program to help simplify our treatment plan. This could prevent treatment timing from being an obstacle for these patients. When we take another disease process like biliary atresia, other surgical complications come to mind, like surgical adhesions from the failed Kasai procedure and extensive portal hypertension from both cirrhosis and atretic portal veins. Portal vein flow in these cases can be the Achilles heel of the operation. This is an example where we used a living donor left lateral segment as a donor and attached a cadaveric arterial conduit to the SMV splenic confluence. We found that using an arterial conduit instead of a vein has less compressibility to sustain flow. From being involved, this type of complexity becomes a bit more routine. Metabolic liver transplants have their own surgical complexities. One would think that without portal hypertension or liver failure, the surgery is vastly simplified. However, what about the medical instability of these patients and what they can do under stress? These surgeries need to be done flawlessly and with the right resuscitation in order to prevent a possible metabolic crisis and irreversible brain damage. Bypass may also be used to prevent complications of clamping the portal vein in a scenario where there is no collateral portal flow. This could prevent bowel edema and pancreatitis. And then you have to think, would this liver work in another patient? Would it be worth entertaining the idea of a domino operation where you're doing 2 transplants at once with another team of surgeons? Acute liver failure, again, may be an easier surgical operation, but the concern could be possible brain swelling from hyperammonemia, and we may need to position the patient head up or to use dialysis or bypass during the operation. With hepatoblastomas, you worry about the patients being at their chemotherapy nadir and at a high risk for infection. They also could be a potential resection candidate that you don't know about until the time of the operation, since they are out from their chemotherapy. As we move beyond the diagnoses in pediatric liver transplant surgery, we see more complexities in the form of donor selection. Do we use a cadaveric donor or a living donor, partial or whole? And if we're going to use a partial, which part, of course? This complexity has shown me that we are still growing in our implementation of these modalities, especially in the United States, and I'll try to explain. It is well established that there is a survival benefit to split liver transplants for both a child and an adult. Wait times are shortened, and there are fewer patient deaths. The Italian experience, where they instituted a national mandatory split liver policy, showed that wait times and patient survival were improved. We also know that delays in liver transplants have unique consequences for wait-listed children that include diminished quality of life, loss of schooling, puberty delay, long-term impairments in neurocognitive and growth. And despite these efforts, the pediatric priority for liver organ allocation remains disadvantaged because of the lack of size-matched donors. So if you look at the United States specifically, approximately 1 in 10 infants and 1 in 20 infants listed for liver transplant die while on the wait list. Yet if you look at the number of technical variant grafts that are being performed in the United States, it has really not changed over the last decade and is at about 39%, whereas Europe is now at 70% and their waitlist mortalities have significantly improved. We tried to hone in on the reason why the United States underutilized technical variant grafts. We used the SRTR data between 2010 and 2020 and looked at a cohort of 5,208 patients that met inclusion criteria. We broke them down into 2 groups, whether or not they were performed at a high volume or a low volume center, a high volume center being one that performed more than 5 pediatric livers per year. In that cohort, 83% of all the transplants were performed at the high volume center and 70% were at the low volume center. And the high volume centers were statistically significantly more inclined to perform technical variant grafts, 42% versus 31%. This graph shows all of the liver transplants that were performed in the United States between 2010 and 2020. The blue signifies whole livers, yellow split livers, and red partial livers. The dotted line divides the low volume centers from the high volume centers. As you can see, there really is not a program that approaches the 70% of technical variant grafts that is seen in Europe. And we were able to reproduce the finding that high volume centers with significantly higher rates of technical variant graft use demonstrated a 23% reduction in waitlist mortality. But the discrepancy in graft survival came when splitting up the programs between high and low volume centers. So the red and blue line show high volume centers comparing whole to technical variants. The yellow and green line compared low volume centers comparing whole and technical variants, where we see a statistically significant difference in outcome based on the type of graft that is used. And in a multivariable Cox regression model for graft failure, the only statistically significant factor was the size of the transplant center. So not surprisingly, we again showed that technical variant grafts can decrease waitlist mortality and have excellent outcomes. But maybe what we found out was that it's not in all situations, and the surgical complexity may lie in further education and training, or in even list sharing, really any means to preserve the lives of these children. To add to the complexity of this thought, I bring up another technical adaptation, the hyper-reduced left lateral segment graft. And the reason I actually bring this up is my partners and I have showed this slide a number of times, and I want to make sure everyone realizes that you may bring up the slide and suggest that this is a good solution, yet we also have never performed it. So there's learning for everyone. This next illustration is to show that each child can individually bring their own complexities despite what we've learned or know. This 1-year-old with biliary atresia failed Kasai was admitted with feeding intolerance, growth failure, abdominal distension. She was placed on TPM with bowel rest. Her PELD was 13, and she received an exception score of 35. During her hospitalization, she was transferred to the ICU. She had increased abdominal distension, tachycardia, tachypnea, was intubated, required pressors, was developing acidosis and a dropping hemoglobin and hematocrit. Her findings were consistent with a small bowel obstruction, and she was taken to the operating room and found to have a volvulus around adhesions involving most of her small bowel. She underwent a massive small bowel resection for the necrotic bowel, leaving approximately 45 centimeters of jejunum beyond the ligament detritus in the transverse left colon. The root limb remained intact. This shows ischemic bowel with no restoration of perfusion after release of the volvulus. She remained hospitalized with ascites and growth failure. She had feeding intolerance with GI bleeding and refractory ascites. Her total bilirubin rose to 9.5, albumin of 2, INR 1.3, ammonia of 79. Ultrasound and CTs showed diminutive portal vein with reversal of flow. There were no prominent collaterals, and the portal vein and hepatic artery were almost the same caliber. She received a liver offer and was transplanted 5 weeks after the bowel resection. The donor was a brain-dead 2-year-old, 13-kilogram child who died from anoxia. The graft was a reduced size on the back table, removing segments 6 and 7. The patient's portal vein was atretic like we had predicted and was common in biliary atresia. The vein was dissected down to the confluence of the splenic and SMV, at which point it was fish-mouthed to increase the diameter. The transplant was standard implantation with a colodocal duodenostomy. A rulum was taken down and restored the bowel length, resulting in 75 to 80 centimeters of jejunum, anastomose to the transverse colon. Due to the swelling of the abdomen, it could not be closed, so a wound vac was placed. Her initial labs were pretty typical of a liver transplant from a reduced-size graft. On postoperative day 1, her LFTs began to rise. She was taken back for a wound vac change on postoperative day 2. The liver was beefy red and consistent with reperfusion injury, but the portal vein had flow. The ultrasound velocity was decreased to 7 with the wound vac on, but removing suction improved the velocity to 47. Over the next several days, the liver function peaked and began to decline, with enzymes dropping to 300. Total bilirubin remained below 2. The INR was 1.5. She returned to the operating room for a wound vac change and was noted to have patchy necrosis of the liver, and the vac remained off suction. On postoperative day 7, however, she had an abrupt rise in her LFTs, with enzymes greater than 7,000 and an ultrasound showing sluggish portal flow. She became increasingly unstable and was relisted for a status 1 for primary graft non-function. So 10 days after her first liver transplant, she underwent a second transplant. She received a liver from a deceased donor, 6 years old. Gunshot wound to the head. The graft was a left lobe split on the back table. On exploration, she was found to have a thrombosed portal vein and IVC. She underwent IVC and portal mesenteric thrombectomy with good return of flow. An interposition graft, as we talked about before, of a donor iliac artery was placed at the confluence. She was remained on intraoperative CRRT throughout the entire transplant. She was in now renal failure. Her initial labs were reasonable and as expected, and the ultrasound demonstrated portal flow. Again, on postoperative day 1, her enzymes acutely elevated, her INR was rising, and she returned to the OR where portal vein was noted to be thrombosed, and the liver had poor turgor. The interposition graft was taken down, it had poor flow, and thus was ligated, and the IVC was ligated behind the liver and divided. An iliac vein interposition graft was placed on the IVC and connected to the portal vein, completing the transposition. There was excellent flow with immediate improvement in the liver. This is a picture of the ligated IVC with direct flow into the portal vein of the transplanted graft. She is now approximately 1 year out from her liver transplant with excellent graft function. She has return of bowel function as well, but unfortunately remains persistently on dialysis, and her kidney transplant will be my next surgical complexity. My last illustration of complexity involves changing course, adaptation, and learning. This is Stormy Jones, the first case of a simultaneous heart-liver transplant performed by Starzl in 1984. She was a 6-year-old girl with homozygous familial hypercholesterolemia. She lived 10 months following her transplant, but her untimely death was not failure, as it paved the way for innovation. Since Stormy, the number of combined transplants is likely to continue to grow. Our cardiology and cardiac surgery colleagues have gotten better at caring for these patients with congenital heart disease, and more of these patients are developing secondary complications of their chronic heart failure that include liver failure. The mechanisms behind heart failure in the Fontan patient are different from those of adult cardiomyopathy, and many of these patients are needing both heart and liver transplants in the future. The classic heart-liver technique, the organs were procured separately. The cardiectomy and heart transplant were performed first. The patient was taken off of bypass. The liver transplant was then performed after completion of the heart transplant. The difference is, in many of these combined heart-liver transplants in the past, patients were non-cirrhotic and compensated with straightforward heart procedures as well. At Stanford, it was Annie Bonham who suggested that we do these simultaneous. Why have prolonged cold ischemic time? Why delay cardiac allograft function, increase pressor support, venous pressure, and reduce portal flow? That can impair perfusion of the liver, cause venous congestion, and ischemic bowel ischemia. And if we combine the procedure where the liver and heart are placed simultaneous, could we prevent these wide mood swings in preload, distributive shock from liver failure, thromboembolism and instability with the liver reperfusion, and prolonged coagulopathy, potentially leading to bleeding and cardiac tamponade? The en-bloc donor technique would include the heart and liver being procured together with a complete in situ dissection of the organs prior to cross clamp, eliminating the need for back table preparation of the grafts. And the inferior vena cava would stay intact. In order to do this, we would transect the diaphragm and place the organs in as one. We would be shortening ischemic time. We'd have control reperfusion of both organs while we'd still be on bypass. We'd shorten the period of coagulopathy, reduce the risk of thromboembolization, instability on reperfusion, and have a better and more rapid allograft function. This is a picture of both the sick heart and liver. This is after cardiectomy and hepatectomy with the diaphragm split. These are the organs procured en bloc. This is a picture of the recipient continued on bypass before the organ implantation. And the new organs prior to diaphragmatic closure. And as we continue these new techniques, we will study them and build on the knowledge and those who have paved the way before us. So hopefully I've talked a bit about simplifying the complexity. The ways to do that is to stay involved. Again, it's a small field, but to be willing to learn, to listen, to grow, and to travel. We have to think about the child. We have to change the course, adapt, and learn, and we have to train the next generation. Each team member can contribute so much to the learning process. We have to listen to all of them, including our patients and their families. Thank you very much.
Well, thank you, Dr. Gallo, for this excellent. I think we have time for one question. Dr. Gallo is online, actually. You can see her here on the screen. No questions? Okay. Well, then let's move to the next talk, and let me introduce Mr. Chris Callahan, who is a consultant. Oh. But how are we going to do it? Sorry, Chris. Just one sec.
Thank you very much. That's fantastic. Just trying to get the audio up. Speak now. Put this closer. Okay. No, we can't hear it very as well as I would like to. But anyway, thank you so much. Thank you so much. That was amazing. And yeah, come back with a kidney transplant after that amazing liver transplant. Thank you. All the best.
Thank you. Okay, so as I was saying, the next talk is going to be given by Mr. Christopher Callahan, who is a consultant transplant, pediatric and adult surgeon at Guy's, and he's going to talk to us about how we optimize the deceased donor kidney transplantation in pediatric recipients.
Sure, Josh, thank you very much. While we're waiting, thank you very much to the organisers for inviting me to speak to you today. I always love coming to talk here. A little bit cloudy, but it's always a great view, isn't it? I've had lots of fantastic events and memories in this particular room, so very special to be back here. Thank you. The title that I've been given is Optimizing Deceased Donor Kidney Transplantation in Children, which is a pretty tough topic, really, isn't it? Because it might be getting the TAC levels right, it might be choosing the right patient. I'm going to be very narrow because as a surgeon, that's how I feel comfortable. I like to leave all the complex stuff to my pediatric colleagues. I'm going to really be focusing on the utilization of deceased donor organs for our pediatric patients. I also have a role with NHSPT with a particular interest in the utilization of higher risk deceased donor kidneys.
It's seized up on me, so
no worries.
I can't quite get hold of it. Let me see if I can run it from.
That looks good. Awesome.
I'm just going to get rid of that thing. Slideshow. Slideshow. Oh, no. Go away. Go away. Go away. I don't know why.
Success. No. There we go. That looks good, doesn't it?
I don't know why that thing won't go away though.
That's okay. Oh, they can see it on screen.
Yeah.
Okay.
I don't know what it is or why it won't go. Or why I can't.
Oh dear. That little white arrow there, is that a minimise?
Those seem to be doing anything. Nothing seems to be operating that a bit.
That's strange, isn't it? Speaking. If you right click, does that give you any options to close?
We seem to have this before, didn't we? With,
do you want to escape? Maybe start again.
I can't escape back.
Apologies, guys. We'll get there. Please bear with us.
Go.
Oh, like that.
You like that?
Yeah, now we're talking.
Right, that's it, isn't it?
Let's give it a go. Shall we give it a go?
Yeah.
Okay. Thank you very much. So I realise we're running a little bit behind time, so if it's okay, I will scoot through this. The fundamental question I want to ask is, are we missing opportunities to implant appropriate deceased donor kidneys into children and young people? I'm being very careful about my, my use of language there. What I'm going to talk about today is the outcomes in paediatric renal replacement therapy. There will be many people in the audience who know more about that than I do, but just to set the scene, I'll be talking a little bit about how we assess deceased donor kidney quality and what risk means from a surgical perspective. I'm going to be asking some tough questions about how good our organ utilization decisions are and whether we could be any better, and a few further issues to touch on at the end, and perhaps a suggested approach as well. I'm also aware that there are a lot of people in this room who may have experiences not just in different centres, but in different countries as well. And I suspect that every country and every centre has its own challenges in this regard. So this actually shocked me, I must say. I looked at the UK Renal Registry for the outcomes of children incident on dialysis stratified by age. And although the scale on the left there is slightly magnified from 80 to 100%, if you start dialysis as a 0 to 2-year-old in this country, after 10 years, your survival is only 85%. I feel very privileged as a surgeon. I don't have to deal with the outcomes of that. It's my paediatric nephrology colleagues who talk to parents, who talk to siblings and explain the implications of that. But for me, that is the essence of the surgical decision making that we are faced with at the time of organ offering. If we don't transplant these children, this is what their fate may have in hand for them. If we look at the survival hazard ratio in children who are on dialysis versus being on transplant, this is slightly old data. Apologies, I couldn't find anything newer. But you can see at the bottom there, being on dialysis has a 7-fold higher risk of mortality. The risk is still relatively low compared to other pediatric diseases, and I have colleagues in the audience who may be familiar with liver failure. We heard a great talk of the risk of dying on the waiting list. But for those of us in the kidney transplant world, they're very humbling data to be aware of, and that's why we want to get our patients off dialysis in an appropriate way. Of course, there are differences in terms of transplant options. In an ideal world, all of our children would have a living donor from a healthy and fit and well mum or dad or grandparent or cousin or perhaps even sibling if they're over 18. The reality is, certainly in London and in many other places around the UK, those parents may have other children with renal failure. They may be struggling with health issues themselves, and therefore it's obviously appropriate for the kids to be on the deceased donor list. Great to see that DCD outcomes are as good, if not better, than DBD. Again, this data is perhaps slightly old now, but certainly minimizes some of the concerns that we might have had in the past about DCD outcomes in children. So when we're talking about kidney quality, and we're just focusing on deceased donors now, not living donors, what do we mean by risk? And I've divided this from a temporal perspective, so from short-term and long-term, and then other risks, particularly around the risks of transmission. If we talk about short-term graft function, I guess we're really talking about delayed graft function and primary non-function. Delayed graft function in this hospital, in Guy's Hospital, happens all the time. 50 to 60% of our adult deceased donor kidney recipients will have delayed graft function. It doesn't bother us too much. It might be for a week, it might be for 2 weeks or 3 weeks. We start getting a little bit twitchy at that point. It's not too bad. If I was at the Evelina or GOS, DGF is a different kettle of fish entirely. Far harder to manage a child post-transplant with DGF, both physically and psychologically. But in the long run, the impacts are probably fairly minimal for DCDs. For DBDs, there may be slightly more risk. If we look at donor AKI and the impact on delayed graft function, which I think often worries us when we're on call taking organ offers, we can see that for deceased donors up to AKIN stage 1 or stage 2, the risks are certainly slightly higher, but not excessively so. This is primarily taken from adult population. When we get to stage 3, however, the risks are higher again. And we start to worry about primary non-function. And just so people are aware, primary non-function is the kidney never working. Delayed graft function means that it does work at some point. Again, we can be relatively happy with donors with AKIN stage 1 or stage 2. The odds ratios are not increased there. You can see that on the left-hand side. But data from Kat Boffer's work from Oxford and Portsmouth suggests that AKIN stage 3, there is an increased risk of PNF, approximately 2 to 3 times. And I think we would be appropriately cautious in our pediatric population. Really, I want to focus much more on long-term graft function. That's what we really hear, what we worry about, and what we're here for. And a lot of people will still be thinking about SCDs and ECDs, so standard criteria donors, extended criteria donors. If I could really ask you to try and throw away that terminology, I think it's distinctly unhelpful. Trying to distinguish things in a binary fashion, good and bad, ECD, SCD, is, I think, oversimplistic, to say the least. Risk is a spectrum, and we're very fortunate that in the modern era we have appropriate donor risk indices to allow us to explore that spectrum. So I think SCDs and ECD terminology should be discarded. There's lots of different donor risk indices. We can go to the US, where they have lots of data, and they have very complex risk indices. In the UK, we like to keep things a little bit simpler. This is work from Chris Watson and Andrew Bradley in 2012, and they did a retrospective analysis using the UK transplant registry, and only 6 or 7 factors had an independent impact on graft survival. This is modeled in adult recipients. By far the strongest donor risk factor for poor graft outcome in the long term is donor age. However, there are other factors: hypertension, donor weight to some extent, hospital stay, and then adrenaline. If you ever want to publish lots of paper, get into the donor risk index world, because every 4 or 5 years you can just repeat the paper again because there's new data, so it needs to be updated. And Lisa Mumford, actually, she hasn't published this. She's very naughty. She should do. Reanalyzed UK transplant registry and updated it. And you can see the risk indices stratify into 4 different groups there, what have been described as D1, D2, D3, and D4. Donor factors, donor age, again, by far the most important factor, and there are other factors as well: height, hypertension, donor CMV, hospital stay, etc., etc. But really, 9 times out of 10, when I'm on call, what really bothers me is donor age, and I think at the moment our upper age limit for pediatric recipients in the UK is 60. That's recently increased in an effort to try and broaden the donor pool. The other thing that I mentioned that we worry about is transmission of serious diseases, and fundamentally that can be divided into 2: transmission of cancer or transmission of bloodborne viruses such as Hep B, Hep C, or HIV. So far as cancer is concerned, none of us are cancer experts on a day-to-day basis. It's not possible to carry all that information in one place. So we have these very accessible and easy to understand SABTO guidance. I'm being sarcastic, by the way. If you've ever had to read through the SABTO guidance at 3 in the morning, it will probably put you to sleep if it wasn't for the fact that your phone was going off from the hub asking you to make a decision. The good news is we can get that information from the donor coordinators about the type of donor and get an estimate of the risk of transmission to the recipients. And you can see that might range to up to 6.5% all the way down to less than 2%. This information, as always, needs to be updated on a regular basis. But the fundamental question we need to ask ourselves is, what type of risk of transmission would we accept for a child on dialysis? A risk of 10% transmission, I would suggest would be far too much. A risk of 5% still feels a bit much. A risk of 2% or 1%, I think we're starting to ask ourselves some tough questions. And why do I use those numbers? Well, we know the risk of the patient dying after a pediatric kidney transplant is in the region of 1 to 2% per year, or certainly for the first year or two after transplantation. So it's within that broad range of the risk of transmission anyway, and we can start to have sensible risk-benefit discussions. There are no clear lines or demarcations to say yes or no for pediatric patients. We are, of course, sensibly more conservative because our patients do have relatively low risks of dying, both on the waiting list and post-transplant, certainly compared to our liver colleagues. But it's about that type of threshold, 1 to 2% risk of transmission, that for me, I have in my mind as a cutoff when I'm thinking about the SATO guidance. Transmission of serious diseases is just as concerning, but in some ways it's harder to get a handle on because there are more unknowns. We can get the donor stage, the grade of the cancer, the treatment that they've had, but the problem with deceased donation is that there are unknown unknowns. We never really know what the deceased donor has been up to in the last couple of weeks of their life. I don't know about you. I don't tell my GP everything that I do in my life. I'm pretty sure I tell my wife everything, but I'm not sure that would go for everyone in this room. So there is always a risk of transmissions of serious diseases. So if we have a donor that has negative hepatitis B, hepatitis C, negative HIV, but has increased infectious risk, which is actually identified, whether it be a prisoner or a sex worker, an intravenous drug user, that leaves us with a tough question to try and answer. We've got negative serology. Can we quantify the risk of that donor actually being in the window period and missing a transmission of disease, which is obviously upsetting for everyone. UK guidance around this is slightly less clear, partly because we have very, very few patients in this country who have HIV, Hep B or Hep C, which is unrecognised. This is actually Canadian recommendations. I'll skip through this for the interest in time, but you can look up tables to say if they have negative serology, what is the risk of an unrecognised transmission, depending on the risk category there on the left-hand side. And using that information can start to give us an idea of whether we think that risk of transmission is acceptable or not. Broad rule of thumb, about 1 in 300. If you've got negative serology from a UK donor, but they have other risk factors, the chance of passing on something really nasty is going to be less than 1 in 100, probably less than 1 in 500, but I tend to use 1 in 300 as a ballpark. You can, of course, get NAT tests to reduce that window period even further, but you will never reduce it to 0, unfortunately. There's a whole different way of assessing kidney quality, of course, and this is something that nephrologists don't see because they don't get to pick up kidneys in their hot little hands. They're very welcome to come down to theatre and pick up kidneys if they want, but there are all sorts of things that surgeons see, whether it be the perfusion deficit or scarring, damage at retrieval, cysts or patch quality. This is all important information, which might mean that as a nephrologist, you get a phone call from your surgeon saying, look, the numbers look great, but this kidney doesn't look right. I don't think we should go ahead. Problem is that is really difficult to quantify and assess. As a nephrologist, you would love a scoring system to say, well, okay, Georgios, that score's 6 out of 10, but I'm happy to go ahead because here's the risk estimate. We can't do that. We don't have the information and the scoring systems available to use, unfortunately. You may say, well, hold on, if there's some scarring there, perhaps we could do some pre-implantation histopathology. That actually causes a lot of problems. You have to wait for the histopathology. You have to have a histopathologist who's available at 2 or 3 in the morning. There are not many units that can do that. And it raises some very interesting questions about the predictive value of pre-implantation biopsies and their impact on long-term graft function. There are many different scoring systems out there. They tend to be, or they may be useful for older donors, over 60, over 70, with multiple comorbidities. I would suggest that the utility for pediatric kidney transplants is low, if not non-existent, because the organs you're getting offered anyway are pretty good, if not excellent. So we've got some problems there. Post-transplant outcomes are dependent on lots of different factors. The chronic donor risk indices, the donor risk indices I've just mentioned in terms of donor risk, in terms of donor age, CMV, and all those other things, actually have a fairly poor predictive value, a statistic of about 60 to 70%. There's a lack of evidence base for surgical decision making and a lot of uncertainty about the use of pre-implantation kidney biopsies. So what can we do? Well, there are some predictive tools out there. In the interest of time, I won't spend too much time on this. Again, they're all focused on adults. The AID memoir can help in terms of defining risk of cancer. Fundamentally, I think we need to ask ourselves, are we as good as we can be, even with these uncertainties, in terms of making utilization decisions? And this is a funnel plot taken from the most recent kidney report for NHSBT, looking at the difference in offer decline rates between different centres in the UK. Every dot there is a different paediatric kidney transplant centre, and these are for organs which are ultimately implanted for standard criteria, DBD donor kidneys, and the variation around the country is marked. It's really huge. Some centres are saying no to 70% of kidneys, which subsequently end up getting implanted. Some centres are saying no to just 20%. I think that poses some really tough questions for us as a community. We can't all be right and all be wrong at the same time. It's a great paper from Matko Malay and also from Steve Marks and colleagues from GOS, which basically asked that question. They looked at all those declined kidneys, declined for a pediatric recipient, and worked out what happened to the kidney if it was implanted and what happened to the patient that it was declined for. And in essence, if we focus on those kidneys which were declined for donor or size mismatch reasons for pediatric recipients, this is in 2009 to 2014, and work out what happened to that kidney afterwards, if it was implanted into an adult, had about a 94% 3-year renal allograft survival. That's pretty good. Strangely enough, if it was implanted into a child, the 3-year allograft survival was barely 80%, which I don't think any one of us would be happy with. I still can't quite get my head around this. I can't understand why some kidneys which end up going into kids would do so much worse than those going to adults. I suspect it's more of a reflection of the recipients. If a kidney has been offered to one child, turned down, then offered to another child, they must be very, very high priority recipients. They're probably highly sensitized with a lot of other medical issues. Fundamentally, I think a lot of those kidneys may well have been usable, but fascinating results and great work from the GOS team. As I said right at the start, it's really important to acknowledge that there are big variations between countries. Almost all of the information I've given you today has been based on UK data. If you're lucky enough to live in Denmark, Sweden, Finland, Slovakia, or France, your median waiting time for a deceased donor pediatric kidney transplant is about 6 months. If you need to, you can afford to be fairly picky. If you live in Turkey, Russia, Belarus, Netherlands, or Germany, very different. Your children are waiting for a long time. The risks on dialysis are starting to accrue. We are somewhere in the middle. Kind of makes it tough. We're neither Arthur nor Martha in this regard. So what should we do? We need to weigh up all the risks, all the pros and cons, think about our children on dialysis. What is their prognosis? What is their attitude to risk along with their parents and carers? What type of discussions have been had in clinic? How much risk are we willing to take as clinicians on their behalf? And actually, what are the risks? Can we separate short and long-term graft dysfunction and think about the risk of disease transmission? So just to summarize, I would suggest a decision-making framework. It's really important to distinguish between organ quality, long-term issues, and disease transmission. Disease transmission is usually easier to get a handle on, and the risks are fairly low. Please know the literature and your options. Please, please, please talk to the patient and their family in clinic. And I must admit, I'm not always great in that regard, and my recipient coordinator colleagues will sit there thinking, hold on, Chris, you don't talk about all this stuff. Is it because I'm scared? Is it because I don't want to talk to them about the risks of transmission of HIV, Hep B, Hep C, and cancer? It's not much fun to do that with a family of a 5-year-old child there. So it has to be done in the right way at the right time, and that's challenging to do. And of course, when in doubt, phone a friend. This is my favorite saying: prediction is very difficult, especially if it's about the future. Never a truer word spoken. But I think when we ask ourselves these really tough questions, I think we are missing opportunities now and again, and we need to be really stringent as a profession, as a clinical group, to make sure that we miss as few as possible. So in conclusion, yes, they're tough, but we need to acknowledge that we're probably declining some good quality deceased donor kidneys for the children on our list. We need to be aware of all those local and national factors and the data that can be out there to support our decision making. And always, if you can, as a transplant surgeon, as a transplant team, control the controllable. Have a short colder ischemic time, do a great operation, keep the warm ischemic time short, have wonderful nephrologists and nurses on the ward and in clinic to provide that aftercare that's so important, and work within what feels comfortable within your unit with gentle challenges now and again, and review all your organ offer decisions on a really regular basis. Thank you very much.
Thank you, Chris. Great presentation as always. Any questions? Professor.
When we talk about risk, it's trying to understand what the risk is. And people get fixated by, let's say, high-risk behavior, which is detailed and very specific for that donor. And yet, when there's no history available, it passes through without much comment. So I think it's how do we educate ourselves about real risk? Because actually for a child, HIV, Hep B, C is remarkably rare, and it would take a very narrow window of opportunity for the virus to come through to the child. So do you think living donor liver transplantation has done a kidney donation has done a disservice to the cadaveric side? Do you think it's made people very risk averse now?
We have a terrible problem in kidney transplantation in this country in that we have excellent outcomes, and it's a lovely problem to have. And we want those outcomes to be even better, but the margins are so fine now. I think in some ways, if you're a pediatric heart transplant surgeon or maybe liver or lung, and obviously you'll talk about that next, if you've got 5, 10, 20% rates of death on your waiting list, in some ways you're faced with such a stark difference. These things about increased infectious risk donors fade into insignificance. In the kidney world, I think sometimes we end up going round and round in circles and worrying about things which perhaps are not there quite so much. I think that risk is fundamentally about numbers, but even more importantly, it's fundamentally about psychology. And it's mainly about our psychology. We have psychologists to support our patients, and they do a great job. I wonder on occasion if we need to sit down with psychologists ourselves as a group and think, how do we perceive risk? What is it that we're trying to do? To answer your question, I think the success of living donor kidney transplantation has made it really hard for us. We see a deceased donor kidney transplant not so much as a failure, but certainly as a second best option. I don't think that's the case. I think we need to be hard-headed about risk and have some really honest conversations. We are very lucky in the UK. We don't have the problems they have in the US. We don't have 20% of our donors dying, after opioid overdoses or gunshot wounds. We're very fortunate, and I think we can be far more focused and hard-headed in that regard. Yeah.
Thanks, Chris, for an excellent talk. We're just about to look at the fourth time we've done a prospective audit of the declines in the UK, because what we found when we did it the last few times is that as soon as you tell nationally that you're actually doing the audit, the declined offers actually go down a bit in those years because people realise that the spotlight's on them. So I think there is a bit of clinician variability, and I think that, as you said, that now we're in the situation where if we've got a kid who's on the waiting list for a deceased donor transplant, that we're in the situation that maybe what our thresholds were 10 years ago are different. Maybe we shouldn't be so stringent on the matching. Maybe we shouldn't be so stringent on what we're aiming for, because if they are on the waiting list and it's gone up from kind of 250 days, like 265 days 10 years ago, and it's now heading from 1 to 2 years, we have to be careful.
And I think as a community, as I say, we need to get together and say, what is our standard approach to risk? We need to be having those tough discussions more. Yes, some of our donors will be intravenous drug users. But if their serology is negative, we can get a NAT test. If as a community we support that, then I think we should send that message, because otherwise it's the unsaid, it's the unknown, which I think makes it really tough for our children and young people and their carers, and makes it tough for us as well.
And my question to you was about hepatitis C, because it's actually now a treatable disease. So actually,
curable disease,
and it's curable. So actually,
Nigel's sitting there saying, "What are you worried about hepatitis C for?"
Well, I do worry about it.
Do you?
But it's because of the other viruses
Exactly.
that come hand in hand with this. When you talk about risk, for me, the children who get split livers, the risk is with the other viruses, CMV and EBV, that happen early on in the post-transplant recovery, can influence both short and long-term survival.
Thank you very much.
Thank you, Chris.
Thank you very much. Thank you.
Now, please welcome Professor Nigel Heaton, who's a professor in hepatobiliary and transplantation at King's College Hospital, and he's going to talk to us about, along with Sergio. So Professor Heaton is going to talk to us about the surgical complexities of the combined liver and kidney transplantation. Thank you.
Sergio's got the presentation. I'm just going to load the slides up. You've already heard about liver transplantation, so I'll just try and pick out a few things that interests me and talk a little bit about the outcomes of combined liver and kidney transplantation. I'll emphasize over the course of my talk that this is pretty rare stuff. There aren't many institutions with significant experience. So when you hear people talking about 10 or 20 cases, it represents a very large experience. And I'll try and bring out some of the lessons I've learned. I follow on from a very nicely demonstrated talk from the transplant surgeon at Stanford, which is an excellent unit. Thanks, Sergio. At King's, we've done about 1,400 liver transplants since I first started in 1989. And we've transplanted somewhere between 40 and 50 children under 3 kilos, which for me represents the extreme of liver transplantation. And maybe I'll say a little bit more about that during the course of the talk. So liver transplantation has been around since 1967. That was Tom Starzl reporting the first successful case. This is Carl Groth, who was one of his first fellows and trainees who brought liver transplantation back to Europe. And you can see that many of the early survivors were actually children. The reason for that is they are robust. They don't have cardiopulmonary disease. They will take a tough time during theatre, and they have much better powers of regeneration and recovery after transplantation. So they were a good group to learn on. And you heard the North American experience, which is most kids are transplanted with whole organs. They have enough for various reasons, and therefore transplant surgeons in the US are very risk averse in terms of cutting livers down. The first combined liver and kidney transplant was performed by Margreiter in Austria in 1984. It seems quite recent, really, or at least it does to me. I've said it's an uncommon operation in children. And I think the challenge only comes when you get to the very small children. I think if they're missing veins, missing the inferior vena cava, it's very easy to replace those. That's, I would call, really quite standard. But the challenges, I think, are when you get below 6 months. And as I say, for me, the critical landmark is 3 kilos. And the smallest transplant or the smallest child for me has been 1.7 kilos. And that takes it down to where you have to be very, very careful with the veins when you're suturing, because it becomes very fragile. I think what Chris was saying about psychology, I believe strongly we should all be seeing psychologists and having some form of therapy for counseling us through these things. Because when I'm training my younger colleagues, it's not just the technical aspects that they have to be adept with. It's managing the tension in theatre when you've got a small child and things may not always be going quite so smoothly as they show in various talks. And to try and keep your nerve and to allow yourself to grow and develop experience safely, I think is probably the most important thing that I've learned in my career. Because if you get burnt early, You're never quite the same person, certainly the same surgeon. The other thing I'd like to emphasize is that perioperative management can be very complex in children, primarily because of the metabolic diseases that you're transplanting for, that all have little aspects, nuances of management that require specialist knowledge. So building a team of specialists and having really good colleagues that you can trust for their judgment and decision making, I think is essential. Now, what are the groups? I've put this here, this is sort of academic really, but it's useful to have a framework. So there are three scenarios. You have a disease that leads to damage of the kidney and liver together. The most obvious disease and the most common we transplant for is polycystic kidney and liver disease. The second group is where they get end-stage renal disease caused by an abnormality, a metabolic disorder in the liver. Now, for a liver surgeon, when you're treating this group, the liver looks normal. The liver looks normal, but there's an abnormal enzyme being produced that is damaging the kidney or another organ. And then finally, you've got a third group where you get both, liver and kidney disease together. And I would say the most common now in young adults is chronic rejection of the liver with CNI renal injury. So the most common indications, and I'll briefly refer to the top three in this talk, are primary hyperoxaluria type 1, polycystic liver and kidney disease, the autosomal recessive form, and methylmalonic acidemia. There are other much rarer indications that you'll see when you're reading papers, but really the numbers being performed in the literature are tiny. One of the things I want to say is where you have an abnormal liver, so particularly referring to the polycystic kidney group, the liver disease takes an unusual form. Most people have it fixed in their mind that liver failure, liver disease means jaundice. Actually, it's jaundice in a proportion of patients, but the majority of patients coming to liver transplantation with end-stage liver disease will not be jaundice. They'll have synthetic failure or shunting of blood related to portal hypertension. So in the group of patients that you'll tend to see in the kidney world, where they've got fibrosis in the liver and portal plate malformations, they have portal hypertension. And that's quite subtle. So you need to be looking at the size of the spleen, the presence of varices, shunting, in severe cases, encephalopathy. But they seldom get liver failure. So portal hypertension dominates the clinical picture. They can get recurrent sepsis. It can be quite difficult to see, is it coming from the kidney or the liver? And we can sometimes have quite significant discussions about that. And the other important thing to say is that the liver and kidney disease progress at different rates. So in the polycystics, the kidney disease will usually manifest earlier than the liver disease. And trying to assess, do you do a kidney alone or a combined, can be quite tricky. You've heard about transplantation today, so it's all sizes, all ages. About 85% of our children will get a partial liver transplant, a piece of liver. So it's quite unusual to get a whole liver. If technically everything's okay, the grafts grow with the kids. They don't need a retread every 10, 15 years. If you go back 30 years, probably 20% of children were required retransplantation before they reached adulthood. Now it's down to about 10%. And it tends to be early technical complications that cause the troubles. Hepatic artery thrombosis, or as we saw in the case presentation, portal vein insufficiency. Actually, in that case, I think it was collaterals siphoning blood away from the portal vein that went unrecognized. And the long-term outcomes improve. So 1 year survival for us, for a straightforward case, I'd expect to be 97, 98%. Our outcomes are slightly less good than that because we're taking on acute liver failure. We're taking on some, I think, sometimes fairly extreme cases. And the final thing, as with kidney, living donation provides an advantage. So this is an important slide. Here is the left lateral segment. It's about 20% of the liver that's transplanted into a child as effectively a whole liver. Okay, so these kids are getting the right liver mass. It just isn't a normal configuration. This is living donation. This was our first mother-child combination 31 years ago. And this is what it looks schematically. You can see good sized liver sitting comfortably in a sort of anatomical position, and the quality of the grafts are good. The technical complication rates go down because the blood vessels you're anastomosing are slightly bigger than if you're using a size match from a young child. And this is where it starts to get more tricky. This is a liver from a neonate with neonatal hemochromatosis, and this is where we're transplanting the children under 3 kilos. And we've been able to use, for example, living donors to transplant children down to 3 kilos now. So the combined liver and kidney transplant, well, it combines aspects of both, and we've done it as deceased or living donor. The living donors tend to be sequential. So the children get a liver, say at age 6 months or a year, they'll grow a bit, and then they'll get a kidney. And they'll often get the kidney from the same donor, and that has worked extremely well. As you sit here after lunch, your liver accounts for about 2% of your body weight. So most of you will have a liver weighing about 1.5 kilos. If it's more than 2 kilos, you should come and see me at the end. And the liver, whether it's whole or partial, is implanted first, and it goes into the right upper quadrant. For us, with the liver, we're taking good quality donors. They're under 40 years of age, by and large. Primary non-function is rare. I can think of 3 or 4 in 1,400 transplants, whereas delayed kidney function seems to be more common. I won't talk about the complications, I don't think. So what is there in the world literature? Well, the first thing to say is this is data from the US, and it was over a long period of time, 1983 to 2016. And you can see that whilst there are over 7,000 combined transplants in adults, in children there are only 297. And the other striking thing is how few were under 1 year of age. So I think that reflects a number of things: a reluctance to transplant small children for much of this period of time. Up till 1988, children under 10 kilos were turned down for transplantation. So there's been a change there. And also a lack of referral of the very small children until quite recently, because it was thought their survival would be too poor. So at the moment, there's somewhere between 10 and 30 combined liver and kidney transplants being performed worldwide. So if you look at the North American data again of 150 odd primary transplants, you can see that the patient survival at 1 year is just under 90% and just under 80% at 10 years. And the liver graft survival seems to be just a little bit better than kidney, but obviously this does not reach statistical significance. And what I put at the lower end here is a isolated liver and kidney patient survival over that same period of time. If you look at the Paediatric transplant program in Poland, it's the only one that does children in Poland, so they are the national experience. They reported 25 combined cases. This was 5 years ago, with a reasonable follow-up of just over 4 years. But you can see their patient group was rather older, median age of 16, with a patient survival of 92%. Again, with the kidney graft outcome being 84% at that median follow-up of just over 4 years. And here, looking at the polycystic kidney disease, what I want to draw your attention to is this bit up here. The children's median age of 10 years. They had portal hypertension due to congenital hepatic fibrosis or platelet abnormalities, and with a liver and kidney graft survival of 72 and 88%, again with a similar sort of follow-up. This is a paper from Birmingham looking at small children. They define the small children as being under 15 kilos. That's usually somewhere between 12 and 15 kilos in weight. And the donor to recipient body weight ratio was 4.8. That's high. Okay, I told you normally it's 2. Once you get that high, you start to see blockage of hepatic artery and portal vein related to the thickness and compression of graft. And what they reported was that the survival seemed to be the same as for children greater than 15 kilos, 87 versus 93%. So that's good. So what about the specific indications? Well, primary hyperoxaluria, I won't say too much about the condition, other than to say we now have genetics that provide guidance as to how things are going to play out over the longer term. The discussion in the literature has been, should we be performing combined or sequential? And even now, what I believe in is preemptive liver transplantation. I think it still remains very controversial. In this particular condition, I've put out the outcomes here, that at 10 years, patient survival for this condition is 69%, with 60% of livers surviving at 10 years. You can see the date is 2005, and I think things were really very different at that time, and we will have improved significantly. I think the problem with primary hyperoxaluria is every child is a little different in their genotype and phenotype, and you get this widespread oxalate deposition, which can affect cardiac function. So whether you do liver first or combined, I think is determined by the child size and occasionally by the systemic disease extent. For me, if we could do early diagnosis, identify those that we expect to run a very aggressive course, and transplant them before their eGFR falls below 50, then you can preserve their native kidneys for long periods of time. In this paper published recently, again, a single country experience of 18 children with primary hyperoxaluria. They were looking at the long-term outcome, which was a median survival of 9 years. You can see they have improved. The kidney at 15 years is a 75% graft survival, and for the liver, it's 85%. They had one death in this series, which was a child with Down syndrome who died early post combined liver transplant. You can see their experience is primarily combined. And the reason, I'll pass over that. And the reason for that, sorry, I haven't got that on the slide, is that the majority of their patients were a little older, 12 years, and therefore I think that influenced their decision making. They had a couple of children that were very young, but few under 6 months of age. So this has been the first paper published looking at preemptive transplantation in primary hyperoxaluria. And you can see in these patients transplanted that in 3 out of the 4, the renal function remains stable over a long period of time. And that's been our experience as well. When we reported our experience of 8 children, we had 3 who underwent preemptive liver transplantation with a GFR of 40. And out of these, only 1 has required transplant about 8 years after. And the world experience says that if the eGFR is greater than 50, you can expect native kidney survival to be in excess of 10 years. So I think that's meaningful and helpful in terms of managing these patients. One of the other conditions is methylmalonic acidemia, which is again a rare autosomal disorder. The liver looks normal, they get kidney failure. Actually, this is a systemic disease. These are children that are tricky to manage infection. Stanford, whom we heard from, published a fantastic series of 14 cases, older children than we tend to see at King's, with a mixture of indications for transplant, including renal disease and metabolic. You can see 12 whole grafts and only 2 partial grafts. but they published 100% survival with one liver retransplantation. That for me is the gold standard internationally. These are tricky children to transplant. They get a lot of complications. Their wound healing isn't particularly good. And then I'll pass over this because I think it's sort of come and gone. We were encouraged to go into a program of doing auxiliary liver transplants in conjunction with kidney transplants for sensitized patients. You put the liver in, it mops up all of the antibodies, and then a few hours later you can put the kidney in, and people were reporting successful outcomes. This is a scheme of it. Actually, we use auxiliary liver transplant in acute liver failure. We have a child that comes in, put an additional piece of liver in, child survives, wait a year, the liver recovers, wind down the immunosuppression, the graft atrophies, and their native liver grows back. For a child, it means life without immunosuppression, which is a huge advantage. So, in summary, it's an uncommon procedure, very uncommon. There's been debate in the literature about doing simultaneous versus sequential, but as I've said, it's usually dictated by the size of the child. And for me, 6 to 12 months is the benchmark for small to large, the extreme under 3 kilos. There are some advantages of a combined. It protects the kidney. You see, I think, better survival of the kidney graft in the long term. But if you can do a sequential from a living donor, as we've done in conjunction with our colleagues here, that to me is a fantastic way of doing things. And with the advent of genotype and phenotype, the advent of new medications, it's changing the field quite rapidly. So I make a plea that good outcomes are associated with complex team working. The complex surgical side, I think, is straightforward. That's what we're trained to do. It's the complex team working around the child and the family to produce a good result. And the plea is everyone thinks everything's finished on the day of transplant. The parents say, oh, thank God the child survived transplant. And you say, well, that's our expectation. They don't die in theatre. This is where the challenges start. And for me, the challenges are both in the short term, getting them through the first 6 weeks when there is a risk of them dying, into a long-term program. But all of these kids are coming into adult life now. There's a whole cohort coming through, and they need specialist care of people who understand children's disease within an adult context and to manage them through their adolescent and early adult life when they're at most risk in the whole course of their transplant life. Thank you.
So, you have a question?
Yes, I do. Nigel, just want to ask you something that we talked about at times. When you transplant these children, when you take healthy livers which are enzyme deficient, why do you think that we are not proceeding and implanting those livers maybe in some senior donors in whom the enzyme defect may not cause that many troubles as it did in children? For example, somebody who is in the desperate need of a liver transplant, I'm sure they wouldn't mind getting a enzyme deficient liver if that's gonna mean that they're surviving.
Yeah, so that's a good question, and the answer is we did do that. We've probably done about 40 domino transplants, where you take one out of someone and give it to someone else. We did that first for familial amyloid polyneuropathy, and we were the first people to report de novo disease in the recipient of familial amyloid polyneuropathy. And it was very painful to see someone develop a neurological condition that slowly progressed. He came to retransplantation purely because of that, but he was left with a long-standing neurological injury. We were the first person to report that. That was 9 years post-transplant, but now it's become well recognized, and the threshold for developing de novo disease with that condition is somewhere between 8 and 10 years. I've seen other people die as an outcome of that, and even when they're 75, I mean, it's getting closer to home now. It used to be so far away, it didn't seem important, but now, it's even 70s starting to look quite young. It is very painful and very hard. In India, in China, they're taking a piece of liver from 2 children with different metabolic diseases and crossing them over. Well, within our clinical governance structure, what worries me is 5 years down the line, people have forgotten what the real diseases were they were transplanted. A child may get jaundice and they say, well, that's okay, it's conjugated jaundice. Actually, it isn't, it's unconjugated, and they'll get a brain injury or something like that. Primary hyperoxaluria, some people did domino them, but hey presto, they get primary hyperoxaluria and then they get kidney injury and kidney damage. And that's because of the dissociation between what goes on in the adult world and what's going on in the children's world. The crossover isn't always great. Maple syrup disease is probably the most commonly exchanged liver now as a domino. Again, within the context here, this is a lifelong disease. This is going to go into another child under 5 years of age. They're going to have 80 years of exposure to not a normal metabolic environment. So they may be okay, but I have a problem with that. I much prefer to give them a cadaveric liver and be innovative about how I get people transplanted. So the answer is yes. I have quite a bit of experience. I have my reservations. That was a very long way of saying I don't like doing it anymore.
Any other questions? Okay, well, thank you very much, Professor. Let's give a 10 minutes break after the class. Let's have a 10 minutes coffee break or for some water whatsoever, and let's come back for the last session of today. Yeah?
Hello. Well, I have not any objections to that. However, getting things to work in the system is so it might not gel like that one didn't before. Yeah, you can. I mean, is it up and running?
Good question.
I think Elena said to put in, yeah, just a second, 1 and 2. Just 2. Yeah. Just 2. Okay, that's fine. Carry on. She's the one who promotes the poster in and asks you guys to see. So, you, me, and you. Oh, just 2. That's great. Yeah. Was that an hour? I think just because this one gives sequence to the combined liver kidney, I can make it as long as you want. Okay. 5 minutes. 5 minutes.
Okay, I think there's no problem to have your coffees and, let's sit down again. Easier than have your lunch while watching. So that takes us to the last part of today's talks. And um, let me introduce Sergio Asia, who is one of the senior clinical fellows in pediatric liver transplantation at King's College Hospital. And he's going to start the session named Complex Cases. He's going to take us through an MMA case, I believe.
Yes, hi.
Oh, you don't need
Good afternoon, everyone. Thank you, Nikos. Thank you, everyone, for inviting me. It's a huge pleasure to be with you, a part of my family. All of you are close friends to mine. We've been together for a long time as well. And also thank you for inviting me for a project for Transplant for Kids. I'm always willing to participate for Transplant for Kids. So today we're going to talk something really interesting. Just to give continuity to the previous talks. So this is a child. When he presented to us, he was presented at the age of 3 years old. He's now 7 years old, so he's 4 years after the transplant. And he has a background of methylmalonic acidemia and Williams syndrome. He was diagnosed at 2 weeks of age because of high ammonia level of 400 micromoles. Then he was also diagnosed because of the Williams syndrome with a bilateral dysplastic kidney. And at that time, his glomerular filtration rate was between 20 to 25. Then he also had chronic diarrhea and vomiting. And a very important thing to highlight here is that his quality of life was not that great because he had to be continuously fed with a special feeds that these children require. And then his neurological status was not ideal, and he was not having the normal neurodevelopment. And as you can see as well, his weight was way below the fifth centile. I just want to highlight this because of the follow up. Um, so the first time he came to us, well, we listed him, me being part of Gosh, Prof being part of Kings, in an MDM in August 2020, and then he was activated for in the transplant list in 2021. He was discussed in the beginning for living related kidney transplant as a sequential operation, like in doing the kidney first, and then 6 months afterwards doing the liver transplantation. In order to be listed for living donor liver transplantation, you need to be on the deceased donor waiting list. And the deceased donor waiting list, as you know, it can be quite long because of the points they need to get to qualify for a liver transplant. He was transplanted in April 2021 at the age of 5, and his body weight was 14 kilos. So just a quick overview. Methylmalonic acidemia, as Prof. Eaton said, it's an autosomal recessive disease in which it was a controversy as well. Should we use living donation for this patient because they have the risk of well, if you have a carrier in the family or a parent, you can pass the disease to the child. So that was also a question mark, and I will touch this at the end of the talk. So in methylmalonic acidemia, they accumulate methionine, threonine, isoleucine, and valine, and this also increases the ammonia levels. And they also have a high deposit of odd-chain fatty acid and cholesterol. Plus, add to the child, or add to the complexity of this case, the fact that he has Williams syndrome. So this, as you can see, has many, or it's a syndrome that includes most of the systems and organs in the human body. So it was a challenge also for the anesthetic team, not only for the pediatrics, for the kidney surgeons, the transplant surgeons, but also both for the anesthetists and the intensivists. So he had a transplant. He received a combined liver and kidney. The donor was a donor in his 30s. We gave him a reduced left lobe, which was weighing 417 grams, which is a graft weight ratio of about 2 to 3%. Then it was a cable replacement and duct to duct. As you can see on the right side of your image, the liver this child received includes segment 2, 3, and 4, and he had a duct anastomosis. It was not done as a rule loop because it was a good size match between the duct of the donor and the recipient, same as the artery and the portal vein and the single outflow. And the kidney, if you can see on the right left hand of your screen, it's sitting medially compared to a normal kidney that you're used to seeing, where it sits laterally. That's because, as you can imagine, if you're transplanting an adult kidney to a small child, it's sometimes, you all know that sometimes you have to juggle it a bit to find how it sits better inside the cavity of the child. So at the end of the operation, both organs were working. The lactate was still rising, which is expected, and then the next few hours it started to come down. However, at the time of surgery, it was difficult to close the child, so a silastic mesh had to be placed in situ, which also had something very interesting. Something we also do is when we struggle with abdominal wall closures, we can also bring the fascia of another cadaveric donor. So on this time, we use the rectus muscle fascia of another donor on his 30s with no other comorbidities. So what we see is on the bottom left of the screen, you can see how the rectus muscle come to us. Then we remove the muscles. We only keep the fascia. We only keep the sheets, and then that way we use like a mesh closure of the abdomen. So that's how we managed to close his full abdomen. As you can see during the follow-up, the methylmalonic levels dropped significantly, and despite them being a bit higher or higher than 100, they were significantly low by 6 months. In the follow-up, he was doing well. He was at home. He was having better growth, better neural development, gaining weight, better interaction with mom. However, taking into account that this child had Williams syndrome, which goes with its own neurological development affection. So 2 years afterwards, he developed a tight biliary stricture. You remember, it was a duct to duct. So they have the risk of developing tight structures. So what we needed to do is an ERCP. So insert the camera through the duodenum and go up and try and dilate that bile duct. However, it was very tight, and he was having recurrent biliary sepsis. The biliary drainage was diverted through a PTC, and so we decided to take him back to theater to do a biliary reconstruction. We took that stenosis down, and we brought a limb of bowel there to do a root loop. That way, all the bile was diverted downwards, and the child had a good recovery for the next few weeks and months. He had a bumpy time at that moment because he was septic. He was extremely difficult to manage in ITU. He even had to receive methylene blue as a rescue therapy in intensive care. But then he had a better outcome. So that also at that time he had seizures. He had seizures before the transplant, so he presented as seizures afterwards. And I want to keep this one on top of your minds because he presented again with a seizure, and because he had an MRI pre-transplant to see how was his brain. We could do an interval imaging study in which we could see that there was new diffusion in the left globus pallidus with evolution of changes involving the right side, and this was considered to be a metabolic crisis. So he had metabolic crisis before, and he developed another metabolic crisis afterwards. And this is because methylmalonic acid stays inside the brain. It cannot be completely eliminated, so it stays circulating inside the brain. Currently, he's at home. His weight has recovered and is now in the P25. He has normal renal function, he has normal LFTs, and his neurological symptoms have been improving following his stroke. So this is where you can go and see the case. It's been very nicely reported. You can read the protocol, and the conclusion that has been drawn about this case is that it has to be a multidisciplinary uh, uh, management. So discussion about this type of patients. Isolated kidney transplant may provide 18% of the mutation enzyme activity. Then there's a trapping hypothesis, which I was telling you about the central nervous system, in which the cerebrospinal fluid methylmalonic levels remain raised, and that this makes them have risk of metabolic strokes on the basal ganglia, and they also have some optic nerve diseases. Since parents have no symptoms, 50% of the normal activity is likely to be sufficient to provide metabolic control, and liver transplantation in these type of patients protects against metabolic instability. So in conclusion, combined liver and kidney transplant can be achieved in these patients. we all have to work together. At some point, we will about like I don't know 100 brains thinking for together for this child, plus handovers, plus all of the teams who are involved. It's a kidney team, the liver team, the metabolic team, and you can add a team. And the use of directed fascia can be used in these type of children. It's actually the first case reported as a fascia transplant in a metabolic disease patient. And of course, for this child and for all the metabolic children, they need a tailored management for the disease and complications. So I just wanted to show you how living donation has been done in another country. In Japan, they do living donor liver transplant, and they have really good serum MMA levels post-transplant. So thank you very much, and I can't wait to hear your questions.
Thank you very much, Sergio. Questions?
Well,
that means that either you were too good or they didn't understand anything. It's those two scenarios. Oh, Yellen.
Just a question, really. Now thinking about it, when you presented, Sergio, he did not have biochemical or clinical metabolic decompensation during the 10-hour surgery, nor in the immediate post-operative period. Why do we think that 2 months into the admission this time he suffered major metabolic crisis?
That's a great question. So I have been thinking a lot about that answer, and because he had a decompensation, he was extremely sick while coming back with biliary sepsis. And I just have an hypothesis, and Prof, maybe you please correct me if I'm wrong. Oh, you take it. Oh, yeah. So I think that because there was some degree of liver failure, the enzyme was not properly synthesized, and maybe there was some degree of deficiency with a failing graft, which was very septic, and then the child, all the mitochondria could not compensate properly at the time of a septic crisis episode.
So I agree with that. This is a systemic disease. So replacing the liver only partially replaces the enzyme. You've heard that the brain is particularly at risk because of the blood-brain barrier. You could see when he was newborn with an ammonia of 400, you're likely to get a brain injury unless it's treated very quickly and you're lucky. So that's the first thing. You're only partially replacing methylmalonic acidemia. The second thing is, if a child's at rest and well, how much liver function is required to keep that child fit and well? The answer is probably 30%. So there's a huge reserve. But with methylmalonic acidemia, there may not be that same reserve. And then the third part is people view liver transplantation as curative. So often people say, yeah, he can eat anything he wants now, anything. Well, that's not true for methylmalonic acidemia. They have to remain on a restricted diet in the long term. And so that's part of the education for the medical team and for the family, that the transplant is there to help, but it is not curative, and they need a discipline for this child, short and long term. Because in methylmalonic acidemia, a late complication of stroke is common. And people present the data of 4-year follow-up. Well, that's hopeless for a 4-year-old child. It's meaningless to me, because these stroke complications come at age 10 or 11 when the transplant is in the distant past. And then the final thing is, I'd be critical of us at King's, because it was a deeply frustrating time with him, because he got a bile duct complication, he got recurrent sepsis. The methylmalonic acidemias don't manage sepsis well, and we failed to get him in. And we had him lined up for surgery on one particular time when we had a conversation, and he got bounced because someone else thought another child had a priority without discussion. So he came into it late with recurrent sepsis in a condition that almost cost his life. So this business of working together, it doesn't always happen, and it can be catastrophic. So Sergio presented it very nicely, but behind the scenes, we almost had a disaster. And you were pushing very hard, weren't you?
Thank you, Sergio. Very nice presentation. and we all remember the case very well, the bad times and the good times. Now, yeah, absolutely. Even though you replace the liver and the kidney, the rest of the body still has the disease, to be honest. So that's why it's still a problem. And we do hope that, and you did some studies show that there's less strokes after metabolic disturbances, but actually they still do happen. And this is just an example of that. Thanks.
Thank you, Sergio.
Thank you.
So the next person is Benedict Phillips. Actually, me, Sergio, and Benedict, we have something in common. You know, guys offers this pediatric transplant fellowship, and Sergio has done it before all of us. I did it at some point. The current pediatric fellow and senior clinical fellow, obviously, is Benedict Phillips, who is going to take us through another case now.
Yeah, I'll take that. Oh, no, no, why don't you take that? I'll keep this as well. This is working. Yeah. Yes, it will be. Thank you very much, Mr. Papadakis. So I have the pleasure of discussing a fascinating case, and we know that many of the children that we take care of are very complex, but occasionally there is complexity from the perspective of the donor. And so this is a particular situation in which the vascular anatomy of the donor was complex, adding to some of the interesting points of this case that I will systematically bring to the panel for their opinion. So we begin with a patient who is 9 years old, female, with chronic kidney disease and a mutation in the NPHP4 gene. And we know that this gene does code for an important protein that is related to renal tubular development. And this is, has a pattern of inheritance, which is autosomal recessive, and as a result leads to nephronophthisis, a form of ciliopathy, resulting in hypertension, anemia, and consequentially chronic kidney disease. This girl has a brother with the same condition, and it's a very strong family unit with strong faith. However, the wider issue of financial difficulties, social difficulties, and difficulties getting housing support. Of course, the anxiety from the family's perspective is, of course, trying to find donors for their children. Father not medically well enough to be a donor, and mother wanted to be a donor. But of course, with 2 children in the family approaching end-stage renal disease and the anxieties about who would be the donor, as well as the logistical and emotional difficulties of having potentially 2 children on dialysis, obviously adds to the wider picture of what was going on for this family at the time. So now with the patient aged 10 years old, worsening serum creatinine, and sent for assessment by the transplant surgeons at 24 kilograms in July 2019. She was activated on the deceased donor waiting list as living donation was becoming less and less likely. In the middle of this, COVID-19 hit, and whilst the aim for this patient was to transplant her as early as possible, preemptively, to avoid two children in the same family on dialysis, unfortunately, this caused an understandable delay in everything, and the patient started hemodialysis whilst the transplant program was paused. Thankfully, she was reactivated on the deceased donor waiting list with a slightly more relaxed HLA criteria. And I have many questions about this relaxation of HLA criteria in our pediatric recipients relative to our adults. Thankfully, the pediatric nephrologist received a phone call from NHS-BT offering a altruistic donor, 32 years old, no medical problems, a favorable HLA match, fantastic kidney function. And this was the donor anatomy. And may I ask, Ms. Saran, looking at the donor anatomy, would there be a kidney side that would be preferential and why?
The left kidney would always be preferable because of the longer vein, and in this particular case, the simple anatomy. From the recipient surgeon point of view.
Absolutely. With a little bit more additional information, this unit underwent split function. Would this split function worry you, Nikos? Okay, so this nuclear scan determines what the proportionate function is on either kidney. So the assumption with equally sized kidneys is that each kidney is probably contributing 50% of the function, which is why some units do not routinely do it. So at Guy's, we do not routinely do this additional scan unless there is an obvious size discrepancy on the imaging that we've undertaken. But some units do, and as a result, the general feeling from the donor's perspective is to leave with the donor the better function. So the donor, the center, offered the right kidney. So that is the kidney with 46%, which is fine, but with apparently 3 arteries, 2 veins, and 2 simple cysts. So simple cysts are fine. Obviously, more complex cysts might require follow-up to avoid malignancy in that kidney in the future. So on this basis, would you be happy to accept Professor Marks? The right kidney.
I'm not the surgeon, so of course it'll be easy. But yes, I also know the case, and it's difficult because actually, as you said, we still discussed for a child we would have preferred the left, but the left has no longer been offered because the donor's been counselled by their donor team.
What Leeds has to say? What Stuart Faulkner, he's from Leeds, pediatric surgeon.
So yeah, there's a couple of things. First, I can probably guess what center this is that was a donor, but we'll not go there. So talking about, the split function thing's interesting. Are there any radiologists here? No, fine. The reason I say that is that actually, if you speak to a radiologist that does this test, they will tell you that we sort of just, because radiology, we just take their word at what they say, and we think that it's quite exact. And a lot of the stuff they do is very precise and very impressive. This test is not one of them, and they will tell you that it's actually relatively imprecise and it's quite subjective, and there's got a lot of sort of operator variability, which is why generally it's accepted that if it's within 5%, that's a standard error margin. So if you measure the same aliquot of blood twice, you may get different results. There's an error margin, and this falls within that. So this kidney, the right and left, the split function is equal, and we would treat it as such. I do understand not every centre does that, and my personal view that's not the right thing to do. Obviously, you're going to have much more complex anatomy to deal with on the right side. If there was no option for persuading your donor centre for the left, then the next thing you really need to get some more information on is what are these 3 arteries and 2 veins like. It may be that the 2 veins, one's big and dominant, and the other one's small, in which case you'll just ligate it. It may be that there's a tiny upper polar artery, and therefore you've just got 2 arteries to join, and that's fine. Or it might be 3 very small 2mm arteries that are going to make you upset, and probably pick up the phone again and try and persuade them. So that's probably what I would be looking at next.
On that basis, the scan on your screen now is exactly that. So you see 3-ish visible arteries that are approximately the same size. So yes, that is consistent with my discussion with Martin Drage, the surgical lead, is that within 5%, that's essentially margin of error, essentially normal. However, regardless of that, the right kidney was offered and the right kidney was accepted. So just thinking about consent. Sorry, Nikos.
Yeah, just to add a bit more drama into the equation. Yeah, they did ring Steve, but then rang me. And of course, if you're offered a living donor kidney when you're on the deceased donor list, I mean, there's only one answer there as far as I'm concerned. So in fact, this particular donor was offered somewhere else and they rejected it, you see. And then we're lucky enough to get it on the second sort of in the queue. So yeah, of course we said yes, and I tried to ring the unit, and I spoke to them, and they already discussed it twice in their MDM, and they said no, we're only going to give the right kidney. So we were stuck with that, but not disrespect to the kidney, it's a good kidney.
Two comments. With multiple small arteries, I try and get a cadaveric SMA, and to try and get it the day before or 2 days before. And then you've got a number of tributary or branches, and you can anastomose very nicely those 3 arteries on the back table under the microscope, and then have a single anastomosis in the recipient. So the question is, do you think about that? And the second thing is, I think it's important to think about the recipient when you're talking about cysts in the liver or the kidneys, because cystic disease of the liver and kidneys is different in men and women. Obviously, in women, these cysts are exposed to a significant period of life with estrogens and progesterones, and therefore they tend to grow. It's not the same environment in men. So I think that's also something to keep in mind when you're talking about who the graft is going to go into.
Yeah, absolutely. Well, in my discussions with the other unit, I was sort of guaranteed that I'll get 3 arteries. So I thought, okay, 3 arteries, not too bad. So I did aspirate diseased donor vessels for this occasion. Thanks. Let's carry on.
So you're absolutely right. A living donor kidney, when someone's waiting for a deceased donor kidney, it's difficult to say no, which is why we proceeded at this point. So just think about consent. How has this slightly changed the consent process? Is there an increase of risk of something? So this is the consent form, and we can see an altruistic donor renal transplant. And it's interesting that actually on there, it had the foresight to say post-op heparinization. And looking at the other bits of the consent form, you can see additionally, we've got bleeding and thrombosis, multiple arteries. We've got post-op heparinization, and we've also got reoperation. So, this is a great consent form, other than the handwriting, but it's a good consent form. So obviously that's all been taken into account. So that's great news. So it is the day of the procedure, and the donor operation is in motion. A phone call to the recipient surgeon that whilst it kind of was 3 arteries to begin with, it's now become 5 arteries, with a small area of reduced perfusion at the upper pole. How did this change your appetite to proceed, and did it, and what was going through your mind, Nikos?
Yes, I was there with George. We were waiting for this kidney. And yeah, I got a call from the surgeon saying, during the stabling, the upper artery essentially was taken a bit further up. And he was trying to explain what the top diagram shows through the phone. And he was saying, you just like at the top. He was essentially saying, but I didn't quite get that message through the phone. And I decided, obviously, I'll have a look at the kidney as the next step.
And this vividly graphic image here demonstrates the 5 arteries and, of course, 2 veins here. So the left-hand side of your screen is the upper pole, and 2 small arteries that were hanging on between their mucosa and everything else there. So proceeding on, just thinking about what could be done with this potentially. There is obviously the opportunity to spatulate two of the arteries together to form a common orifice. There's even this description of spatulating three arteries into a single common orifice. There is swinging branches onto the side of main renal arteries. There is obviously implanting them individually, and if you do so, you have to decide where they're going to go, on the external or on the common iliac artery. And of course, there is also, as a professor has described, is using some of a patch from a deceased donor, either an aortic patch or even better, an SMA with that cluster of lumens, to allow multiple arteries to become a single anastomosis. The decision was made to implant all four arteries, essentially spatulating two of the upper poles and putting that on the common iliac artery, and the remaining three arteries were individually implanted onto the external iliac artery. This is the end result. We can see the anatomy. So this side of the screen is the head end, and with 1, 2, 3, 4, 5 arteries. Mr. Papadakis, did you perfuse all 5 at the same time, or did you unclamp and then complete 2 or 3 or 1 final anastomosis more distal?
So apparently we have the option to clamp distally, do the initial anastomosis, even reperfuse, and then clamp further down and do the rest of the arteries. At that point, we discussed with Nikos, and we said, well, let's start and see how it goes. It went quite smoothly, actually. And, by the time we had anastomosis, the fourth artery, the warm ischemia time was something like 50 minutes, 45, 50 minutes when we had done already the 4 arteries. So we said, you know what, let's just do the 5th one as well. So I think it was something like about an hour of warm ischemia time. So we did it all together.
Yeah, I think that makes a lot of sense because you've already done it very quickly. You might as well just do them all. If things were slowing down, perhaps you would just say, well, let's get some blood into most of the kidney and do the rest later. So
but that's something that you can discuss at the point, It just went really smoothly.
Yeah. Yeah.
We did tie the second vein.
Yeah. I think that's wise to ligate one of the veins so that,
it wasn't that small, but we were running out of space for proper anastomosis with the second.
Yeah, I think running out of space is the right thing. Yeah. Okay, so that's the heparin is. Would people heparinize? Put your hands up if you'd heparinize this patient afterwards. Yeah. So some heparin was given. Target blood pressure. Do you feel that you need a slightly higher pressure to get through these small arteries, or just see how it goes? Or aim for a donor blood pressure, or aim for a recipient blood pressure, or what's your general feeling?
Well, we have.
Sorry.
Sure.
Thank you. I was just going to say I was on call that the day this patient got the transplant. So it was I was told 120 to 130 would be the target blood pressure. And it was really tricky to get it because her baseline is she was an annual child. It's very difficult to get the blood pressure up. So she was on inotropes on the night of the ITU, but obviously we didn't want her to be on inotropes. So she came off dopamine in the morning and then, But I think we relaxed it once the heparin came off but it was very difficult to get the blood pressure up to 120, 130 because she's not that big and so it's difficult to get it there.
I think the guide most of the times is the blood pressure at the moment of reperfusion, provided that you're happy with the perfusion of the kidney. And that's what we're aiming more or less, isn't it?
Postoperatively, as we've heard, is the patient was hypotensive, going to PICU and requiring some inotropes as well as human albumin solution, but did go to the ward, did develop a perinephric hematoma that required exploration and washout at day 13. But all in all, has had a really fantastic result with a baseline serum creatinine a few days ago of 41, which is incredible. So what is the evidence base? What are the outcomes of multiple artery kidneys, and does it have a bearing on long-term function? Well, unfortunately, this was published in the New England Journal of Medicine in the same, just a few months earlier, from a UK group, obviously a deceased donor kidney with also 5 arteries, but as you can see, they had the benefit of having a patch. So it has been described. But what are the outcomes? There's quite a bit of low quality evidence out there, but looking at this systematic review and meta-analysis of 50 recipients relative to a higher proportion of a single artery anatomy, is that there does seem to be a higher complication rate. And this is borne through in the 1-year graft survival. Warm ischemia time is, of course, longer, but when looking at 5-year graft survival, they're very comparable. Any further questions? And of course, acknowledgements to Nikos and Georgios for doing the operation, our incredible nephrologists, coordinators, and nurses at Great Ormond Street, the anaesthetic team, and of course, patient and family. Any other questions?
Thanks, Georges. The only thing I would add is that obviously the family's dynamics were quite tricky in the sense that there was another sibling who had a failed graft, had gone back to dialysis. So it's whatever, as in when we said what happens if you have 6 arteries, what's your concern then? I don't think for the family that would have been, I mean, they would just say, please doctor, do whatever you can, because, and that's, I think, what drives all of us. And I give it to Nikos and George, but I think we can't then at that time, I would have thought, said, no, we can't do this, or because then it becomes just for the family's sake, it is difficult.
Yeah, no, obviously I spoke to the family thoroughly before the transplant, and indeed about the potential in between once the kidney was on its way down. And the mom actually wanted me to anastomose that extra sort of 2 arteries. So I said, I'll try. So we did. Thank you.
There's a wonderful article written by a retired nephrologist from this very institution, I'm sure Nikos has read, where he actually became the living donor for one of his relatives. And he had multiple arteries and things didn't go so well. And it really talks through your emotions as a living donor about, are you going to be able to be a donor or not? And then you can be, and then the worries, and then actually if things don't work out the way you can. So I think for this patient, it was an excellent outcome. And I think Zainab's right that we did talk a lot about the family with 2 children. But the other thing, which was even at the back of my mind, is we had been knocking on the door to NHS Blood and Transplant because we had a national crisis with the number of children on dialysis. So we didn't get this kidney actually just by luck. We got this kidney because what we wrote in was the fact if there was an altruistic donor which came forward that was turned down by an adult centre, that it would be preferably offered to a paediatric centre. So actually, when you have algorithms and you make a decision that I'm not accepting this, as Stuart says, it really, you look at the individual patient and you have to think about all the context. So you're right, we said the same thing about the DMSA. Does it really matter? And then when we were told this was the only kidney on the offer and there was the only kidney that we could get, we thought it was in the best interest. And I remember discussing, Nikos, 3 may not be 3 and how good was the imaging and what, the other centre, is there anything else that we could do? So I think you really have to think about the individual patient and everything into context. So I think in one aspect, we were very lucky to have such good surgeons, but we're very lucky to have a good outcome for the patient. just very quickly, I would agree with all of that. And I think it raises a really interesting kind of ethical dilemma where you've got someone who's donated a kidney who is emotionally invested in that having a good outcome. And you could, well, I would argue the transplant team have not necessarily done that donor the best service because they've misinterpreted that split function and then allowed them to donate a kidney. It's probably higher surgical risk from a donor surgery point of view as well. It's much easier to take a kidney with one artery than 5, I can tell you that much. It would not be a fun day at the office for me at all if I was doing that operation. So they've got higher risks as well unnecessarily, and that's then immediately transferred into the recipient. And it's only because of Nikos and Georges's exceptional surgical skills that they've managed to pull that off, because that is not something that would any of us would normally enjoy. Doing something like that is really, really tricky. And hats off to you guys for doing that, because I think we would have not. I don't know what we'd have done if we got offered 5 arteries. We would have probably phoned Nikos and said, "Do you want to come to Leeds and give us a hand with this?" Is absolutely awful. So well done on that.
Thank you very much.
So I would add a well done to that. I know nothing about kidney transplantation, so you can laugh. So any centre that offers out an altruistic donor that's not going to use the donor themselves, that's a small red flag for me, first off. Secondly, when there's complex anatomy, that's a big red flag for me. And then I'd be looking at the surreptitious markers of surgical competence here, because they haven't got the staging or the assessment right. How long did it take for the kidney to come out? How good were the arteries when you got them? Did they look healthy, or did you look at some of the cut bits and they looked a bit chewed? So I'd be thinking, well, how good is this kidney being pitched up now? Has it had a hidden traumatic journey, or is it had a nice calm sail down the Thames to Guy's? And my question is, then try and do the back table under controlled temperatures, 4 degrees. You won't get a warm ischemic injury. It always worries me, because you never quite know, is it going to take half an hour, or are you still struggling and swearing at 2 hours? And the final thing is, what about hypothermic machine perfusion when you get these kidneys that have traveled a distance? Just optimize everything. Even if you get a 5% advantage, that's 5% you'll never get back post-reperfusion.
Yes, I mean, all these little things added up, of course. Now,
I'm not criticizing.
yeah, sure. Oh, no, it's all points to consider. The arteries were in good condition. It's unfortunate that they took a little bit more on the upper one, but I guess what the surgeon was telling me over the phone, and I didn't quite get that, was just tie the upper 2, so just stay with the 3 arteries. I was guaranteeing you before, but. Anyway, I didn't know how much they were perfusing, to be honest. I had to sort of assume, we should still use them. And but they were just held, the upper 2 were just held by, nothing really. So, and the angle wasn't right. So I had to trouser them properly, to be able to come down and be proper artery for anastomosis endocyte to the iliacs. So once we sort of simplified the anatomy to just 4 arteries, 1 vein, it looked more appropriate to implant, and it didn't take that long. And because of the multiple arteries, though, we couldn't use machine perfusion, because there usually it's just 1 artery, and also they were quite small, these ones. And also it's a living donor, so we haven't really done much on the living donor in machine perfusion. But maybe Ben can tell us a bit more about that.
Yeah, in terms of normothermic machine ex situ perfusion for kidneys, my general feeling is that it doesn't matter how many arteries there are, because what you can do is just use a graft, synthetic graft, put your ostia in there and just perfuse through that. But still, at the end of the day, once that's done and you need to cut the arteries off the graft, your vessels are going to be smaller, and once you refresh the edges. So so there's always that. But what with the evidence base, it may not necessarily have improved delayed graft function rates, we know that, but what it can do is determine whether there is perfusion deficits, which may or may not have been important in this case.
Great. I mean, I would love to keep talking about this case forever, but we have a schedule to proceed. So Ben, thank you very much. It was a fantastic presentation. I think I'm going to steal 2 seconds. Okay, go ahead. Clap for Ben. But following this discussion, and maybe I didn't have the opportunity to do it in public before, I really want to thank Nikos for that opportunity to do this case. I was a trainee at that point, and it's not easy as for a consultant to allow a trainee to go through this whole case. So, Nico, thank you so much. And now I'm passing the microphone to Professor Flynn, who's going to chair the rest of the session.
Okay, and we're shifting the schedule a bit. So we have just 2 talks for the afternoon left. And then, yes, 1 talk from today will get moved to tomorrow. And then I guess the patient and family couldn't make it for them. So our next talk will be Dr. Arslan, who will talk to us about current practices in management of children with failing allografts.
Thank you very much. While we wait for the load, thank you very much to Yelena and to Nikos for the invite to talk about failing allografts. It's the second last one. Thank you very much. It's not clear. I'll be talking about current practices in the management of children with failing allografts. This is preliminary data from the European Society of Paediatric Nephrology working group work that we're undertaking right now. Throughout the day, we have learned how we've improved kidney transplantation in children and improved outcomes. The allograft outcomes have improved with reduced rejection rates. Recurrence of primary disease is reduced because we know better about the disease. Progression of CKD is halted because we understand the mechanisms better. But there are some issues with this as well. Because these patients are on immune suppression, they can have viremias and urinary tract infections that eventually lead to allograft dysfunction. Cardiovascular outcomes we learned about earlier, where hypertension leads to allograft dysfunction, obesity and diabetes also plays a part. And it's not just about the allograft in itself, it's also about the growth of these patients, not just linear growth, but also developmental growth and quality of life. What I'm essentially trying to say is that however hard we try, most of the children will require another kidney transplant because we're transplanting them earlier in their childhood and we're transplanting more complex patients. They will probably require a kidney transplant before they've even transitioned to adult life. The estimated half-life of a really good kidney is probably between 12 to 15 years. And we know that adolescents have a worse 5-year survival of the graft than if the kidneys were transplanted at less than 11 years of age. We know the reasons for allograft failure. That's very well documented from this review a long time ago and subsequently since then as well. Chronic allograft nephropathy stays the biggest factor in allograft failure in children, along with disease recurrence, infections, which include viremias, and also non-compliance adherence, which is a big issue in the adolescent population. We do know that grafts fail, but we don't know what to do when they fail and how to look after them. KDIGO undertook a controversies conference last year in March where clever people came together to try and understand how to look after patients with allograft failure. This is adult and pediatric. And they came up with 4 strategies of research that is important in this area because it's so poorly understood. One of them being understanding the definition of a failing graft. And I'll come to that in a second. We were involved, Yelena and I, doing this British Transplant Society guidelines for failing allografts, where we co-wrote the pediatric chapter. Although we went through the evidence. There was very poor evidence, as we know, and the data is quite scarce on what to do with these patients. So we wanted to understand how to look after these children. And in order to come up with guidelines as to how to best look after them, we have to know what we're currently doing. So that's what I'm going to talk about. So our project is actually the 3-step project. We're on phase 1 right now. We're looking at the current practices of management of these children across Europe. We then propose to prospectively follow up and understand the optimal management of strategies for these patients so that eventually we can produce some practice guidelines for good outcomes for these patients. For that, we did a 2-part survey. The initial survey was sent out in April 22, where we sent it to all the European Society of Paediatric Nephrology working group members in the 3 working groups of CKD-MBD, dialysis and transplantation. They were asked to respond to the survey. One was to try and understand people's appetite for such a thing, to understand failing allograft, but also to try and come up with a consensus of a definition of a failing graft, because we can't try and understand failing allograft till we actually have a definition of it. As you can see from the responses, there were many different variation of responses. We got 40 pediatric nephrologists from 34 centers who were interested in undertaking a further study. But as you can see, defining a failing allograft was different. So the definition varied from a decreasing EGFR from anywhere between 30 to 15 to actually commencing dialysis was one of the options. And as you can see, some of them actually said there was no definition because there was no consensus definition. So armed with this information, and also, there was lots of appetite, basically. What we're trying to say over here is that people had lots of functioning allografts and failing allografts, and there were lots of centers who wanted to have a follow-up study or a retrospective study to look at how we look after these children. Armed with this and having further discussions within the ESPN working groups, we set up our retrospective study, which I'm going to talk about now. And we defined failing allograft for the purpose of the study as an EGFR of less than 30 ml per minute per meter square for more than 3 months, as in it's irreversible damage that has already happened. We said we will look at children who had their transplant at the age of less than 18 years, and we do a retrospective data collection for 3 years. For centers who were already contributing their data to CERTAN, which is the collaborative registry for transplantation in Europe, we extracted the data from CERTAN registry to try and avoid duplicating the work for those centers and sent it out to them with an already populated Excel sheet. What we wanted to study was 4 aspects of failing grafts, 4 different aspects of failing grafts. One was cardiovascular outcomes of these patients. So in terms of hypertension, were they hypertensive at the time of graft failure? What kind of medications they were on? Were there dyslipidemias? Were they diabetic? Were they obese? Secondly, we wanted to look at their CKD, MBD. There is some data that's coming out from the CERTAN registry in terms of CKD, MBD in transplantation, but we wanted to look at failing allografts and management of anemia, acidosis, and growth in these patients. We wanted to look at what happens to immune suppression, because we don't really understand what is the optimal therapy for immune suppression reduction in these patients. We don't know what happens with viremias or malignancy rates. And it's not just about the medical management, it's also about the management going forward. Certainly, someone who's had a failed transplant needs discussion about either further transplant or dialysis options, and actually a lot of psychological support for transition. Not just transition, but also transition to the next step, because it's a big psychological burden. So from the 34 centers who had expressed interest, we have results so far from the 17 centers, 2 of whom said that they did not have patients with failing allografts. So we have results from 15 centers to report right now, and this is unpublished data. So, and this is the first time anybody's hearing it. So all of them are from Europe, actually, and 3 countries where we've got the most responses from is UK, Germany, and Italy, whereas we've got others who are going to be contributing as well. Thank you. So just demographics on the first instance. So we have 74 patients who we've got the results for, and 70 of whom had a first kidney transplant. For the purpose of this analysis, I'm only going to be talking about the 70 patients. The mean age at the time of transplant was 7.8 years, with a median age of 6 years. About 20% of them had preemptive transplantation, which is which is probably similar across Europe, but you would, we don't know if that's an indicator. So obviously the numbers are quite small to make any statistical difference, but I'm just reporting as they are. There were about 36% of patients who had living donors, and their average mismatches were 2.7. The underlying etiology of children with failing allografts, the assumption would be that perhaps glomerular disease will make your graft fail quickly, but that wasn't the case. The spread of the disease is similar to what we would see as pediatric nephrologists. CACOT was congenital anomalies of kidney and urinary tract was far majority of the patients who had a failing allograft as well. And you can see the rest of the numbers are pretty much similar to what we see in pediatric nephrology. So coming specifically to their cardiovascular outcomes. So at the time of allograft failure, 3/4 of the patients were either hypertensives as described by their center, and I don't know what definition they were using, or they were on antihypertensive medications. As you can see from the graph over here, a majority of them were on combination medication, and by combination I mean more than one medication. Quite a few of them, some of them were on monotherapy. About 50% of them, so half of them, had a 24-hour blood pressure monitoring performed as a part of annual surveillance, and with quarter of them having left ventricular hypertrophy at the time of allograft failure. About 60% of them continue to have annual echocardiograms as a part of surveillance for their failing grafts. In terms of diabetes, annual surveillance for HbA1c occurs in about 40% of the centers, with about 10% of the patients reported as having developed diabetes post-transplantation. This is before graft failure. Annual lipid surveillance takes place in about 60% or 55% of the centers, with some of them requiring lifestyle modification and statins for reducing their lipid levels. Moving on to their CKD MBD surveillance. So as you can see, bone parameters are really important. The orange lines represent the normal range of phosphate and PTH, and you can see most of them have very poor control of PTH and phosphate, and that's a recipe not only for bone disease but cardiovascular disease going forward as well. And so very poorly controlled both phosphate and PTHs. Quite a few of them were acidotic and anemic at the time of allograft failure. This data is from the time of allograft failure, and you can see about 50% of them were, more than 50% were anemic, and quite a few of them were acidotic at the time of allograft failure. But during the course of their follow-up, quite a few of them were on medication to try and settle down this issue. So vitamin D analogs, iron supplementation, and bicarb supplementation, along with erythropoietin and phosphate binders, which were started on during the course of their follow-up. Moving on to immune suppression changes after allograft failure. So this was a bit more difficult to pin down because it's very difficult in a retrospective analysis to understand at the time point where immune suppression changes took place. But from the data we have so far, most of the immune suppression changes took place when the patient started on dialysis, with some of the changes having taken place when the EGFR started to be below less than 30. Most of the patients, nearly half of them, did not have any immune suppression change at all of the data we have. So it's not that much we have. 43% of them continued with all immune suppression as such, and quite a few of them were on triple immune suppression, so including CNI, antimetabolite, and steroids. When medication changes did take place, about 30% of them stopped their antimetabolite and continued with the CNI, and only a few of them stopped all immune suppression, and this was mainly after the initiation of dialysis and transplant nephrectomy. Ongoing DSA monitoring took place in about 3/4 of patients, with 1/4 reporting that they did not continue to monitor DSAs because allograft had already failed, and about 50% of the patients had a donor-specific antibody at the time of allograft failure. Viremia monitoring was prevalent throughout, with about 100% of the patients, only one not having a viremia monitoring. Otherwise, everybody had viremia monitoring ongoing as a part of allograft failures, with 2 patients who developed post-transplant lymphoproliferative disease, but that was prior to allograft failure, not after transplant failure. And about 10% of the patients had a graft nephrectomy after allograft failure. Moving on to the next step. So we think that's very important for these patients, especially not just in terms of CKD management, but to understand going forward the psychological burden of things. They need access to multi-professional teams. And we asked the question about which patient, if these patients had access to a dietitian and psychosocial team, and most of the children after the 70 had access to these teams. But as you can see, play specialist and youth worker were less, patients had less access to them, and obviously they are very important in understanding the psychological burden for these families. In terms of next steps, when on the last follow-up, about 44% of the patients were back on dialysis, most of whom were either on hemodialysis or home HD, which is a bit out of keeping with what we would normally do because we normally start PD, but that's probably because of their access issues which they've developed over a period of time. And at last follow-up, most 30% of the patients were either on list for retransplantation or there were plans for retransplantation. About 70% were not. They were just getting medically better to try and get into that state. So in conclusion, chronic kidney disease is a continuum. I've heard that before, as in, I think we all know that. It's not just the immune suppression after transplant, it's the bone disease and cardiovascular disease that will actually be the most harmful. These children with failing grafts have additional needs and hence need access to multidisciplinary team, and we definitely need more research to understand the optimal management for these patients. At the end, thank you so much to all of you, but to everybody contributing centers, and I'd like to thank Farhad and Rukhsana. Thank you very much.
Great. So I have a comment and a question.
Yeah.
Comment would be when you present your blood pressure medication data, you amalgamated two different ways of looking at it, so into one graph. So you should separate one graph number of drugs and one graph the classes of drugs, because it'd be interesting to know in that really tall bar that has all of the kids with 2 or more drugs, how many of them are on channel blockers versus ARBs versus ACEs.
Can I just, so when the data is entered into the registry, they enter either A class or a combination, and that's how it appears in the registry.
Oh, so it's a failure of registry data. Yeah.
We can, it's very difficult, but that's the part that we will hopefully answer in the prospective part, because these are the kind of answers.
This is the problem with any kind of, and sort of Steve will talk about this tomorrow at the research part, but you never know the data you're going to need until you actually do the study. And so if you didn't design the registry right in the first place, then
it's difficult because you don't want too much data. You don't want to ask for too much data, and people then won't
there's
fill it out
always
as well.
a balance. So my question about the, Elaine and I were sort of going back and forth about the modality of dialysis. And so it might be interesting if you could suss it out as to either how many of the kids on hemo had a rapid loss of function and didn't have time to prepare for PD, or how many had previously been on PD and maybe didn't want to go back on it, or if you could figure that out.
Yeah, we can definitely have a try and look. Again, might be tricky in the retrospective part, but we'll try and suss it out in the perspective.
Any other questions from the audience?
Do you have a feel for how many of these patients are having fistulas formed as part of their long-term?
We didn't ask the question, but yeah, we didn't ask the question, and I don't know if the registry asked that as well. But that's a really good one for long-term access.
It wasn't such a long time ago that in some countries you didn't get access to transplantation until you actually required dialysis.
Mm-hmm.
And in some countries as well, there was the mode in some units that your first kidney should have been deceased donor because you wanted to keep the living donor for your retransplantation, whereas now we believe trying to do preemptive living donor transplantation is the way forward. But you can still do preemptive living donor retransplantation. So I guess the question is, are we doing enough for a transplant population in managing their chronic kidney disease? Should we be thinking about done the biopsy because of the creeping crab, you can then predict how long it's going to take until the EGFR drops into single figures. Should we be planning for the families to move forward with working up the living donor maybe sooner? It's not obviously one centre, so it's within Europe. Do you think that may be an issue that we're seeing?
I think it's important because we as transplant nephrologists also need to understand when the kidney is not going, it's irreversible damage done, because the sooner we realize, I mean, by me as we mean the whole MDT, the more easier it is for us that information and how to move forward. It's difficult to deal with the acidosis and all that part and get them medically fit if we are not getting to the point. I mean, we should be doing it as a continuum, like I said, but I think we need to be more proactive in trying to get these. And the patients we managed to get preemptively transplanted are the ones that we've actually spoken to a lot in advance about this is not working. We need to get the next steps going. So I think, yes, there is some way in that. And hopefully with more education, we can get there.
Most of the work we're doing about access to transplantation, research online, fellows who is doing a PhD who can come here today is about, is it open access to everybody? So looking at ethnicity, socioeconomic class, and I suspect it's the same when we look at the data will be for the retransplantation as well as for the first.
And one thing what we haven't tackled here, which is very difficult to understand, is adherence as well. There are some centers where I would say you will have to make sure that you're adherent before you get an access to second transplant, because there's more likelihood of failing the second transplant as well. And it's very difficult to understand or actually know when you're actually now adherent to then say you're okay for. So that's something didn't even get there, because that's a whole different.
Great. So we're at the end of the allotted time for the day, but there's one more talk. And so does development of de novo DSA accelerate progression of allograft failure? And Dr. Ali will talk to us on that one.
While we're trying to set up things, I just want to thank the team for the invitation. It's a pleasure to be here in front of big things in the pediatric nephrology ward, so thank you. And what we're So what I'm presenting today is yes, it's back. So it's the last talk, so I'm just going to try and be very concise and quick. So what I'm presenting today is one of our study and try to present the preliminary findings, and we're trying to answer the question of does development of de novo donor-specific antibody allograft failure in children. So just an overview of what we're going to go through today is we'll try to explore what do we know so far about the topic, about the donor-specific antibodies and graft failure. We'll try to explore evidence from the adult data and go through some of the pediatric literature. And then we'll present the study findings and results, and then questions if the time allows. So what do we know so far about it? We know for a fact that donor-specific antibodies have become an established biomarker in predicting antibody-mediated rejection. We also know that antibody-mediated rejection is a major cause of graft loss in kidney transplant, and we know it's really important to address the causes of kidney transplant, accelerated aging, and it's an important challenge, aiming for the outcome of improving long-term transplants. So regarding adult data, this is a data from France, published in 2017, where they have a large adult population of over 2,000 patients. They were enrolled. The main outcome that they've studied, and they've put it as the outcome for graft failure, is interstitial fibrosis and tubular atrophy. So they've studied patients who had, they've recorded DSAs positive patients, and they recorded as well biopsy-proven IFTA, which is interstitial fibrosis and tubular atrophy. What they found that circulating DSAs positive are major determinants of premature and accelerate allograft fibrosis, acting independently of any other risk factors in that group. There are another data from the US, which was published 2 years later, 2019, where they've enrolled 294 adult population, and they followed them across for 4 years. The aim of this study was to understand the timing of development of DSAs and the role of medications, immunosuppressant and adherents. What they found that the combination of T-cell mediated rejection plus DSA positive led to an almost threefold increase in graft loss compared to either DSA's presence by itself and T-cell mediated rejection by itself. They've also found that patients who develop both DSAs positive and T-cell mediated rejection proven in their biopsies have 75% of these patients have impending graft loss by 4 years follow-up. So we do have these big studies from the adult population. Why do we need more studies in pediatric population? So we know for the fact, the accumulation evidence in adult literature for the association between DSAs and poor renal allograft outcome. Pediatric data are limited. There are few published studies in this matter from the pediatric population, and they show different evidence. So some of them, they showed that there is no significant outcome from the presence of DSAs in the long follow-up. And one of the earliest published data from 2012 showed that there is a significant effect from the presence of DSAs in 10 years follow-up in pediatric population. Why is that? Possibly because of B-cell subpopulation in children mature in a different way, and it might matures more as the child grows and get older. This is one of the studies from the UK that was published in 2014. They followed up 215 patients between 2006 and 2012. They followed them with DSAs monitoring at 1 month, 3 months, 6 months, 1 year, and then yearly after their transplant. What they found that DSAs were not an independent risk factor unless patient developed microvascular injury proven in their biopsy. They've also found that the magnitude of effect of GFR is proportional to the MFI, which is the DSA intensity level, and mainly in class 2 DSAs. And they also found that in short term, the outcome of patients who DSAs resolved at some point after they developed the DSAs is more or less comparable to the patient who did not have DSAs at all. This is another study from the US where it was published in 2019. They have enrolled 103 patients, less than 18 years, and they followed them up between 2007 and 2013. They've done a DSA screening every 3 months for 2 years, and then additional DSAs monitoring if clinically indicated. So what they found that the screening detected de novo DSAs was not associated with decline in GFR or graft loss, and that tells the effect of the presence of DSAs in patients who have a stable kidney function. What they also found that de novo DSAs that were first detected on 4-cause testing was associated with 2.8 times increased risk of decline in the graft function. So coming to our study, these are preliminary results. So there is still work, ongoing work and data collection at the time being. But I'm just going to go through the results from what we got so far. So the aim of our study was to understand the development of allograft failure in children who developed de novo DSAs. what we've done that it's a retrospective observational review at a single tertiary hospital, following up patients in the last 10 years. We've included patients who had a transplanted kidney and they're less than 18 years, and we've extracted data from the electronic patient records. We have analyzed the demographics, donor and recipient characteristics, rejection episodes, DSA surveillance, progression of EGFR and immunosuppressant changes. We had a total of 117 patients. We've excluded around 25 patients just because one of the inclusion criteria in the study that we want them having minimum of 1 year follow-up. The mean age at transplant was 11.5 years with a median age of 6. The mean follow-up time was 4.3 years with a median follow-up time of 7 years. This is just to represent the underlying etiology for the population studied, and as we can see, the majority are CACUT, and that represent what we know as the most common causes of kidney diseases in pediatric patients. So this table, we try to understand the characteristic of both groups who developed DSAs positive and no DSAs during their follow-ups. We had 33 patients in the DSAs positive and 59 patients in the DSA negative. And interestingly, the only statistical significance were around the patient who did have living kidney donors, and preemptive transplant, and the majority or the higher number did not develop DSAs during their follow-up. And just to understand the DSA positive group, we've divided them into three groups in terms of biopsy findings. So the first group were patients who had proven rejection in their biopsy, and then the second group who did not have any rejection in their biopsy, and the third group who did not have biopsies during their follow-up. We found that there was no statistical significance between the three groups in terms of timing of first detection of DSAs, peak of MFIs, and the decline in their EGFR, and that was calculated as mean delta EGFR across the years of follow-up. So this is just to see the difference in the biopsy-proven rejection episodes in both groups, DSAs positive and DSAs negative, and that showed statistical significance difference between both groups in terms of biopsy rejection. Coming to the main outcome that we want to discuss in this study, which is the mean decline in the EGFR across the years. There was no statistical significant difference between the group of patients who developed DSAs during their follow-ups and the group of patients who did not develop DSAs. So that tells us that the long-term, as a long-term outcome, both groups have the same rate of decline in their EGFR, and that's represented in this graph. So the blue line is the group of DSAs positive, and the orange line was the DSA negative group. So both of them, they had similar rate of decline in their EGFR up to 8 years follow-up so far. So in conclusion, our interim analysis for our study showed that there is no difference in EGFR decline in children who do and do not develop DSAs after kidney transplant. We also found that episodes of biopsy-proven rejection are more frequent in patients with DSA positive, and we also can see from our study that MFI level and timing of detection did not show any effect on the rate of decline of EGFR during follow-up. This is all the data that we have so far, but there is lots of work ongoing. Any questions?
Great, thank you. Questions?
So, thanks for that. Steve, we did the same thing about 10 years ago, but it was in the IPNA. And that one, there was, I think, similar in terms of decline. It was a 5-year follow-up at that point. So rate of rejection was much higher on the DSA positive group. and the outcome was worse, but it didn't correlate with the level of donor-specific antibodies. I think my gut feeling is we end up with the same kind of conclusions again.
And don't you think there has to be a better marker? Because you showed our data from Seattle and it didn't work except in the people who we did it in for cause. So what do we need to look at next? What do you think is going to be a better predictor?
Yeah, I think it's just looking at the DSAs by itself and the MFI doesn't look like it's adding a lot, but definitely there is something else that we can look at. I'll leave that to Steve.
So I'll talk a little bit about this tomorrow because we followed it up with the second study, which looks at complement activation. So I think that's the issue is can you predict which patients are going to have rejection, and can you predict those that are going to lose the allograft? And one of the things that we found was the antibodies which are complement fixing. And we'll talk a little bit about the difference between C1q and C3d. So it's the next step. And what you have is some patients that have donor-specific antibodies with a stable MFI for years that do absolutely nothing. Some patients develop a fleeting donor-specific antibody. Some of them have persistent, but actually some patients can have donor-specific antibodies within a month. They fix your complement, and then you get the bad rejection. You can't treat, and you lose the allograft. But as Professor Flynn says, it's the prediction of those patients. Some people are using other markers like donor-derived cell-free DNA, but again, that doesn't answer the full question. I think we need a better biomarker to predict in the future.
Yeah, that cell-free DNA test is most of the time indeterminate and not helpful.
Thank you.
Great, thank you. And I guess I will have the closing remarks from our host.
Thanks very much. Yes, thank you very much all for your attention. It's been a long day. I hope that you found it useful. We will regroup here tomorrow at 8:30. There will be breakfast, coffee, teas, and all of that. So those who are joining us for the second day, there will be breakfast. I would just want to say two things. One is please do not forget to fill in your feedback form. The reason why it's still on the paper form is it needs to be sent to the Royal College of Pediatrics and Child Health because of the accreditation, and we do reflect on the feedback and incorporate that